endocrine surgery case presentation, clinico-pathological correlation, under moderatorship of Professor Anjali Mishra ma'am, Professor Narendra Krishnani sir,
Thank you.
I just wanted to say that the nuclear features of inclusion. All the three features are in, it is almost all the three features are not being right. So we can avoid the user. So it depends on the objective. Usually what we do is minimum speed.
Over to you, Pratisha, and she would be taking a different subject of this and she can
Good morning all. I'll be presenting next case. This is of a 39-year-old female presented with anterior neck swelling, and she has no other complaints, and her general examination was within normal limits. And on examination, there is a well-defined vertically oval-shaped lesion measuring 5 centimeters in its largest dimension with no cervical lymphadenopathy. And her TSH was in normal range, and her ultrasound neck revealed a 3 centimeter heteroechoic lobulated solid nodule replacing entire lobe with multiple macro calcifications within, and it was reported as Thyroid 4 lesion. So we went ahead and did an ultrasound guided FNAC, and my colleague Dr. Rishabh from pathology will be discussing the same.
Good morning to all. I'll be discussing the pathology part. So USG guided FNAC was done from the left thyroid nodule, and it showed cellular smears which were composed of thyroid epithelial cells which were arranged in predominantly microfollicular pattern. These are the other images which display a beautiful microfollicular pattern where small follicles repetitively are seen, comprising of 5 to 6 thyroid follicular epithelial cells. This is the Papanicolaou strain slide showing the similar morphology. On higher power, we can appreciate that the cells are largely monomorphic, round to oval with fine nuclear chromatin. Here we can appreciate the nuclear chromatin, and background shows predominantly hemorrhage, very scant colored was seen. So it was reported as a follicular neoplasm, Bethesda category 4.
Diagnosis of left ST and follicular neoplasm was made, and patient was given options of both hemithyroidectomy and total thyroidectomy. Patient consented for left hemithyroidectomy, so when we went ahead and performed left hemithyroidectomy, and all the vital structures are preserved, and gross findings, specimen XY weight was 28 grams, and it was measuring 5 centimeters in its largest dimension. And on cut section, there was a single well circumscribed pale fleshy nodule, solid tumor present. And this histopathology will be for discussion now.
So we received left hemithyroidectomy specimen. It was weighing 28 grams. Left lobe measures 4.5 into 3 into 3 centimeters. On cut surface, we can see a single fleshy gray white nodule measuring 4.5 into 3 into 3 centimeters, which was replacing the entire thyroid parenchyma. On histopathology, we can see a tumor was seen which shows interspersed broad fibrous septae. The tumor was comprising of mainly thyroid follicular cells which were arranged in microfollicular pattern, which was arranged back to back. Foci of capsule, multiple foci of capsule invasion were also noted. Here we can see the capsule which was infiltrated by the tumor cells. We can see the tumor on both sides of the capsule. Similarly, here we can appreciate the capsule is infiltrated by the tumor cells. Multiple foci of vascular invasion were also noted. Here a vessel which is lined by endothelial cells is showing a tumor embolus, and it is also areas of RBCs were also seen. Similar multiple foci of vascular invasion were noted. This is another focus showing vascular invasion where we can appreciate the vessel lined by endothelial cells and comprising and shows tumor embolus. This is another foci of vascular invasion. So multiple foci of vascular invasions were seen. So it was reported as widely invasive follicular thyroid carcinoma. Since it was 4.5 centimeter in maximum diameter and limited to the thyroid, pathological stage of PT3A was given. Capsular and vascular invasion were present, but stomach was free of tumor. Current WHO 2022 has classified follicular derived neoplasms into benign neoplasms, low risk neoplasms, and malignant thyroid neoplasms. Follicular thyroid carcinoma has been kept in the malignant neoplasm, and it is further subdivided into minimally invasive, encapsulated angio-invasive, and widely invasive, which was also there in the previous 2017 WHO classification. So basis of dividing all this into minimally invasive thyroid follicular carcinoma where only capsular invasion is present, encapsulated angio-invasive follicular thyroid carcinoma where only vascular invasion is present and foci of capsular invasion may or may not be present, and widely invasive follicular thyroid carcinoma where multiple foci of capsular invasions are seen. 40-month disease-free survival rate has been cited the basis of dividing into these three categories as minimally invasive follicular thyroid carcinoma where only foci of capsular invasion are seen, 97% survival rates are seen, while angio-invasive follicular thyroid carcinoma comes up with 81% survival rate, while widely invasive follicular thyroid carcinoma has the poorer prognosis with only 45% patients having 40-month disease-free survival. Extent of vascular invasion, only if less than 4 vessels are involved, we tell it as limited vascular invasion. If more than 4 vessels are involved, we say it is extensively vascular invasion. Again, multiple studies have varied literature, but most of the studies tell that if any vascular invasion is present, the patient will be having poorer prognosis.
So for the management, we went ahead and performed completion total thyroidectomy, and later patient was started on thyroxine supplementation suppression dose, and whole body radioiodine scan was done, which showed minimal uptake in thyroid bed. So ablative dose of 50 millicurie of iodine 131 was given, and her thyroglobulin levels were in normal range, and she is scheduled for her next scan in November 2023. So my second case is a 37-year-old lady with anterior neck swelling since 1 month, and on examination there is an solitary thyroid nodule on the right side measuring 4 centimeter, and her TSH value is in normal range. Ultrasound neck revealed a thyroid 5 lesion measuring 1.8 centimeter, and we subjected her for ultrasound guided FNAC. That will be up for discussion now.
So FNAC was done from the right lobe of thyroid. Here we can see the smears were cellular. Smears were comprising of macrofollicles, microfollicles, as well as few clusters. This is again another image showing microfollicles, macrofollicles, and few of the clusters. On higher power view, we can appreciate that these few of the clusters were showing nuclear overlapping at places. However, nuclear grooving were not seen. Occasional nuclear pseudo inclusions were also seen. So, since architectural and cytological atypia both were present, we reported it as follicular lesion of undetermined significance, but is the category 3.
She was diagnosed as right solitary thyroid nodule plus, and options of hemithyroidectomy, repeat FNAC, hemithyroidectomy, and total thyroidectomy were given, and patient consented for right hemithyroidectomy. So we performed right hemithyroidectomy, all the vital structures are preserved, and her gross findings, ex vivo weight was 28 grams, and largest dimension was 5 centimeter, and on 5 centimeter of the lobe, right lobe, and on cut section there is a 2 into 2 centimeter well-defined, well-encapsulated single fleshy nodule in the lower pole. That histopathology is for discussion.
So for this case, we see right hemithyroidectomy specimen, right lobe measure 4 into 3 into 2 centimeters. Cut surface showed a single gray white nodule in the lower pole measuring 1.5 into 1.2 into 0.8 centimeters. On HE stain section, we can appreciate it was comprising of a tumor which are arranged in follicular pattern. This is a higher power view which showing all the nuclei are showing fine nuclear chromatin. However, few of the nuclei were showing optically clear nuclear. However, nuclear pseudo inclusions and grooving were not appreciated. Only one foci of capsular invasion were noted where this thin fibrous capsule is infiltrated by the tumor. Multiple foci of vascular invasion were noted. We can appreciate here the vessel which is showing tumor emboli. Left lobe, when completion thyroidectomy specimen was done, left lobe was largely unremarkable. So it was diagnosed as encapsulated angio-invasive follicular thyroid carcinoma with foci of capsular invasion. Extensive angio-invasion was seen, and pathological stage was PT1B. Left completion thyroidectomy specimen was largely unremarkable.
Patient was then on thyroxine suppressive doses, And whole body scan was done, which showed minimal uptake in thyroid bed, and ablative dose of 50 millicurie of iodine 131 was given. Her thyroglobulin levels were in the normal range, and she's scheduled for her next scan in December 2023.
I think both Bishop and Patricia presented the next subset of the question. And as I said, due to constraint of time, one quick question, and that should be only directed to pathologists. We would not be dealing with management controversy. Yeah, this issue.
Case it was a follicular neoplasm. In second case it was FLUS grade 3, category 3. So a very practical question: do you think frozen system would have made a difference in the management?
Very difficult to comment, but frozen section, we will only say that this is follicular neoplasm. Difficult to explain, difficult to see the angio invasion on frozen section. So as far as management is concerned, I doubt that it is going to happen.
As a rule, whenever I do any therapy, I submit it for frozen section biopsy. Many times, follicular neoplasm are not always follicular carcinoma. Sometimes they turn out to be papillary carcinoma also.
That's the difficulty if we say papillary carcinoma. As far as capsular invasion is concerned, it's not going to happen much. So we don't even encourage for the frozen invasion.
Sometimes in frozen we can see badly multiple vessels as well. Then you can go ahead with full completion therapy. Otherwise, it is very difficult because vaccine limited time, 1 or 2 sections, it is very difficult to comment on the individual. And for nuclear feature, often here nuclear feature frozen system are usually not appreciated. That's also
Within the widely invasive, you can easily appreciate on the crowd.
No, actually, it all depends. What is your question? Whether you are trying to differentiate a particular derived tumor from papillary, then you can do a frozen section. If you are just trying to see whether it is a particular adenoma or a carcinoma, there is no problem. Then it boils down to probability. On the basis of affinity findings. So over to Arjun.
Now we'll be discussing about high-grade thyroid carcinoma. He was a 69-year-old male presented to us with swelling in front of neck since 40 years, associated with rapid increase in size and hoarseness of voice and dysphagia for solid and liquids since 8 months. There was no history of toxicity or hypothyroidism. He was bronchial asthmatic since 20 years and hypertensive since 3 years. On general examination was all findings within normal limits, and he was having a right thyroid lobe enlarged, measuring largest dimension 10 centimeter, which was hard and associated with the restricted mobility, and lower border was not palpable, with no deep cervical lymphadenopathy. He was euthyroid with serum TSH levels of 3.08, and ultrasound neck showed a nodule of 7.5 centimeter in the right lobe, which was graded as Tyrad's 4, with which was heteroechoic with the coarse calcification and increased internal vascularity. And the left lobe also was showing a hyperechoic lesion with size 10 millimeter with Tyrad's 3 stage. Bismuth was normal. FNA, he came with an FNA done elsewhere. It was follicular neoplasm, and his ideal was showing right vocal cord palsy. And in view of this hoarseness of voice and retrosternal extension, we did a CT, and it was showing an enlarged right lobe with largest dimension of 62 millimeter, with retrosternal extension of 1 centimeter, and along with an ill-defined heterogeneous nodule of largest dimension 43 millimeter inside the lobe, with macro calcification. And we done an ultrasound guided FNA. I'm inviting Dr. Gauri to discuss.
This case, FNA was performed from right thyroid swelling. The smear is mildly cellular and shows the follicular epithelial cells lying on a hemorrhagic background. On further high power view, these follicular epithelial cells disposed in repetitive microfollicle as well as the dispersed follicular epithelial cells. These follicular epithelial cells are isomorphic round to oval nuclei with fine chromatin, inconspicuous nucleoli, and moderate amount of cytoplasm. So based on this finding and low cellularity, this case reported as follicular lesion of undetermined significance, that is the category 3.
From these cytology findings, we made a diagnosis of euthyroid MNG plus with right RLN palsy in view of his advanced age and high suspicion of malignancy in view of hoarseness. We planned for total thyroidectomy and further management as per operative findings and histology report. Total thyroidectomy with end block removal of the thrombus in right superior and inferior thyroid veins, and part of strap muscle was excised. This is the thrombus showing, and the lobe was enlarged and stony hard with multiple parasitic vessels and infiltration into overlying strap muscles, and the extension of tumor thrombus was seen in right superior and inferior thyroid veins with no enlarged lymph nodes. And this is a picture showing tumor thrombus in the right inferior thyroid vein, and the tumor nodule was present in between the two branches of right RLN, which leading to overstretching of the lateral branch. So we, after once the tumor was resected and the tension was released. Grossing was showing 105 gram with multiple nodules. The histology open for this.
Received total thyroidectomy specimen, weight is around 160 gram, and cut surface of right lobe shows the multiple grayish white nodules which range from 0.5 to 2 centimeter, with central large nodule measure 4 centimeter in diameter with areas of calcification and hemorrhage. And the cut surface of left lobe was, shows the unremarkable thyroid parenchyma. And this is a section shows the tumor infiltrant, tumor disposed in sheet as well as closely packed microfollicle. In this section, we can see the capsule. We see the capsular invasion. This is the capsule, and there is the breach in the capsule. At a few places, tumor disposed in papillary fronts, and these papillary fronts lined by the atypical cells. And and few sections, these atypical cells are disposed in closely packed follicles. These are the closely packed follicles, and here is the sheet of the tumor cells. On a further high power view, these tumor cells are round to oval in shape with some at places there is the nuclear overlapping was identified, and chromatin clearing are also noted, and few of them shows the nuclear groove. This is the nuclear groove, and frequent mitotic figure was also noted. It is around 8 to 10 per 10 high power field. And in this, there is a vascular, this image shows the vascular invasion. This is the tumor foci within the vessels, and these vessels are lined by the endothelial cells. This section is from the left lobe and isthmus, shows the variable size colloid filled follicles. These follicles are lined by the cuboidal epithelial cells. So based on these findings, right thyroid lobe reported as a differentiated high-grade thyroid carcinoma, and left lobe and isthmus was unremarkable. This is the new entity added in 2002 WHO classification, come under the follicular cell-derived neoplasm in malignant neoplasm, and it further categorized into the follicular-derived carcinoma high-grade. In this, two entities is added: differentiated high-grade thyroid carcinoma and poorly differentiated thyroid carcinoma. So this is the differentiating table, differentiate between the poorly differentiated thyroid carcinoma and differentiated high-grade thyroid carcinoma. In case of high-grade thyroid carcinoma, growth pattern may be papillary, follicular, solid, And in this poorly differentiated solid trabecular or insular-like growth pattern is seen. PTC-like features are seen in case of differentiated high-grade thyroid carcinoma. Other features like tumor necrosis, mitosis, and convoluted nuclei. Out of these three features, one should be present in case of poorly differentiated thyroid carcinoma. Mitotic count more than equal to 3 per 2 mm square. This 2 mm square is equivalent to 10 high power fields. And tumor necrosis and convoluted nuclei. And in differentiated high-grade carcinoma, out of two criteria, one should be there: mitotic count more than equal to 5 per 2 mm square, and tumor necrosis. And anaplastic features were absent in both cases. So in our case, there is a growth pattern, papillary, follicular, and solid, all three types of growth patterns seen, with papillary-like nuclear feature like overlapping nuclear grooving and chromatin clearing is seen, and mitotic figure is around 8 to 10 per 2 mm square, and there is absent anaplastic feature. So this case reported as differentiated high-grade thyroid carcinoma.
Postoperative course was he was kept in elective ventilation in view of bronchospasm for 2 days, and next whole body radiation scan is planned on 29th of this month. In view of the diagnosis, this high-grade differentiated carcinoma is considered as invasive high-grade follicular cell-derived carcinomas and are considered still differentiated. They now constitute to 1 to 6.7% of all thyroid cancer, and the prevalence is more seen in Europe and South America than less in North America and Japan. They present mostly the patients will be more than 50 years, and the females slightly predominant presentation than males. They are mostly rapidly growing tumors with or without extrathyroid extension, and around 30 to 50% will be having lymph node metastasis. 50% of these tumors are not likely to be radioiodine avid, so further mutation molecular based systemic therapies will be needed for these patients. And disease-specific survival, 10-year overall survival is 56% when compared to the poorly differentiated thyroid cancer, and currently it is considered as having lesser prognosis than poorly differentiated thyroid cancer. And
initially what we had was just two groups of tumors, that is, you have follicular derived and the papillary side carcinomas, and one entity was a poorly differentiated thyroid carcinoma. Now with the studies that were held, it was realized that there is a group of tumors which do not show a typical poorly differentiated, is the one which had solid type of a pattern or the insular type of pattern. They realized that there are other features which are also important, like the mitotic figures and the tumor necrosis. So now, if you have, initially we were not grading the tumors according to mitosis and the presence of necrosis. Now, with whatever evidence we have, these tumors which have a differentiated type of morphology behave poorer with when they have necrosis and mitosis as compared to the other tumors which do not have a high qualitative index of mitosis or necrosis. And the ones which were initially said as poorly differentiated now go into that group of which have a typical solid pattern, which go into this group of poorly differentiated follicular lines. So this is what has been the case in these two. Earlier they were all grouped into the poorly differentiated.
This this stratification and radioiodine that may have radioiodine cases. So that has been subcategorized poorly differentiated carcinoma.
As Dr. Manoj said, these are poorly differentiated ones are generally radioiodine refractory. So that is why it is important to one quick question.
How can we differentiate them with a follicular versus papillary cancer? Because both will have follicular as well as papillary cancer. This high-grade cancer versus follicular variant of cancer.
So if you look at the criteria, what Dr. Gauri has just pointed out, follicular variant of PTC versus your these hybrid cancers, you have to look for the number of mitosis and tumors. If you find tumor necrosis and mitosis which is more than 5 per 10 hypothesis of what you would have to label it as hybrid. So these could be differentiated hybrid follicular carcinoma. Follicular variant of PTC, if you are trying to label it, it will not have tumor necrosis and hybrid.
Molecular variant, but that ERA mutation has to be seen in these cases, where you want to categorize for the base carcinoma.
And more important point for clinician is that we have to be not out for tumors, they are likely to be more aggressive than PGES. So that is a new entity. We were always wondering initially we find some tumors which were not fitting to any category. Probably this is the way forward. Thank you, I think. Thank you, Gauri. So much.
Thank you, ma'am. Our case is that of a 39-year-old male who was evaluated elsewhere in 2019 and was lost to follow-up. I would be telling the details of that later. He presented to us with complaints of fever associated with chills and rigors, weight loss and generalized weakness, along with on and off history of headache and pain in the right upper abdomen. However, there was no history of hypertension, palpitations, or excessive sweating. He underwent excision biopsy of right cervical lymph node in 2019, the histology of which was consistent with metastatic MTC. His plasma metanephrine and normetanephrine done outside were elevated, and FDG PET also showed lesions in bilateral adrenal gland and a lesion in thyroid gland. When he presented to us, his general examination was found to be normal. He was normotensive with no neurocutaneous markers. On examination, there was a scar of the previous excision biopsy that was noted on the right side of the neck, and there was a right SCN which measured 1 centimeter in largest dimensions. There were also 2 discrete lymph nodes, 1 into 1 centimeter in the right level 3. His abdominal examination was unremarkable. So we went ahead with biochemical and hormonal evaluation of the patient. He was euthyroid with serum calcitonin 875, and urinary metanephrines were raised more than 3 times. We also screened the patient for hyperparathyroidism, and he was found to be eucalcemic. On ultrasound, a 16 into 11 mm hypoechoic solid irregularly marginated lesion with coarse internal calcification was noted, giving a score of TIRADS 5. Left lobe also had a similar lesion measuring 16 mm in largest dimensions, and multiple cervical lymph nodes were noted in right level 3 and 4. We also did a CT scan and the CT of the thorax to evaluate the patient to see for the extent of the disease and rule out any pulmonary metastasis. We then went ahead with a gallium dotonox PET scan, which showed tracer-avid hypodense nodules in both the thyroid lobes and tracer-avid enhancing bilateral level 3 and supraclavicular lymph nodes on the right side. A triple phase CECT adrenal protocol showed bilateral enhancing solid cystic mass lesions in bilateral suprarenal lesion, right being larger than the left, and the measurement of the right side was 13 centimeters. Because of the clinical presentation of the patient, a diagnosis of MEN2A syndrome was made, and we subjected the patient to RET mutation testing, which was positive for 634 codon. Therefore, the plan was to go ahead with bilateral open adrenalectomy in view of large adrenal mass, followed by a medullary thyroid carcinoma surgery, which was total thyroidectomy, central compartment lymph node dissection, and bilateral MRND. This is the intraoperative pictures of the right pheochromocytoma and the left pheochromocytoma, along with the glossing image. We then went ahead with total thyroidectomy and central compartment lymph node dissection with bilateral MRND. I would request Dr. Radha to please come forward and discuss the FNAC and histopathology of this patient.
Thank you, Dr. Sara. So for this patient, we first performed an ultrasound-guided FNA from the thyroid gland as well as the cervical lymph nodes. So the FNA smears from the thyroid gland were cellular smears, which showed chiefly dispersed population of tumor cells. This is the May-Grunwald Jimsa stain and the Pepinicola stain of the smears. So the tumor cells were medium to large in size with eccentrically placed nuclei, stippled chromatin, and abundant amount of granular cytoplasm. The background was hemorrhagic. The smears from the lymph node also showed similar cells against a background of lymphoid cells. So the diagnosis on cytology was given as medullary thyroid carcinoma with cervical lymph node metastasis, Bethesda category 6. Subsequently, we received the total thyroidectomy specimen with bilateral central compartment lymph node dissection and bilateral selective lymph node dissection specimen. On a gross examination, the right lobe of the thyroid measured 4.5 by 2.2 by 1.6 centimeter, and the cut surface of the right lobe showed a nodule that measured 1.2 by 1.2 centimeter. And the left lobe measured 3.7 by 2 by 1.5 centimeter, and the cut surface of the left lobe also showed a nodule measuring 1.6 by 1.4 centimeter. The isthmus measured 1.5 by 1 by 0.5 centimeter, and the cut surface on gross was unremarkable. So on microscopy, the histopathological sections from both the right and left lobes of the thyroid showed a tumor with similar morphology, which was largely disposed as sheaths and nests, with large areas of this eosinophilic amorphous deposition within the tumor. The tumor cells were medium to large in size, with central to eccentrically placed nuclei, stipple chromatin, and abundant amount of granular cytoplasm. And on Congo red stain, when examined under polarized light, we found apple green birefringence displayed in this amorphous deposition, which confirmed it to be amyloid deposition. We also found areas of C-cell hyperplasia within the tumor, which was confirmed by immunohistochemistry with calcitonin. So C-cell hyperplasia is defined as more than 6 to 8 C cells per cluster in clusters with more than 50 C cells when examined under LOPAR. The lymph nodes that were sent for examination showed metastasis in the bilateral central compartment lymph nodes, as well as the right selective lymph node dissection specimen. So the final diagnosis on histopathology for the total thyroidectomy specimen was multifocal medullary thyroid carcinoma involving both the right as well as the left lobes with C-cell hyperplasia. Isthmus did not show any evidence of malignancy, and there was a lymph node metastasis involving the bilateral central compartment lymph nodes as well as the right selective lymph node dissection. Over to Dr. Sarah.
The postoperative period of the patient was uneventful, and his repeat metanephrines also were found to be normal. Because he had RET mutation positive, we screened both his live children for the same, and both of the children had a 634 codon mutation in the RET gene. His daughter, who was 7 years old, her examination was unremarkable, and so was her ultrasound thyroid. However, her serum calcitonin was found to be elevated, 46.6. His son was 5-year-old with his evaluation of thyroid being normal, and calcitonin was also in the normal range. So we went ahead and did prophylactic total thyroidectomy for both his children, and the histopathology is now up for discussion.
So we first received the total thyroidectomy specimen for the older child. This was the specimen grossly showed the right lobe of the thyroid to be measuring 3 by 1.8 by 0.5 centimeter. The left lobe measured 2.5 by 1.8 by 0.3 centimeter, and the isthmus measured 1 by 0.5 by 0.2 centimeters. The outer surfaces of both the lobes as well as the isthmus were capsulated and did not show any gross abnormality. The cut surfaces of both the lobes as well as the isthmus grossly appeared unremarkable. There was no definite nodule identified on gross examination. There were no lymph nodes identified. On microscopy, the sections from the right lobe of the thyroid showed a tumor which was disposed as clusters and small groups of tumor cells, which showed these medium to large cells with central to eccentrically placed nuclei, stipple chromatin, and abundant amount of granular cytoplasm. The rest of the thyroid parenchyma showed benign colloid-filled follicles. The sections from the left lobe showed benign colloid-filled follicles. There was no evidence of malignancy, and the isthmus also showed no evidence of malignancy. So on total thyroidectomy specimen, it was reported as medullary thyroid carcinoma in the right lobe. Left lobe and isthmus were free of malignancy. Subsequently, the younger siblings' total thyroidectomy specimen was also received. The right lobe of this specimen measured 3 by 2 by 1 centimeter. The left lobe measured 3 by 2 by 0.5 centimeter, and the isthmus measured 1 by 0.5 by 0.2 centimeter. The outer surfaces of both the lobes as well as the isthmus were grossly unremarkable. The cut surfaces of the isthmus as well as both the right and left lobe showed unremarkable thyroid parenchyma. Microscopy also showed unremarkable thyroid parenchyma in all of the sections. There was no evidence of malignancy or C-cell hyperplasia when examined under microscopy. So the final diagnosis of the right lobe, left lobe, and isthmus for this case was given as no evidence of malignancy.
The ATA has stratified as per the mutation for M2, the timing for prophylactic thyroidectomy. And because our patients belonged, the children of our patients belonged to the high risk category because they had 634 mutation, doing a prophylactic thyroidectomy at or before the age of 5 years, according to the calcitonin levels, was imperative. And that is what we have tried to show in this case. The younger sibling did not have hypercalcitonemia and his thyroid gland was unremarkable. The older sibling did have, was 7 years old and did have a 1 centimeter MTC. We thank you for your patience.
Older sibling, roughly there was no tumor. So where are the millimeters? Simply as so this and that's what it is. So these question marks show lymph node. If it is less than 0.5, going to increase more than 1 centimeter, chances of lymph node metastasis are more. So that is why it is to be measured and informed. Further management for the lymph node metastasis. So that is the importance of it.
Essential messages operate the test for stratification before the tumor becomes metastasis or lymph node metastasis are there. Because once lymph nodes are there, usually we can't cure. But if it remains within thyroid, then this is one of the greatest examples of bedside practice where we will prevent malignancy before. Probability of developing FPT mutation is up to 98%. So, and after thyroidectomy, we can put the patient or child on replacement. So that is one of the greatest primary prevention of malignancy.
One more comment. For the third, where there was no evidence of malignancy, we could have also done this calcitonin as well as PGES. These are habits. We are saying definitely there is no evidence, but we do. Sometimes hyperplasia we can miss on like that.
Just the point, whatever why we do take the gross from the total thyroid. It is important to see that you take the gross also from the upper part of the thyroid because that is the place where you find the super thyroid. Actually, this thing, when we used to be resident and mutation testing was not available at frequency. So when this thing, the quality report was showing multiple hyperplasia, then those were the cases where we were screening them for other components of MA2. Because as we know that in MA, the earliest manifested component is medullary thyroid testing. Only 10% patients with pheochromocytoma could receive. And we told in our setting, as we get advanced cases, many a time majority of our patients would be having both, as was evident in this case. So if there are no other questions, I think we. WHO classification of management. Like one of the cases that are I think it was either thyroid carcinoma as well as I supported on that. In order to know the difference, whether it's you need to do the observation. Now that you are adopted to WHO classification, molecular testing for presently, no, we are not doing NTS. We are doing the immunohistochemistry, which is the survey marker. So we are doing ERA 100E by immunohistochemistry on an FDA approved platform. We have not yet started doing the patient analysis. Usually, we are this question, and if you say that we are found that the personal patient now that we have started doing this, I think one of the reasons now if you look at the newer classification, basically the biological behavior is on the molecular structure. You have the DRAS or the RAS pathway being activated. Classification has also evolved to categorize into different. I completely agree with your point of view. Maybe the new future is something.
We are soon going to start IS and just complete better.
I think now we can close down this session and I think and trying to ready. And thank you so much.
Thank you all for such an elaborate discussion on the entire spectrum of thyroid pathology. And I request all the delegates to make their way upstairs to the SK Naik auditorium for the live surgical workshop. Thank you.
नहीं इधर पे ही रहेगा ऊपर से लेकर उसको कॉपी कर लेते हैं उसको
हो गया है
Hmm. So, as the simple Baba endoscopic technique, we put the position after general anesthesia, put the position to the supine position, and then infiltrate the adrenal saline solution. And given the incision, 4 ports we are marked. 4 incisions, same as the endoscopic. We are creating a subperitoneal stage. So, the important difference in this robotic versus endoscopic that you have to mark the 8 mm port side on the all 4 port side. So, in endoscopic, we mark the 10 mm or 12 mm into the perioral and 10 mm on the one side and another side the 5 mm. But here we mark all 4 ports with 8 mm. So after putting this 8 mm 2 ports into the axilla, then we start dissecting by endoscopic to raising the flap. So same as using the hook. Speed is very high. We have to raise the flap. Then after raising the flap, we put all 4 ports and dock the rotor. So in the robotic, I used to take Maryland bipolar on one hand and hook monopolar on the other hand. So 3 arms we use, one for the camera, one for this hook, and one for bilateral. So after raising the flap, we have to open the midline. We start from external notch up to the height mount. And once the open the midline, we start dissecting from one side. And start from the inferior pole. So try to identify the nerve. And once the nerve is identified, so you have to be careful to dissect it out. So some surgeons prefer the seizure in spite of this hook. So their explanation is that the lateral thermal spread is less in the seizure. But what I feel that if you use hook, so there is chance holding and dissection is easier for the beginners. So if you use hook, but you have to be very careful because although this is not very sharp, but definitely the thermal injury, chances of thermal injury is there. So it start dissecting from the opposite side. So first we have to identify the nerve. And here we strip the instruments. So scraping of the instrument, like bipolar was initially on the right side, you have seen. Now the hook is on my left hand and right hand is the bipolar. So in robotic surgery, we have to change the instruments. Once we operate on the left side, the setting is different than the operating on the right side. So identification of the nerve and parathyroid is easier. Near to the parathyroid. So what the surgeons who are using seizure, they are saying that it is less damage to the nerve and parathyroid. So we have to be careful with using of this hook during the dissection near these vital structures. So once the specimen is taken out, we put some hemostatic agent. Same as in endoscopic, we are using, and then approximating the midline. So you can use the robotic needle holder, but that had another cost. So by the same instruments we are using for the suturing. Although suturing is easier in robotic, but if you use the needle holder, that will be more easier. So this is the completion of surgery and then for the dressing. And this is the target statement. Thank you very much for it.
PGES रहते हैं हम कहाँ भागे
इसलिए नहीं सकते हमको पता रहेगा कि हमने
May I please request Dr. Tanavai Sundaram to kindly present his next video exhibit, which is on robotic eye dressing.
Respected senior faculty members, colleagues, and dear friends, it is indeed an honor to be presenting my work in this August gathering. I thank the organizers for giving me this opportunity. At the utmost, I would like to thank my institution, Tamil Nadu Government Corporate Specialty Hospital, for giving me this unique opportunity. So now I'll be presenting about rabbit. I think Professor Gyanshan has almost covered everything. Rabbit for the technique is nothing but robotic assisted with as low insufflation technique. It is a modification of Baba. I will show you what is the difference. The flat marking is already shown. It's almost similar to Baba. You see the flat markings here. Video.
आपको पुनः थोड़े से
No, it's not working. Video is not working. May I invite Dr. Siddharthi from Apollo, Hyderabad, for presentation on endoscopic radar.
Morning, everyone. Thank the organizers for this opportunity. Today I'll be presenting on transoral endoscopic thyroidectomy. So patient has a solitary thyroid nodule. Positioning is like a standard thyroidectomy, like the road position, you put this. And the extra thing that we have to do for this is we have to support the neck, putting this cloth plaster and also supporting the nasal bridge is important. Otherwise, you sometimes after the surgery you realize there is a trauma there. So this is important in the positioning of the anesthetist tube because you will be standing on the head. So this positioning is quite. So to create the space, we use saline with adrenaline. So the first port is fixed to the frenulum, and earlier they used to. Initially, when we went, the port was more and more close to the teeth. Later, it is becoming more and more superficial. First is the 10 mm camera probe, where we do the blunt dissection. So in this part, you have a difficulty near the chin, where it is tightly fixed. So you have to be careful there. Then we use a very needle to do the hydro dissection. The flat dissection is the extent of the flat dissection is like in standard thyroidectomy on both sides of the sternocleidomastoid, and we use this blunt trocar to create the space. So these are the three ports. This is actually my old video. As you can see, the port is more close. It is away from the canine, but it is close to the teeth. But now it has moved. Even Dr. Anuvang is saying that you have to go more and more close to the lip line. So the ports, now we are putting it here. So these are the three ports. So once you put the ports, then it is creating the space. These are the strap muscles that you can see. And we use the ligature. We can be comfortable ligature device. And this is the straight ligature. But later, I think using the curved one more. So these are the two strap muscles, and you can see this is the sternomastoid on the other side and the sternomastoid on the other side. So just raising the strap, raising the flap is like a standard thyroidectomy. And then we open the midline. After that, the trachea. The next step is to do a hysterectomy. And important thing, what I realized once I go to the private practice is, when you are in an institute, you have a very good cameraman who will drive you where exactly you want to go. But outside, that's a problem. Getting a good cameraman sometimes is a challenge. we are cutting the instrument. And then we have to mobilize the lobe. This is the upper pole. The transfer is like a standard thyroidectomy. Only thing is you are looking from the top down. Okay. As I was mentioning about this yesterday, also we saw the robotic surgeon was mentioning this curved tip, like a bird beak it is, and it is very useful for coagulating the upper pole. And then we have to meticulously identify the parathyroid glands. This is the posterior branch which we leave to identify the parathyroid. So that's the parathyroid. So once you identify the parathyroid, again you have to stay close to the thyroid gland. Yeah, one thing what I realized is if it's a benign, which we usually do for transoral, I generally select a clear-cut benign case. So never hesitate leaving behind maybe 1 or 2 millimeters of thyroid tissue on the parathyroid. And this stitch is very important. So to retract the staph muscles, unless you put this stitch, you can't see the nerve. Dissection of the nerve becomes a challenge. So yeah, that's the recurrent laryngeal nerve, and that's the trachea, and that's the lobe there on the top. To do that, it's very simple. You take out the gland and put it in the back, and then easy. You can deliver it up to 3 centimeters of the nodule can easily come out through the 10 mm port. You just have to change to a 5 mm on the other side. But for the youngsters who are starting, select a very nice small 2 to 3 centimeter benign nodule. Then we close the staph muscle. This is at the end of the procedure, the 3 ports. Like I said, the ports now, this is the old one. And now we do the incision somewhere here. So they say it causes the chance of mental nerve palsy is less if you go more close to the lip line. And this is the image just before extubation. You can see there isn't any much erythema or redness. And we apply this pressure testing for 48 hours, and after 48 hours, once we take out, it looks very clean. The only this is the needle which we put to retract the staph muscles. The other patient, 1 week after the surgery. Yeah, this lady had a category 3 on a pineal aspiration cytology, and we did a total thyroidectomy, multinodular goiter, and we did total. The patient had transient hypoparathyroidism, which is recovered in 6 weeks. Final biopsy came as papillary thyroid carcinoma around 2 centimeters, but almost 1 year, his thyroglobulin, everything which is in the cured range. So after 7 months, can't see any like a true scarless procedure, no hidden scar. Thank you.
I will invite Professor Jansen sir to please come on the dais and present the video snippet on robotic transport directions.
Thank you very much again. And because I have to rush to the OT, so I have to get early before by Sundaram. So I take the permission from Dr. Sundaram to present before him. So this is one young female presented to us with a solitary thyroid nodule around 3 centimeters. So in robotic thyroid surgery, position is same as Dr. Siddharth has stated already, the position and infiltration of the saline solution. So similarly, but the test is that you have to infiltrate lots of saline solution, so it will act as a shock absorber or buffer to do not injure to the surrounding structures. And the nerve is also went away, so there is no post-operative nerve injury. And you see the incision, as Dr. Siddharth told, that incision is always close to the lip line, so there is no tear of that, because in robotic there is a lot of movement is there. So the putting the port is the similar. You have to create the space, and once you create the space, especially the below the chin, you have to be careful. And once you create the space, then you have to take again the very needle and put in. So usually we do not put it in the central, because the central there is chances of injury to the irregular, then you have to go to the lateral side. It is enough if you go to the lateral section. No need to go into the central first, because in the beginning, if suppose there is bleeding started from the anterior, it is difficult to control. So it is better to create a space on the lateral side only, not put directly into the anterior side. So there is a little space, and then you put the port. The port, robotic port 8 mm. That is all 3 ports placed. So we start with the 5 mm ports on the lateral side and do the endoscopic. So this is a robotic docking. So before docking, we have to create some space by endoscopic technique. So once we create the space, then dock the robot and we start dissecting with the hook and same instrument I used in there. So here we do not use any flow grass, so we can save the cost of one instrument. So this is transvestibular, is cheaper than the BABA technique, because in BABA we have used 3 instruments. Here we use only 2. One is the bipolar and one is the monopolar in the hook. So creating space up to the jugular notch. And the vision is, you think it is very clear. Then the endoscopic technique for reading magnification and vision is clear, so you will be more comfortable while doing this robotic transvestibular. Laterally depends on the size of the tumor. If it is a large tumor, then you have to dissect the lateral side more. So you require a big flat area. Otherwise, the only go up to the external sternocleidomastoid border is sufficient. And inferiorly, you go to the external notch. Superiorly, you have to dissect little bit more, so you have enough space to retract and approach into the superior pole of the thyroid. And initially, you see the diversification of the sister muscles, so that is the limit of the lower limit of the sternum muscle. So there is no need of pushing because in the robotic you can't go in from the outside to know the exact boundary of where you have reached. Otherwise, you keep on operating, dissecting out. So you see the diversification of the sternum muscles, especially the sternum high muscle. So you start opening the midline. So once the midline is open, I usually separate the sternocleidomastoid with the sternothyroid. So entire length of the sternocleidomastoid is separated out. Then start dissecting the sternothyroid muscle. Here again you see this instrument setting is also important because in the right hand we have the hook and we are operating on the right side of the nerve. Once you go near to the nerve, we have to strap the instrument. So opening the space of breathing, the areas where space can increase the vessels are visible. And one limitation of robotic is that you don't have the harmonic or any ligature. We have to manage with the bipolar and unipolar. So once the upper pole is exposed, you see the all vessels are there. Okay, polar vessel. Then we use the external anchoring feature. Usually we use the 2-0 silk from outside. And you see the limitation that we have only one instrument which you can hold and use. So there is no needle holder, nothing is there. So if you use needle holder, then again cost is added. So we have to manage the one instrument. Similarly, if you use the scissor, then again the holding and lifting difficult. So carefully, once you handle the superior pole, then go and dissect the stomach and do the stomach. So carefully, if you are lifting and cutting using the bipolar, so you know into the trachea, then dissecting from the midline. So this midline is actually important whether you are doing endoscopy or robotic. Without detecting this, if you try to rotate, there is chances of getting. So if you do the adequate medial dissection near the trachea, then it will be helpful to rotate the entire gland over the trachea. So roll over the entire gland, so there is no hemorrhage from the gland. Otherwise, if you start without doing this work, start rotating, then the time of bleeding is there. So any bleeding, you have to be very patient while doing the transvestibular because there is no other instrument in there. You have to manage with these two instruments. And second thing is, usually we do not put any train. So you have to be very patient and go slowly. Now start dissecting the sternothyroid muscle, especially at the area where you do the final investigation pathology. So there is some provide here. These adhesions we have to manage carefully. So go slowly. And especially the lobe is very high up in the neck. So it's very difficult sometimes. So gradually approaching to the superior pole. In this patient, it was very higher. So we have to be careful. In the earphone, they start detecting sometimes. If there is a bleeding or something, bleeding is there, then you can use the substance along with it.
Means.
I have to stop here because the main theater has started, so you need to ready and they have in the and they have started reading the class.
We have the live workshop started, so we can request the moderator in the lecture call. Professor M.J. Paul sir, Dr. Naval Bansal and Dr. Boot Jogli to come and occupy the 3 days. Can we get a unmic, please?
इधर ही रिटर्न करना है। इसमें
Nucleus or alumni and use of the robotics guidance. And do you use harmonic for your marketing?
Like I
ना जरूरी भी है मोबाइल नंबर ना
Now, you can see the
बोला नहीं आया शर्मा शर्मा है क्या मॉर्गन स्टील शर्मा नहीं लिखते हैं
Okay, can the operating room hear us? Yes, hello. Yeah, we can. Please, one more.
Dr. G,
Dr. E can hear us?
yeah, Dr. Lee is raising the class.
सही हो जाएगा सही है सोचा ही नहीं
Good morning from the auditorium. Can you just tell us how far you got and what step you're in?
स्पॉटलाइट करो इस पे जानना था ना स्पॉटलाइट घूम के दिखाऊंगा नौकरी करा अरे जब हो जाता है सही आ रहा है ऐसे सही आ रहा है हटा उसको हटा देखो सेम नहीं अलग है अलग है एक इसके नाम से ऊपर लैपटॉप के नाम से ये लिखो अपना भी लैपटॉप का तो नहीं लिखो इसके टेपिंग कर रहा है टेप कहाँ टेप लेगा हो जाएगा तुम आओ तो सिलेंडर पे बैठे ना लिखो लैपटॉप नाम लिखो उसको वाले क्योंकि हमको कौन में पता चल जाएगा
Okay, from the picture, we cannot make out that the surgeon is to the patient and approaching to the breast and maxilla and mobilizing perhaps the left side of the neck. Dr. E connected to the microphone.
चौबीस
And now see the full width of the sample, the internal aspirate. Right side and arms going the left. Going upwards. Giving towards the superior extent of the straps.
The lesion, as I said, was on the left, so you can see a small bulge behind the left structure. Yeah.
और दूर करना
There is an interesting point to discussion about this when solitary nodule as presented is a solitary nodule benign appearing characteristics on the ultrasound and nail is benign. What is does the solitary nature increase the risk of emergency has been a point of debate. Then it will say that only 19 population that holds. So in India, whatever documentation, small reports that come out have shown solitary nodules to have higher incidence of emergency, but it's still a point of debate.
We have almost reached the finite cartilage. Not much idea whether the solitary nodules that are inside. But just one point I want to ask, the lab phasing is slightly more sensitive in the body as compared to
Yes, definitely, because the point of view is below 23 where there's an excess extent probably is a little more. You can see here compared to the earlier snippet videos shown. And yes, that is one point that there may be more lap raising, therefore more seroma and effects of hematoma or paresthesia. So these points that are noted, but most of them are temporary. I personally do the transdural, so I'm not for that personal experience with the normal. What is your?
I feel the flap extent of flap is more in our topic. You go till the point of insertion of both because you need a wider space for the body to move as compared to endoscope, where the majority of control is in your hand. And so, second thing, I was discussing with Jan yesterday, like Baba was you were not actually doing open techniques. There was less chance of doses of rapid what's your experience on because I have seen in one or two cases where there is a seroma formation while doing the rapid approach. Maybe Baba is maybe slightly better, but I have very limited experience of doing Baba. Can you hear?
Yes, can hear you. Please.
Yes. So it's creating space and in robotic it needs a bit more space to for the movement of the robot arm. So it is the little bit larger than the endoscopic technique.
So, Dr. Gyan, since you do both techniques, you can tell us the pluses and minuses on both sides. So,
Yes, sir, we can. Hello?
Yes. Okay.
Yes, sir. Repeat your question.
Just a comparison between the flap raising and the effects of those post-operative between transdural and Baba or rapid. You said in the video, actually for transformers, we don't even put a drain because the tap raising is minimal.
For that,
Okay.
and in the
Ready.
चालू नहीं हुआ
कैमरे में 3D बना
and
थैंक यू वही हम लिख रहे थे
along the port. In the mind of the port is bigger.
The answer as well as false. As a beginner, use which one is better?
ब्लाइंड हो जाएगा
Also, what's your take as a beginner, you should adopt for transferal or this Baba port? Which one is you feel is more beneficial in the long run, and which one is easier to start with?
No, I'm not the right person to ask this. Frankly, to share, I looked at power for a long time. I'm not happy with the rating, so I'm completely tired of it. That's why I wanted one to get yeah. I think one advantage, what is said is in the Baba, you're looking from the same direction. So you're not in upside down. The second is probably larger tumors can be handled with Baba. And maybe for a beginner, it would be easier because you're in the same direction. The theory factor in laparoscopy probably required higher for transferals and Baba. So I think overall, that is that Baba may be easier for a beginner.
सर
There's another mic. We can have questions or comments from the audience as well.
Now you could see both the side ports.
Can you just explain what is the use of the tube again?
Yes.
So just we are waiting for to fix the breastboard. So they will not going apart while dissection.
Dr. Gyan?
Yes, sir.
Okay, can you just give your take on how you would advise on somebody who's going to start off, which would be a good approach with the endoscopic technique in general? What would you advise? Because you do both techniques.
Yes, similar to the endoscopic, sir. Just the difference is that we are using 4 port of 8 mm in robotic. In endoscopic, we are using 3 10 mm or 12 mm port, 1 5 mm port. And rest of the things are similar. The position of the patient is same. The port site placement is same. And the dissection area is same. The dissection in this robotic is required little bit more because this port, lateral port have to be more area for the movements, for the robotic arms. So we have to be dissected little bit more flap area than the endoscopic one. The advantage of this robotic is that it's have a larger vision and higher magnification. Energy devices are good, so you can go for the path and you can dissect the large tumor size by this technique. So usually it is recommended that up to 6 centimeters go through the endoscopic power technique, but here you go up to the 8 centimeters side node. And malignancy wise, you can operate the central compartment, lateral compartment, all these through this technique. The robotic technique is good for the neck dissection with the thyroid surgery. So if you go for the total thyroidectomy with lateral neck dissection, it is better to go with this technique. Otherwise, if you have a small thyroid nodule like less than 2 centimeter thyroid malignancy along with the lateral neck, then you can operate also through the endoscopy. But if there is a larger tumor, it is better go with the robotics one or the open. So open is the gold standard. If you don't have the facility, go for the option rather than the endoscopy.
Dr. Dalai is doing the. Could you come?
Yes. So IBAN is the fix now. So we are now deploying the robot.
And Dr. Dalai, you've been doing that quite a few to share your experience.
Thank you, sir. Robotic Baba, as I said, it is a really revolutionized procedure, almost in for the past 2 decades. I think the only difference between rapid and robotic Baba is the flap creation. You've seen in robotic Baba, there will be hydro dissection, followed by the flap dissection, because it's either or harmony. In rapid, the advantage is the flap is raised through under vision. You have better control, and the advantage we saw was the fat lobules don't come down. Unlike hydro dissections where you're doing a blind dissection followed by then raising the flap. In rabbit, you directly start raising the flap under vision, so the fat lobules falling on the camera and obstructing the vision is completely less. And another complication with the Baba or rabbit is the seroma formation. That is another problem. And with hydro dissection, with seroma time for plant dissection, the chances of seroma formation is even higher. That is the only difference. Otherwise, procedure-wise, both of those things easily reproducible, and it gives you the vision and the orientation is as good as an open phototherapy and the other remote access procedures like advanced or advanced surgery. This gives us more better vision. The tracking is less, it's not, there's no, there is a cancer that shows the oral, transoral, thyroidectomy, where you have very narrow space, the tracking chances are more. Whereas in upper bracket, you have more space compared to the other procedures and the tracking is less. That is a big advantage.
Harijan. Harijan.
They are still talking. Any questions from the audience?
ठीक है मैं बोल वो अलग प्रॉब्लम है नहीं, लेकिन वो तो दिन कराने को
We can see some 5 minutes.
Okay. This one, Doctor R. Received. तो आप रिटर्न कर दीजिए। हाँ, डॉक्टर फरीन का भी दोनों डॉक्टर फरीन का एक था रिटर्न मेरे को दे दो एक, मैंने ऑलरेडी सेंड किया। जी I did it or without.
So this console view, surgeon console, you see the instrument description down below and seen in the surgeon console. You see arm 1 is improved, right? It is moving right now. Arm 2 the camera moving. Arm 3 they're using hook like how Professor Kanshan had shown. And arm 4 is the variant bipolar forces. So these are the description of the instruments used. Gives us an idea of what are the instruments being used. It has resultant preference ultimately. You can see the variant bipolar coming in, how we hook, so all the instruments are there. The arms are clutched. Now the surgeon is in control of the instrument. All the instruments along with the camera is under the control of the surgeon. That is the biggest advantage. Camera need an additional person to interact. That is the biggest advantage of this robotic. So is comparing to the endoscope. So thought that plays a role, but over period of time. We have a lot of robots coming in right now. For the past 2 decades, we had only RC, now we have CMR. Over to you, Professor.
All instruments are in the place. And it start detecting from the below. Using the hook, in one hand, monopolar progress from the left side and right side the back.
तो लोग करेंगे अब इसका 3D कन्वर्ट हो सकता है अच्छी में
Dr. Gyan, you're not able to hear me.
Can you ask anything?
Was Dr. E saying something we couldn't hear clearly? Was he talking?
Okay, sir.
I have been put and the bipolar with progress, robotic is your personal choice of instrument that you are using.
Ultimately, it is a certain difference. As Professor Gyan had pointed out, some people use the scissors, program, and the penetrating bipolar. Some people use the hook. Hook you need certain amount of experience, and I think over a period of time, we will definitely use it well. Even scissors, as he said, pointed out the lateral spread is less. You have an additional option of cutting the tissues apart from cauterizing, but that cannot be done in a hook. There are pluses and minuses for each instrument. Ultimately, it is the surgeon's preference. So could you elaborate what is the step being done right now, sir? Professor Gyanchan? Sorry, Professor's voice is not very clear. Is there? Could you please check on a hand, please? Can you hear from us? Yeah, please. Yeah, like he is raising the flap. He feels the tumor size is larger, so he is still creating a space. Okay.
It's under. It's one of them. चश्मा हटा रहा हूँ चश्मा हटा रहा ओके
So please check on the orientation because the console says 30-degree down, but what is being telecast looks like 30 degrees up. Is that the midline which is being opened?
चलता ना किसको
हाँ सर हाँ सर
It showed the thyroid, typhoid, disease in the area. Now mobilizing the left elbow power contact, yeah.
ओटी में ही है।
The audio is still not clear. I don't know why. We can hear clearly. Try to avoid media from the service.
मतलब बाद में हमको काउंटिंग चाहिए ना रेफरेंस के लिए।
Divided into period around
Yes.
And going in the space.
Yeah, you already. Communicate with someone in OT. Hello. Hello. Yeah, you can hear you. Yes, can you come close to the mic, please?
He is trying to identify the nerve
Yeah.
using the neuromonitor.
पेन कहाँ लेके गए क्या?
I think something is visible at the depth. Is it possible to interact with the professor? So, Dr. Gyan, we can interact with you. So, would you like to give audience some tips? How should they protect and safely reach to the nerve?
Then
Yeah, since he is at the inferior pole, so looking for the nerve, what are the tips the audience will like to know?
उसको फिर वापस से करेंगे।
Dr. Gyan, please come close to the mic. We couldn't hear you.
You see the nerve?
Yeah, we can see void
This thing
structure.
that to identify the nerve, you have to lift the gland upward and medially. So it is easier to identify the nerve.
सर नहीं तो ये कर दीजिए।
Once the nerve is identified, you will start dissecting.
Right. So Dr. Jan, is it the preferred approach robotically to go by the inferior fold method, or he likes to do some other approach? So the bolster he is using, hello. So he's retracting the muscles with the little bit of that, some small bolster type. And is there any right angle type of instrument available for such purpose? Yeah, is there any instrument for the retraction of the muscles similar to right angle type we use in laparoscopic instrumentation? We don't have it. Okay.
Does the parathyroid closely associated with the nerve? Vivek can also to come in and moderate this information. Vivek, please.
Dr. Gyan, kindly be close to the mic. You can't hear you.
This video detection is important. He's saying that by doing this detection, then you are able to rotate the entire gland over the trachea. So after doing this, only the lateral dissection is possible. So if there is a large tumor, then you dissect it first on the medial side near the trachea. And then further dissect laterally.
Is it okay to use so much of energy close to the nerve?
Yes, madam. You can use. So you see this blade is the non-active part is away from towards the nerve and active part is away from the nerve. So there is less chances of thermal injury to the nerve. This is a hemostatic valve, so it will absorb as well as have a hemostatic action.
Please take a mention.
We ask the next set of moderators, Dr. Smita Rao also to join, and Dr. Sudhi Agarwal also to come and moderate.
Approach, identifying the nerve first and going, tracing it up endpoint insertion. This is what he is doing for the large size adults. And for smaller ones, you have a choice. You can always go from lateral to medial also. But he has preferred for a larger size to go from medial to lateral side. And you have seen it here, how the recurrent laryngeal nerve has deeply been separated out and the gland is lifted away from it now. So that this gives you a liberty to move little faster and safely, as you know now, you have seen we presume that that's the inferior thyroid, parathyroid, next to it's little stained now, but it was quite nicely visible earlier. And now he is going upwards. So the gland now is lifted. It's a hemithyroidectomy. So for the superior parathyroid now, that we have to again now look for and protect before you go to the superior pedicle and disconnect.
It's a question regarding the fogging. Of course, it's a closed compartment surgery, so fogging is a major issue with the conventional laparoscopic instrument. So, is there any provision even in the robotic surgery camera so that fogging doesn't happen? Because like we are seeing that the fumes are coming, but the camera kills itself. Is there any difference? Are you able to answer?
Dr. Pudi, this they have used smoke evacuator, and also there is continuous removing of the smoke by opening out one of the port, and they have put it a suction tube inside. And second thing is that this robotic insufflator is better than the normal endoscopic insufflator, so it will maintain the pressure the entire time. It's clear?
Professor, your comments on firefly technology, do you use ICG routinely or to identify the parathyroids?
जमा कर दीजिए कितना जल्दी जमा कर दीजिए
Very beautifully done. The expertise is quite evident and good. For the benefit of the postgraduate, could you demonstrate now the strategy and the percentage time to be the answer being collected now and then we have that.
वापस करना है
वापस कर
नाम वाम लिखे होंगे चंदन कुमार का
एक मिनट हाँ ठीक है और सर ठीक है मैं कर दूंगा
How long do you generally keep the brain, sir? Do you hear me, sir?
Sam Hartman? This question. Cut 21 number. देखो इस पे चेक करो कितना है सेक्शन में दोनों हो रहा हाँ इस पे देखो कहाँ इधर इधर
कंट्रोल ममता
इसको मैडम किस पे लिखा था आपने इसका सबका होता है जिसमें अपने में साइन कितना बबल्स इस पे रिसीव कितना कितना नाम नहीं है नहीं है ना इस पे लिखिए ले लीजिए एक मिनट सर मैं जानता हूँ फिर
आपने बोल दिया उधर देख लीजिए नहीं तो
अरे नहीं वो भी बेस्ट होगा कितना
अपने आपका
9415 42 6 हाँ
Any concluding remarks from the caption?
Thinking that the bar to the, for the bar to the top.
अच्छा अच्छा हाँ
That's an excellent procedure performed, and we thoroughly enjoyed it. Let's give him a big hand. Dr. East, everybody is really applauding, and thank you so much for a wonderful procedure.
Yeah, no. Okay, can you hear me?
Yes, please.
Yeah, I did the laparoscopy for the large goiter. It estimates around 3.5 centimeter before the surgery, but I think it is grown over the 5 centimeters. And there's no complication like a bleeding or the nature of injury or cancer injury.
We did appreciate that, yes.
Yes, I think all the important organs and maybe she will be good after surgery. And after surgery the skin, surgery will be finished and she can be go home maybe tomorrow or the day after tomorrow after training. And I am very happy to the surgery doing very well and have a nice response after taking this kind of surgery. Thank you very much.
Thank you so much, thank you. We all join together in applauding you. We can hear the clapping. Thank you.
We're not going to have a second. Wait. This one. Yeah. What's it?
Very warm.
Yeah.
मेरा भी कट कर देना यार, मैं तो कल आप ओटी में नहीं छोड़ोगे। कहाँ है मेरा? इधर।
एंट्री कितना बड़ा और मनी विवेक
Thank all the moderators. We have another video of the
on robotic therapy. I want to allow it to
For moderation of this session, I request Mr. Ashish Varghese, sir. Dr. Anish Cherry and Monto, please join us in this.
हाँ ठीक है वेट काट देना हो गया ना
Thank you once again for giving me the after seeing a beautiful demonstration of the Baba Anchor, and I think my video will much great information, but just to add on to certain things, as Professor had shown, you had seen a robotic Baba left therapy. This is a rabbit robotic assisted breast activation technique. The only difference between Baba and rabbit is the flat creation. In Baba, you had seen before that the flat marking is the same 4 boards in the both the nipple area complex, next 2 on the anterior fold and 1 on the mid-axial line. Professor had not used the they use the suction through the robotic port, that is also good. But this technique we use the additional assisted port to the right mid-axillary line. So this is the flap creation. Flap markings are being done to either the dissection when we're doing it. We do the total flap, which is going to be dissected. So the difference here is this is not high dissection, this is under mission we are doing a flap dissection. Initially through the right anterior axillary fold, we create an opening around 1 inch of size. Through that, we through open technique, we raise the flap, identify the pectoralis fascia. Subsequently, after identifying that, we insert 4 to 3 ports. And then through laparoscopy, hook and suction or maybe or bipolar, we do traction, counter traction, and insufflation of CO2 that around 5 to 6 millimeter mercury pressure is maintained. CO2 is inserted, and you can see the pectoralis muscle is below. This is the flat. The only advantage is there is no blind dissection. You don't go to a different plane, and the fat logging falling on the camera is relatively less. Not that it is totally nil, comparatively less. So this is the main difference between Baba and rabbit. The mission was creating the flap. That is going to all the way. Opposite the outside markings, they are standing the very curve. There you can see the left sternocleidomastoid mastoid. That is a very important landmark. Identifying both the sternocleidomastoid is very important. Otherwise, we tend to deviate from the path of the neck dissection. So identifying the sternocleidomastoid whether it is very important. Once that is done, we go all around towards the opposite axilla. Then we below to the diphtheria complex on both sides.
रिसीव तो आप कर रहे हैं ब्रदर, आप लिखेंगे हम लोग रिसीव नहीं रिसीव में सिग्नेचर को हम सब
That also can be done using the laparoscopic hook. Now you can see the right sternocleidomastoid also. So these 2 landmarks are very important. It gives us the direction where to dissect. So identifying them is very important. If I am best to dissect, just to save on time. Once the next class is also dissected as much as possible, the outside marking helps us guide us. Once that is done, then we stop the robot. This is the next class being done. We already discussed rabbit or Baba. The regime is better. It almost mimics an open thyroidectomy. That is the biggest advantage. Now you can see the additional ports being created, the 4 ports with markings which are shown, along with an additional assistant port. So now we go to the docking. You can see the 4 ports, number 1, number 2, number 3, and number 4. These are the robotic ports. You see the laser guided talking, laser is guided to the camera port. Once that is done, we start talking. Talking does take time, initially because of the wide angle. Where you have the abdomen distended, here talking does take a amount of time. Once the talking is done, we insert the instruments. Again, instruments that we already discussed, the certain difference. We have seen from the gap using the hook. In this procedure, I used the monopolar scissors. So the gaps in the used the Maryland bipolar closer to the hook and the progress. I'm here using a scissor, fenestrated bipolar and the progress. Now you see we're completing the neck flap. You can see the progress on the right side holding the thyroid correction and the penetrated bipolar lifting the neck flap. And using the scissors correctly, we raise the flap. Once that is done, we identify the midline. As I told you, the sternocleidomastoid is very important. Once the sternocleidomastoid is identified, we identify the midline and separate the strap muscles as we do it in the opening technique. So that's the strap muscles being, the midline being identified, opened, and the strap muscles being retracted. So this is another advantage. Where endoscopy, this articulation is not there. That is a bigger advantage in robot. You have 3 arms, all the 4 under your control. That is another advantage. You don't need an additional camera person. You can see the articulation of this. The penetrating bipolar on the left can build the muscle, retract the muscle, and coagulate. Sorry. And coagulate.
हमारे चश्मे वापस हो गए। हाँ वो नहीं क्या करना,
साइन करना है ना, रिटर्न कर रहे हैं।
अरे इस पे एंट्री नहीं किया था, जो एंट्री किया है ना उस पे
अच्छा, तो अपना नाम ढूंढना
लिख
पड़ेगा।
दिया होगा ना। हाँ, जो लिखा हुआ था उस पे रिटर्न करना,
फिर अब तो जाने जाना।
उस पे रिटर्न।
आशा आशा ओटी नहीं जाना है ना, लोगों यहाँ पे तो चल रहे हैं। सुन
कर दीजिए उधर साइन करके।
Thyroid ectomies, Baba and rapid have the better visibility. Already it is a narrow space. So when you operate in a narrow space, the chance of flashing of instruments are more, whereas it is comparatively less in Baba or rapid. Separate strap muscles all around. Take the thyroid low. Separate the strap away. We go to the right side first. We start first the diathermy. The Da Vinci has the 3rd generation RB, which is as good as any vessel sealer. So we use that. Or this is the monopolar currently being used. Short burst, we separate within. There you can see the thyroid lobe visible, like how we see it in a classical open thyroid. Once that is done, the right lobe is retracted using the progress. You can see you can use the retractor also as a. You can articulate the retractor. The right lobe is retracted over the trachea. Lateral dissection is done. And the lateral calf muscles are separated from the thyroid lobe. Once the separation is done, the retraction is good. We come for the recurrent region now. It is the real spine. I'm sorry, I mentioned real space. Real spine.
हाँ कर दीजिए।
Hello.
And then you can see the super candidates. Which gives us another indication that another super candidate. So we continue our dissections carefully. I want the spine to look for the top.
इसलिए बोल रहे हैं काउंटिंग में
being separated. The robotic camera has 15 to 20 times magnification. So rest assured you can see every minor detail. And the chances of lateral spread are very minimal with this. That is the advantage over the road. The parathyroid is right. It is a very good fact. Another option is you can use ICG and find the technology, which is an additional advantage with robotics. You can identify the parameter supply, whether it is still viable. That can be done for the identification or after the thyroidectomy, you can look for the viability of the thyroid also. Now you go to the lower pole, finally lift the lower pole up.
डॉक्टर पेन दे दीजिए.
Once that is done, you still keep looking for the there you can see the regions are there branching there. That is once we are sure that the retinal is identified.
क्या ईमेल है जो एक माइनस कर दीजिए. अच्छा आपको चाहिए क्या? इस पे लिख के लिया होगा.
The previous case we had shown a bone spur. This is the patty only used in neurosurgery cases. This is good absorbent. So we use the patty. Now we go to the so you can see the lobe being retracted down. The counter traction. You can see the
माइनस का एक लगा हुआ है तो है ना इस पे लिखा हुआ है.
We make sure that there is no there, so you make it and then calculate the superior pedicle. Another advantage is robotics because of the magnification, you can identify the vessel individually instead of mass ligation or enhanced ligation. You can identify one superior thyroid pedicle independently. And as I told you, since the early is the third generation one, you can rest assured you can use the bipolar, which is as equal as the unipolar. So there you can see the vessels being identified individually and divided. That is done. We can even more excited, right? You can see the complete division. This is the better view on the return version law. This is another.
Yeah, continue.
Right lobe is separated. Like the case which is being seen or a gas sensor restaurant, they want to midline, divide the resistance and then come to the load side. This we go like how we do it in the opens. This is another option, ultimately the surgeon's preference. So that's the belly being divided just above the sternum now. The right lobe is taken over. In this case, we don't do this split. We go ahead like the lower bone being lifted out of the gland. Some amount of thyroiditis is there for this patient. That is why the pain is not very clear, but it will be managed. Thyroiditis is a related contraindication. As long as the thyroid is on, you have the exercise, but definitely there. Another problem is South India, most of the patients have thyroiditis, but there will be multiple patients that have it. Now the right lobe dissection is done, we go to the left lobe, same way lateral dissection is done, and that has to be separated from the left lobe of thyroid. You can either use the thyroid glands to the same option, or you can hop the ports. Like how we had shown 1, 2, 3, 4, you can hop the camera for better vision, so that you can go to the ports also for better vision in case we have difficulty. For a period of time, you can master it in the second port, or you can see that the is being separated from the thyroid. There is some amount of addition because of the thyroid angle.
आपका चार्जर है क्या? नहीं मेरा नहीं बोलो. संदीप जी यहाँ पे नहीं है, दूर है. तो मेरे ऑफिस में है, दूर है यहाँ से मेरा ऑफिस, टेलीमेडिसिन में.
It's a bit messy because of the thyroid inflammation. Like that is video which was supposed to get. There you can see the recurrent thyroid lungs now coming into the view. After some more section, we will report. And you can see the left recurrent gland. Again, this is also branching. We are very sure that the now is identified. And we start checking over the Once that is done, we go again, separate the lateral additions with the trap muscle. Once that is done, we are forward to this section. That is interesting. Now we have a beautiful plane. Filled with 38 discs, and for the thyroiditis, there is no addition. In this case, we took out the large. But we needed some concentration. But the progress lifting the upper fold and that is the feel very good. This is another way of doing the power. That is done. We will check for any bleeding. You can see the superior character and the that is also preserved. Another option is using ICU and high technology. For the viability, there is no viable tissue. You can look for the thyroid, whether there's any that are stuck to it and do probably auto compensation. This is a normal brain bag which we have customized because the endotype is pretty expensive, it's about 2 by 3,000. This is a train what we use from our trains. We customize it and use to retrieve this. This is the rapid approach of total thyroid. Thank you very much for this opportunity.
Thank you all the participants. May I now request Representative Warren to present the videos with this one focus directly. I would request Dr. Ramya ma'am, Dr. Cheta ma'am, and Dr. Divya ma'am to please come forward and make all the
Nearly more than 20% of expect for their
Good morning. So far, you've all been talking or seeing thyroid surgery and especially rather community. Even after surgery, you need high technology. Be it robo or endoscopy. But to give you a flavor of what else we had and the things that we need to do, I'll show you old style minimally invasive thyroid. Consider a procedure which has been in vogue for 2 decades. In my mind, it's old. But not everything old is to be described. I think this video should be seen in that side. It is not endoscopic, it is not robotic, but something which is effective. This lady, whom the video I'm showing about, is a 58-year-old housewife with symptomatic hyperparathyroidism or status fibrosis, concordant parathyroidism. On table, we located the thyroid gland and marks the incision for an inferior parathyroid peak. Incision is made, deepen down to the platysma. Any superficial oozers are taken care, cut through the platysma, create a plane, subplatysmal plane, and using 3 small retractors, start the dissection between the staph muscle and the sternum. So this is a lateral approach, minimally invasive therapy. Any bleeders, oozers, any minor veins are coagulated or sealed. It's important to have a bloodless vein. And then having created that plane, you straight away go, because this is an inferior gland, it is relatively more ventral and superficial. As you see, along the thyrothymic tract, you can find this technology.
And more often than not, it will be visible along the inferior fold, along with palatinic ligament. And any vessels interconnecting this tumor with the thyroid lobe, as you can see now, can be clipped or sealed and divided. And as you might appreciate, I try to use the cautery tip, the monocular cautery tip as a dissector. Don't use the current, just use it as a spatula. And as and when required, use short bursts of for low current. Now having dissected the tumor, we draw a pre-excision sample after keeping the last particular vessel, that's time 0. And here on we collect 5, 10, and 15-minute sample for RPPH. The specimen is out. And this is the kind of a straightforward, direct vision, lateral incision, lateral approach, minimally invasive therapy. This was 80 milligram adenoma. Just give the operative space some wash, ensure hemostasis, and that is, the infection now was visible even before the excision, but just to show you now, you can see that usually this step is not required. You do not want to see a normal gland always, but at times I do that. This is division of the inferior thyroid artery, so that you can dissect the lateral space. That's the normal superior thyroid. That confirms that what we took out was indeed an inferior gland, and its appearance looked like that of an adenoma. It could be sent for section histology. Now, all this can be done within the time that you're waiting for collection of the next blood sample for RPPH. Patient had curative fall of the PPH levels. Just close the platysma, and then at the end of this procedure, because the retraction, this incision then gets extended to 3.5 centimeters from 3 centimeters to the stage step, and that's it. So this is, as I'm sure not every patient who has a thyroid or a parathyroid pathology is totally averse to having a small scar in the neck. Of course, all those who are totally insistent on not having any scars in the neck visible to anyone, they can opt for a scarless in neck or remote access thyroid or parathyroid procedures. But this kind of a direct access small incision to parathyroid also works. This was we have inferior parathyroid. The same operative procedure can also be done for the superior one. Here, having dissected the lateral space between the straps and the neck and then the sternum, we are dissecting this lateral space and keep dissecting along the border rod or the margins of the thyroid lobe in the vicinity of or in the location where we expect the superior gland to be found. Lo and behold, you see this bulging parathyroid tumor. So it's not always possible to just hit the tumor right away. You have to dissect the any tiny vessels coming in there can be either ligated, clipped, or sealed. This is both these videos are rather old, 15 years or so. At that time, we would use clips more often than what we do now. Mostly these are now sealed either using a harmonic focus or a ligature or even a bipolar cartridge. But again, the capsule of the tumor, see dissecting using relatively one-tip scissors, and make sure that you are not holding the parathyroid tumor, but if you have to hold, use the forceps to, as you can see now, hold very parathyroid tissue.
there is always some bit of fatty and fibrous tissue. Here you see the rectal angle now. And then right now what we're doing is dissection and stabilization of the inferior thyroid artery, which can, as you see, it's being stabilized now. We just put in 2 clips and divide this in between clips. And this step may not be required always. Tumors which are large, which are posterior to the artery, and we cannot dissect safely without ligating or clipping the artery, then of course we do that. And try not to hold and make sure you do not hold that tumor, lest you rupture the capsule and cause parathyroidosis. Dissecting along the rectal nerve, keeping it intact and safe all the time. They can be accessory vessels, accessory or branches in the inferior arteries. Having clipped the last one, that's time 0. That's where you would start the clock. Tumor is out now, as you see here. And simply ensure hemostasis. That's the rectal nerve for you. And all in all, a pretty dry field can leave in a small hemostat and hemostatic material, whatever you use your preference. We use a descent. Collect the 10 minutes and 15 minute samples. Ensure the parathyroid hormone levels are dropped. And that's it. So these 2 short videos, I think, would have convinced you that straightforward, simple. This is a 30 minutes or 15 to 20 minutes job. And it's not always essential to use the latest gadgetry. The cost of this open incision, direct visions procedure is not even 1/4 of a robotic thyroid surgery, at least in this institute. So, depending on what the patient desires, one can choose the appropriate procedure for them. Any comments or questions are most welcome. Yeah, Siddharth.
Regarding the approach for the minimal injury, how do you decide whether you want to go to the anterior thyroid or you want to go the lateral approach from the side? So I'm not going to.
Okay,
Light.
so this is something which we
What
published
light color?
in 2001, 2002, with an elaborate technique for lateral incision in the invasive parathyroid teeth. That's not the only way to do, but this is something which has worked well for us. For the superior parathyroid tumor, superior gland is a more dorsal gland and relatively more lateral. So we use an incision 2 centimeters in length, approximately 5 millimeters above the usual stem-crease incision, starting 5 millimeter lateral to the midline. The neve is slightly higher and slightly lateral. Whereas for the inferior gland, we use an incision right in the crease, neck crease, starting the midline, from the midline of 2 centimeters. But now, more often than not, we do an on-table ultrasound and then mark the incision right on top of the tumor. And that helps it even further. Even while we're doing it, it's best that we place the incision in one of the neck creases. That leaves the best possible start. And then once the incision is marked, the superficial dissection is through this incision. The rest of incision in the depth or the dissection in the depth is just the same. You go in between the straps and the sternum twice. Create a sufficient dissection space, and then go on. Okay, yes, those can be used. But I feel, especially when you're using the small incision, the thyroid surgery or parathyroid surgery, you want more flexibility. So it's better that we have. We do not use a self-retentive factor.
The standard parathyroidectomy or thyroidectomy, if you have sufficient factor work. And second issue is more often than not you do the disposable. That adds to the cost. You cannot use other kind of self-retaining retractor as you use for thyroidectomy. Okay, thank you very much.
Thank you, sir. I would now request Dr. Parin, Assistant Professor Endocrine Surgery, to kindly come and present the video snippet on ICG and PGES for parasites. Good afternoon, everyone. I'll be presenting a small introduction before the video to the benefit of general surgery, PGES, and the SRG. So, ICG is indocyanine green as an inert water-soluble non-radioactive contrast agent approved by US FDA. And it's used as an IV injection, confines itself to intravascular spaces rapidly bound to the plasma proteins. And it is exclusively excreted through hepatobiliary system via first pass metabolism. And when this, after its intravascular space it reaches, then it's illuminated at 806 nanometers with a low energy laser. These plasma bound ICG molecules outline of ICG is short, with around 3.1 around repeated applications in a case. However, it does have a toxic level, which I will be talking about. So this is the indocyanine green, one of the brands of indocyanine green that it has a wider water and comes with the package. So adverse effects, like with any contrast agent, it contains around 5% of sodium iodide, and there are relatively certain occurrences of anaphylactic or urticarial reactions with it. And in studies which have used indocyanine green, where there has been reported 3 operators with iodine or drug allergy, those patients have been excluded from the study. Wi-Fi camera is a handheld device which is portable and flexible and can be used in the intraoperative field from a distance of 10 to 40 centimeters. It is compact, light, and is ideally used for ICGs during post-thyroidectomy. So it is used with 4 modes, that is overlay mode, which shows a green light, a 5 CSF mode, which shows a blue-pink color contrast, a contrast spine mode, which is actually used for grading of the parathyroid. It is a black and white contrast image and a white light image. The primary ICG usage was in bowel surgery, and other uses in endocrine surgery are for SLNDs and inviabilities of flaps after remodeling. So there have been studies on validity of scoring for ICGs in patients where both thyroidectomy to grade the viability of parathyroids. Where grade 0 is no ICG uptake, grade 1 is less than 30%, grade 2 30 to 70%, and grade 3 is more than 70% of uptake. In our institution, in our department, we've done a study
with ICG in post-thyroidectomy for identification of parathyroid glands. And a study by Zebi et al. Had validated a score. So we have used their score to validate it, which is used in our study, but score 0 is for non-vascularized gland. That is the gland that is black. So was given for a white. A 4 or 5 or more with our study results and ROC of more than 5 score was considered to be safe for predicting early post-operative hypocalcemia. So going on to the video,
यहाँ उनका देखो रिमोट में वो सही देखा तुम ऐसे क्यों ये उल्टा फोकस करते हैं ऐसा थोड़ा तुम कनेक्ट हो ना दूसरे में
so this is a 55-year-old male who had a multinodular goiter.
ठीक है
And he planned a total thyroidectomy
बता फोटो भेजते तुम
with ICG. Thyroidectomy was planned via standard collar incision over the neck. And after opening the skin, subplatysmal plaques were raised and thyroidectomy was performed as per the standard procedure. This is the subplatysmal raising the flaps. And once the gland was delivered, it was closely inspected for the presence of any parathyroid gland. However, there was capsular dissection done and all parathyroids were meticulously detected and left in situ. The specimen was then placed in ice as per our protocol to preserve any parathyroids which may have been detected out of the gland. Followed by this is the surgeons and surgeons team identification of the parathyroid left in situ. All 4 parathyroids were identified in this case. This is the forceps pointing at the superior parathyroid. While this is going on, the anesthetist is instructed to reconstitute the ICG, which is done by taking 5 ml of sterile water and instilling it into 25 mg of powdered sterile indocyanine green lyophilized powder. And then this is well shaken for 3 to 5 minutes for complete dissolution of all the particulate matter. All the particulate matter should get dissolved because injecting particulate matter may potentially be hazardous and cause reactions. However, there is also a protective filter which is used to aspirate the dye from the wire, which filters out any sediments which are present after the dissolution. So it is given at a dose of 0.3 mg per kg, which comes to around 1.5 to 3 ml per patient. However, up to 5 ml can be given. The toxic doses are up to 5 mg per kg can cause toxicity. And a single vial costs around 1,200 to 1,500 rupees. And in a day, 2 to 3 cases it can be used. This is slowly injected and the contrast, since half-life is very short, the immediately contrast mode is switched on. And as you can see, this is left superior parathyroid, which is looking white. These are already pre-identified parathyroids by the medical team, and this is the overlay mode, which shows green dye into the parathyroids. On flow, a person stands there and records. Patient scoring was 7, was 2 on 3 sides, 3 glands, and 1 gland was 1. Following this 20 minutes, a PGES sample is sent. And a 6-hour calcium sample is sent, and the next day morning calcium sample is sent. This patient had no symptoms or signs of hypocalcemia and post-operative The downside of using ICG in such a field is that even the lymph node and other thyroid gland nodules will also show up the dye, and that actually interferes and brings down the specificity and sensitivity of this. However, our study done did have results similar to the other validated studies in the past. We found that the specificity and sensitivity of it is around 70%, and when combined with IPDH, the chances of it predicting early post-operative hypoglycemia is up to 80% in cases. So advantages of ICG is it limits trauma to the parathyroid glands during surgery, allows each gland to be evaluated separately, does not limit evaluation of overall parathyroid gland function, and allows change in management of parathyroid gland whether to be reimplanted or not, and in case where surgeon is still contemplating on whether doing a completion on the opposite side, if there are injured parathyroid or non-vascular parathyroid, then the procedure may just be left with a hemithyroidectomy. The limitations is there is obviously a lack of uniform grading system. The subjectivity in identify the parathyroid glands with certainty, all for parathyroid glands is visual. There would be combining autoflow. This is presentation. Is fiber different from iris? Is it infrared or is it laser? Just laser. The one that is an iris is also laser. That is used in this. This why I ask is I'm sure you remember the article. As it is cancer and all, they have identified autofluorescence. Yes. Have you seen that? No, we have not used it, but have you observed it when you are doing? No, we did not want it. Because we need a specific wavelength for it. I remember it was infrared, but you are saying this laser. I'm sure I can, maybe we should. Okay. The senior resident who was involved in the project said it was infrared. Are we not completing the thyroidectomy based on this? What you mentioned. Then stop at hemithyroid. No, the initial plan was considering if there's an STN and the plan was to do a total thyroidectomy for some reason, and like completely, it's just quoted from a paper that it could be, it could possibly aid, because that is the only explanation to it. I mean, not the only explanation, but we do regularly in the communities when I was there, and what we used to do is auto transplant. Yes. So that should not necessarily prevent us from doing the house. Yes, I would agree. And again, limiting trauma to the thyroid glands during surgery, but this is a procedure that is done after the entire thyroid is removing most of the other than in hemithyroid. So what about in hemithyroid? Have we done any cases? No, we have used it only in total thyroid. So they're really not very relevant. Yeah, that makes sense. So if you don't find the adequate number of glands in seed, you have to check the specimen. That's why you. That's correct. It's a protocol anyway. Even before this study, we always store our specimen immediately. And have you noticed any advantage in
identifying these glands and doing PPH versus just identifying the glands or just doing object of it? Is there any additional advantage of doing both the things together rather than either of the one?
Doing this PPH was actually a validation of a study done in the department itself.
Yeah.
So,
We have scale.
yes.
That is one.
Also, Dr. Sudhir's paper.
When do you decide to transplant based on this grading? I mean,
If it is zero, it's only zero. Like only zero when it turns black. If it's one, it means it is gray, it may not be.
again, it is the implication of this grading.
It's just to predict it's just to correlate with the PTH post-operatively and start an early correction.
Practically, if we find that the grade is only if it is zero, we leave it.
No, the grade has to be 5. It is a cumulative sum of all the 4 parameters. So according to our study,
For the individual parathyroid, suppose we have these completely so for that, we should have to make a decision whether you.
yes, whether we should auto transplant it then and there, than to have a patient with post-operative hypothyroidism.
You personally feel that this should be incorporated henceforth, considering the costs. You must have multiple cases.
In my limited experience, I don't think, but it's still at the level of studies, and still studies are going on, because there are more things to it. And combining autofluorescence with ICG may give you better, but the whole thing is subjective according to me. Because first of all, you have to identify the parathyroid. You're not good enough, if you're not skilled enough to identify the parathyroid, you might just identify a node, which is ICG. So that's where autofluorescence comes. Node would not be autofluorescence. I think you need more, studies, definitely some, maybe an adjunct useful, which could be used in difficult cases, but like IOPDH and other adjuncts, it has to be used judicially, because money matters.
Very probably a good tool, especially in cases where you decide later on that you need to do CPLMD.
Definitely, central compartment node-dissection would be a good area of application for initial removal and auto-transplantation, than to have a component.
Even their gland also has a. So that was the limitation.
Exactly, so that's where ICG comes in.
Yeah, actually, I wish, I mean, I had a case recently where I had it in parathyroid, and one or two parathyroids were discolored. So I was debating in my head, should I leave them or will they recover or not? I think in those cases, this will be really useful.
The patient is.
Yeah, he had normal PTH.
We understand we are still in the study phase of the community. This particular case is more of a predictive value rather than definitely. So maybe I'm sure it must be in pipeline that we inject the ICD just before we start identifying the that will be of more help. If you aim to do it now, then the difficulty would be that you thyroid will take up because it's quite a vascular gland. So it may, the whole purpose of it is to remove the then we expect from the ICD, because already the things are done. If it is he was the
कनेक्ट हो जाए तो
your point is valid, but then
One comment regarding what Sudhi was saying. I don't know whether using it actually detects the autofluorescence of the parathyroid. So when you start dissecting, if you use the camera, Striker has good visibility of autofluorescence. I have used IRL and Striker both. Striker probably scores over the IRL expression. So there you can detect the autofluorescence, but there is no tool which tells you how to preserve the vascular integrity. If you are not able to detect, then autofluorescence can help. And once you have done your thyroidectomy, then you do ICG angiography. ICG basically can
that is used for angiography of parathyroid.
That's why the endocrine surgery will come over.
The infrared camera that we are using, it should actually have the ability to detect autofluorescence of parathyroid.
Then it can be detected in situ. as well.
Yeah, in situ, before you are starting the section of the thyroid. There is a reading,
And or probably the background update. I'm not sure because the entire tissue will take us. So it goes into the intravascular space. So everything will like that. I have to check in the paper what exactly the context is.
No.
Thank you, everybody. With that, the session comes to an end. May I please request all of you to proceed downstairs for the poster walk, which will be followed then by lunch.
Thank you, everyone. And before we leave, we give a big hand of applause to Professor Jin Munir for a wonderful surgery in the And second housekeeping announcement, we have quiz with us. Dr. Chandan Kumar Jha, faculty, quiz with us, this member of our name, and Dr. Pandana Jagannath, student winner. And we are now going to go down for the poster walk. 12:30 to 1:30 is the lunch. Then we have a packed session. So the post walk, the presenters are supposed to be near the poster. We will come down and we will start immediately. Thank you.
Sir. No, वहाँ सब लोग सुन रहे हैं। मुझे स्पेक्स ले लेना किसी के हाथ में।
Return the goggles. They'll be of no use to you.
Second.
Kindly return your goggles to the ABT at the back, please.
Thank you.
हेलो क्या चला गया वो पवन कौन है किसको मैं ना कुछ और बात करनी थी यार चलो ठीक है नहीं मिल गया
Yeah, I think I'm on trigger.
Keep going.
Yours and mine. Samsung है हमारे जो देखना पड़ेगा अभी
वो जो ग्रेडिंग
तो भाई सर ये हमारे दोस्त थे, 2 आ गए हमारे।
15 और 10 चाहिए, 10 और चाहिए। कहाँ एक किधर हो गए?
लेकिन तीसरा है पता नहीं, चार में रखा हुआ है।
और 5
मिलना है।
हाँ,
इसके अलावा
इसके अलावा 5। रीना सिस्टर, ममता सिस्टर कैसे कट करके नहीं, मतलब हमको काउंटिंग सही होना चाहिए। देख लीजिए 1 2 3 4 5 5 8 10 15 4 5 और 5 चाहिए। डॉक्टर सुधी के नाम से होगा।
रीना आनंद इंडो मेडिसिन।
हाँ
अच्छा
हाँ,
रीना आनंद।
रीना आनंद इंडो सर्जरी पे है, इंडो सर्जरी वार्ड।
हाँ हाँ। दूसरा
तो इनको ठीक कर दो, रीना आनंद। थैंक यू मैम। इसमें साइन कर दो। ठीक है, ये 100 होगा।
ये तो आपने करना है ना, मेरे साइन से क्या होगा?
रिटर्न कर दिया आपने।
आपने बस सेव करना है। नहीं, दोनों साइन
She has a laptop downstairs. So 55 20 22 और 3
रीना देख लीजिएगा सर, यही इंडो मेडिसिन
और 3 इनके नंबर नहीं है, ये तो हमारे यहाँ की ममता का नंबर। और 3 स्पेक्ट चाहिए। 3 स्पेक्ट कहाँ उधर सकते हैं?
शहर में एक भी नहीं है, पूरा चाहिए इसमें मैं देख चुका हूँ।
25 जो अलग है वो अलग है ना। हाँ, उसका इनके बेकार। और हाँ, एक लेडी था, लेडी वो डॉक्टर यहाँ बैठे तो उसका स्पेक्ट में इसीलिए बेटा वैसे नहीं कलेक्ट करना था, साइन जरूर करा। नहीं, मैंने करा है, लेकिन वो अभी आए नहीं है ना, वो कहाँ चले गए। उधर वो वाला डॉक्टर था, चाहिए बस। हेलो हाँ, वो 3 यहाँ पे शायद अटेंडेंट नहीं गया वहाँ पे। इधर आसपास के नहीं रखा मैं एक बार देख लेता हूँ। एक दो लोग ऐसे ही लेके तो नहीं गए, वो एक डॉक्टर था वो भी ऐसा ही रखा। 3 लोग ही बेटा, लेकिन अब कैसे पता चलेगा हमको कि कौन नहीं दिया, ये कैसे पता चलेगा? ये 22 है और 3 चेक। डॉक्टर रखा था। तीनों टाइप से हो गया। एक दो डॉक्टर हमने ऐसे ऊपर 22 तो और 3 चाहिए ना दादा 3 वहाँ एक डॉक्टर के हाथ में ही देखा मैंने तो शायद
अनाउंस करवा दे एक बार अनाउंस करवा दे है ना वो इज बेटर एट
सोम भाई मिले
क्या
नहीं मिले
इस पे तो नहीं ना तो कुछ नॉन टेक इस पे चिपका हुआ तो वो तो रिटर्न कर देते हैं।
किसके कंपनी वालों के
पता नहीं उसके उनका ले लिया है।
फ्री है के बाहर है असल में सर मेरा भी अभी पेंडिंग दिखा रहा सर प्रपोजल जी सर जबकि सब कंप्लीट हो गया सर मेरा तो सब कुछ हो गया जी मुझे अभी पॉलिसी नंबर भी अलाउड नहीं हुई सर ना अभी जी 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 सर जी
हो गया कैश कैश कैश
क्या पर्स में कितना था
हाँ बेटे से
ड्यूटी का क्या था
ड्यूटी का ड्यूटी कुछ नहीं सैलून में कौन सा भी है ना नाश्ता से चलिए चल रहे
सिस्टर नमस्कार
फोटो भेज तुमने अपना आई कार्ड बना लिया
आई कार्ड कौन सा ये सीनियर वाला
आइडेंटिटी कार्ड
सीनियर वाला
हाँ
अभी नहीं बना है
तो बनाओ अभी फॉर्म भरो मैं फॉर्म सबका इकट्ठा भेजूंगी तुमको फोटो भेज दो ये फोटो निकाल के दे देंगे सबको चिपका देंगे
फोटो दे देंगे
फोटो भेज दो फोटो
फोटो तो आपके पास होगी पर्स में एक फोटो
अरे नहीं पर्स में कहाँ रहती है हमारी फोटो हमको आप भेजे बढ़िया निकाल के
हम कहाँ से निकाल देंगे मैडम
भेजे है ना उसने
कहाँ से
बंद कर दिए क्या मैं
बेचारा किसी का पैसा खो गया 300 रुपए
हटा दिए
हाँ तो बंदी है समझ लो 200 केस तो है नहीं ना
नहीं है
ऐसा बता रहे भैया पता कर लो एक बार
दो केस थे ना
2 किस्तें, एक पोस्टपोन हो गया बता रहे हैं।
अच्छा
वो तो बैठे तो थे
अभी
pre-op
रुको,
में।
अभी रुके रहो, बंद नहीं करना हमारे कहने में।
नहीं नहीं, हमें कुछ नहीं होगा, तो हमारा कुछ नहीं।
तो रिकॉर्डिंग पॉज कर दो तो।
कर तो दिया, चल रही रिकॉर्डिंग।
वहाँ पे कुछ चल ही नहीं रहा, दुकान बंद है, नहीं तो अभी तक पेशेंट नहीं ले लिया होता। देखो रोबोटिक कोटी दिख तो रही है, तो ले चुके होते हैं अभी तक।
दुकान बंद
तो
करवाना।
कल, तो फिर कल होगा
कल 10 बजे आना है।
10 बजे।
कल तो जो वो होगा ना, वो शेड्यूल होगा, कल तो है ही है, शेड्यूल होगा।
कल 10 बजे आना है।
9:30,
9:30 बजे।
कल 9:30 बजे पहले हम लोग आएंगे। और कल तुम लोग, तुम आओगी कल? कल हम आएंगे।
तो हम इवनिंग में हैं।
हाँ, 1:30 बजे
कल
निकलेंगे।
आ जाओगी फिर इवनिंग में इधर अपना घंटा गिन के शाम को थोड़ा
तो
ओटी
बजे
ओटी
निकल
देख
जाएंगे,
दो के
2 बजे तक आ जाएंगे।
फिर निकल लेंगे। ठीक है, है ना? ठीक ओटी एक बार, क्योंकि मंडे के लिए भी ओटी
1:30 बजे छुट्टी होगी ना, तो हम 2 बजे 2 बजे तक पहुंच जाएंगे।
हमारा अच्छा आया,
अच्छा है ना,
गुड आया।
बहुत जबरदस्त कराया।
हाँ।
मतलब उसके नीचे घुसा घुसा के बेचारे ने किया था,
बहुत
दो
अच्छा
ऊपर
गुड
अक्सर लगा दिए थे।
मुझे तो ये डर लगा, बिना आंधे की रिपोर्ट के कर दिया था। और ये था कि पक्का मॉर्निंग इवनिंग बढ़िया तुमने किया
बहुत
था,
अच्छे से हो
तो
रहा था
अच्छे
दीदी।
से हो रहा था, मुझे कोई वो नहीं थी, चिंता
इवन
नहीं
वो
थी।
जो स्क्रब स्टेशन था वो हटा हुआ
कर दिया तुमने, कर दिया। और जो है ये
अरे मैडम को नहीं जानकारी यार, उनकी ओटी में हुई।
जानकारी नहीं है मैडम को, आप लोग बताओ क्या चल रहा है। ये फाइल जो
अच्छा।
वो व्हाट्सएप पे आ जाएगी, मैं आपको व्हाट्सएप पे ही भेज दूंगी मेरा प्रेजेंटेशन जो है।
आपका अभी यहाँ है कि नीचे होना है? नीचे।
मुझे नए नए ऑडिटोरियम के नाम भी याद नहीं रहते। ये कहाँ है?
अभी तो मेरठ में ही आप?
हाँ मेरठ में ही। हाँ, अब चक्कर नहीं लगता मेरठ का।
आप सीट काउंसलिंग नहीं होती, सीपीएमटी काउंसलिंग होती थी पहले, तब जाते थे।
अब नहीं होती काउंसलिंग।
नीट से डायरेक्ट नीट से होती है ना।
अच्छा, तो उसमें फिर कैसे सीट डिवाइड?
ऑनलाइन ही होती है।
अच्छा।
वो करते होंगे फिर।
ये कहाँ है?
ये तो हो गया ना, ये तो लाइव शायद ये ओटी वाला केस है ये तो ना।
नहीं, अब तो ये होगा ना मेरा। 3 बजे 4 बजे
नीचे ही होगा।
नीचे होगा, तो नीचे तो गाना होगा।
हाँ, पेन ड्राइव में है आपके पास डेटा?
पेन ड्राइव नहीं लाई, मैं व्हाट्सएप पे ले रही थी। बस ये डिस्चार्ज हो रहा है, अगर आप बैठे हो तो चार्जिंग पे लगा देंगे मेरा।
हाँ लगा दीजिए, कोई इशू नहीं।
हाँ, बस ये होता रहेगा। चीज होकर
छोड़िए, मैं लगा। ओ क्या सुधीर, बैठो। और बताओ। सब बढ़िया है। क्या हो रहा नहीं होता है?
बस इसी।
सब बढ़िया ना?
हमारा 2 महीने से ऐसे जमा नहीं हुआ, तीसरा महीना है।
ये वाला
1000 वाला।
तो तुम्हारा जितना हो जाएगा उतना हमको दे दो।
हाँ इसीलिए तो जब आएगा तो दे देंगे सब। मेरे सोचे तो कर दीजिएगा।
कर देंगे।
किसी के 300 रुपए के खोले बेचारों के।
किसके पास है?
अरे बेटा अभी देखो, अभी कंसोल में देखो कितने रखे हैं।
नहीं सर, वो उनके अपने हैं।
अरे देखने
नहीं देखिए देखिए कोई बात नहीं।
इसी टाइप के तो होंगे, तो वो हमारे होंगे सेट के।
क्या हुआ चीज?
चश्मे, अरे बाजार से लाके एक मेले से 2 चश्मे रख दो इसमें।
क्या पता चल रहा है?
क्या गिनती तो चाहिए उनको। कंसोल में भी है इसी टाइप के चश्मे।
हाँ है तो दो। हमारा 10 साल पूरा होने वाला।
कहाँ 10 साल पूरा होने
नहीं
वाला? नहीं यार, अभी तो मनी बैग कब मिला था तुमको? तुमको मनी बैग कब मिला था?
पता नहीं, इतना कहाँ है। 2 महीना हमारा वाइफ वाला हो गया, नहीं जमा हुआ है। अभी इसको पैसा करता तो वो भी हो जाता, लेकिन ये सर लेना नहीं ना, हम बीमार थे, बच्चे में बीमार थे, इसलिए बहुत ज्यादा। पूरे डॉक्टर के हाथ में वो लेके गए हो।
8,000 रुपये निकालो भैया। 8,000 निकालो भैया।
निकल जाएगा
पक्का ना?
अरे उधर हम हैं, कहाँ टेंशन ले रहे हैं, उनका मार कर कहा था जब बताइए। आप एक बार बोल दिए थे ना, आप कुछ मत बोलना, हमसे यही बोले थे ना। आप अपने
यार देखो, जैसे मैं हूँ ना, तो मेरे को यार दोस्त मेरे कुछ मैं इतना हूँ ना, जैसे ना तुमने बोला कि देख कर दो, तो हम तो तुम्हारे भरोसे पे किया ना,
ये तुम कर रहे
है ना। लेकिन उसमें मेरी गलती है, जो दूसरा मेरी गलती है, उसमें से वो हम निकालेंगे। वो
दोनों देगा, वो दोनों देगा।
देख रहा है ना? अच्छा,
एक वो मिला, एक में क्या बना?
और एक बात
मैडम लगा के सर पे जा रही थी।
हाँ, सर पे।
जिसको बोला भी मैंने तो करी, अभी मैं लौट के आ रहा हूं।
हाँ, एक बार
लास्ट बाहर जा रही थी, मैंने कहा मैडम वो।
हाँ, वो शरीर में लगाई थी। चलो तो मिल गया, बात तो बहुत ही
ठीक है, और एक बार देख लो, बस हो गए उस पे। यहाँ नहीं मिलेगा।
एक मिला।
हेलो,
एक गॉगल एक बार कोई किसी पे हाथ नहीं हो, वो डॉक्टर लेके गए थे, फिर उनसे हमने ले लिया। ये 25 दिन को वापस करा कर,
ये ले लो भैया सब, ये सब ले लेना रामा जी। इसके अंदर एक
देख लिया तो अभी रखा है।
अमित से पूछिए, अमित को पता होगा। मुझे नहीं आया, अगर होगा तो प्लॉटर में लगा होगा।
इस पे डाल दो। हाँ तो हो गए, ले लो ना। ये 20, ये 25 डाल दो, ये सब हो गया।
हाँ, ई लर्निंग में नहीं, वैसे नहीं रखा होगा। अगर रखा होगा तो प्लॉटर में लगा होगा।
मैं
हाँ, वो रखा नहीं है, 100% नहीं रखा होगा।
हाँ, ये वापस सब टोटल 2 बार काउंट किया है। 145 गॉगल्स है, ठीक है। उनको गिन के दे देना भैया, जो भी बाहर उसकी करेक्ट है उनको बता देंगे। तो ये डॉक्टर ने हाथ में रख के गए, पेपर खाएंगे बेटे, ये पेपर भी आराम से। हाँ सारे ले लो, ठीक है।
गिरेगा नहीं।
हाँ भाई ये पीछे से खुलवाओ तो गॉगल
ये तो लेना है।
ये लो राम
ठीक है, ले लो।
क्या निकल लिए
ऐसी आई
पीछे देखो राम
गिर जाएगा ना, हम साइज आराम से लेके जाओ।
नहीं वहाँ अभी एक मिसिंग यार, चार जो है प्रदीप के पास 5 है और बाकी मतलब अभी उसमें 4 बचे हैं।
चल
हाँ ये जाकर के वो सर पे देखा था यार, उनको ट्रेस करवा रहा। ठीक है बता। बाकी अभी 175 वापस
और किसी में है क्या? देखो चलो क्या सकते एक चश्मा के अंदर में है, एक चश्मे से कोई चश्मा आपके वहां से नहीं आ रहा है, एक चश्मा बताया मैडम नहीं काफी उनका हम उनका कम था हमारे से निकाल तो पूरा और पूरा बताया हम मैडम तो चली गई ध्यान नहीं कल भी नहीं हुआ है। ऐसा लगता है कि हाई क्लास लग गया जो तो क्या आ जाता है साधना है ना ऊपर होना है पता नहीं यार तो पता नहीं लेकिन लोग बोले थे आप कर लें कुछ ऐसा बोला अगर नहीं होगा ये लैपटॉप नीचे निकल जाएगा चेक करते हैं तो लैपटॉप नीचे चल नहीं रहा जो बाहर खोलना देखो और ये लैपटॉप कौन सा सही होता है क्या स्पेसिफिकेशन होना चाहिए विंडो विंडो 10 एसएसडी अभी अपडेट में देखना पड़ेगा एसएसडी तो सब आ ही रही है विंडो 10 अपडेट में बड़ा लेटेस्ट वर्जन है क्या समय का पूरा यूज करता है तरक्की कर सकते इस समय ये जान रही हूँ मैं निकल रास्ते में लेते जाना फिर इसको चार्जर
कहाँ भैया तुम यहीं पे थे?
अरे सर जी उसका ऑडियो
फिर चला गया
हाँ
अबे यार
यहाँ पे होना हमारे कोरिया
जब यहाँ चलेगा नहीं यहाँ कभी तो वही चलेगा यहाँ कुछ नहीं चलेगा
राहुल बाइक की चाबी आप तो नहीं है देख लो पता लगा किसी डॉक्टर नहीं छोड़ के
देखें
देखो अभी घोड़े में हैं देगा अभी देख फिर ढूंढता हुआ आएगा दिमाग से मिस हो जाता है ना
वो लड़की की स्कूटी चाबी है
जो भी हो अच्छा वो जो एंकरिंग कर रही थी उसी की होगी
हम डॉक्टर
हाँ
हाँ
माइक रखा हुआ है नीचे, जहाँ स्पीकर नीचे जब बोलते हैं वो रिटर्न आवाज चली जाती है, आवाज कर रहा है वही चीज को दोबारा लेने में नमस्ते सर, सामान कर ले आइएगा आप पहले ही आ रहे 1-2 दिन पहले मेरे दिमाग में तो सर वो बिलाल भैया ने बोला था तो 2 दिन पहले ही मंगा के रखिए। हाँ तो कैमरा चाहिए सर और एक मान के चलिए कभी 50 छोटा कोई बंडल हो तो 50-60 मीटर वाला बंडल ले लीजिए जितना मुझे और बीएमसी डीसी ले लीजिएगा सर 5-7 की खराब ले लीजिए।
So it requires a real-time ultrasound and intervention probe requirements. The consent needs to be confirmed. It's done under local anesthesia as opposed to the conventional surgery. Done in supine position with neck extension like any thyroidectomy surgery. The principles in these procedures, like I said, is utilization of heat for coagulation, necrosis, and fibrosis. So microwave ablation delivers these pulses of heat to the targeted area, resulting in tissue necrosis, whereas radiofrequency ablation, the energy is delivered in the form of alternating current, which cause subsequent coagulative necrosis. The principles in these, my moving shots technique that I described is this. So multiple penetration from deep to superficial in a fan-shaped technique would be called the moving shots technique. So how do we identify that the procedure is adequate? I'll be discussing here. So the nodule position is confirmed with the ultrasound. Its proximity to the vital structures needs to be properly confirmed before starting the technique. Local anesthesia is injected 1:1 dilution of 2% xylocaine with adrenaline with saline, a maximum of 40 ml with 20 ml each. The location is either the midpoint of the sternocleidomastoid for a superficial cervical block in a fan-shaped technique or into the thyroid capsule. Most often thyroid capsule, but you can even divide the doses between the two. Hydrodissection plane is established with a 50 ml saline or a cold 5% dextrose solution. This provides an aqueous barrier, just like we saw in the robotic thyroidectomy. It provides a heat sink, prevents the vital structures from damage. It is usually done with a 15 gauge to 17 gauge needle. Microwave ablation, the output is set at 30 volts with a 2450 megahertz of power. Energy is released in pulses. Trans-isthmic approach is most safest because it's in the center. It does not have any vital structures that you can damage. Moving shot technique is the most popular technique used. The shots start from deep to superficial and not from superficial to deep. The ablative zone is confirmed by the presence of hyperechoic signals after the procedure with no blood flow in that area and also a zone of microbubbling. So this is
the area. You can see the electrode there, the needle, and this is the area with hypoechoic signals. This is post-procedure. As you can see, there is no blood flow at all. So there is reduction in size as well, what you need to evaluate. So the post-procedure evaluation is volume reduction rate. How is that calculated? The volume of the nodule per se in the beginning is calculated as ABC, all 3 dimensions into pi by 6. The volume reduction rate further on is calculated by subtracting the initial volume from the final volume divided by initial volume into 100. So the volume calculation is with all these 3 dimensions. More than 50% is considered ideal for the procedure. A post-operative video laryngoscopy is done to confirm the vocal cord status. The patient can return home the next day or the day of the procedure as well, depending on the size of the nodule and the discomfort. Follow-up is at 3, 6, and 12 months, majorly to note complications as well as the volume reduction or regrowth of the nodule. Most studies claim that there is 100% volume reduction rate at 1 year follow-up. I have 2 patients till date who have been on follow-up for the last 6 and 8 months. The volume has been stable. There has not been regrowth as such. The post-procedure, an ice pack can be placed to avoid pain and skin pigmentation for people who actually have some discomfort. Pain is expected over the jaw mandibular angle, which can be treated with very simple analgesics like paracetamol. Complications, majorly pain, and pain. 8 to 30% of them have vague pain. Nerve palsy, very, very rarely noted. Steroid injections have known to have helped for temporary palsies. Horner's syndrome, nodule rupture is of serious concern. It's also called the pseudocystic transformation, which can be a major complication. There have been reports where fistulas have formed, and there have been cases where there is superadded infection as well. Post-procedure, increase in volume can be noted in the periphery because the periphery is less targeted during this technique. The regrowth can happen in the periphery of the nodule. So the peripheral regrowth is what we need to be concerned about. Multiple sessions based on patient symptoms and volume reduction rate. So impact on future surgery, practically no impact. If the patient needs to go into surgery the next time, the planes are clear. Important to keep the needle within the thyroid nodule while doing the procedure, not breach the capsule. Under treatment is better than over treatment. So minimum volume reduction is all that we need to intend. Avoid the danger triangle to protect the vital structures. Insufficient evidence in case of malignant nodules, still preferably done only in benign solitary nodules. Papillary microcarcinomas as well. Malignant recurrences less than 1 centimeter, which are not amenable for surgery. Autonomous functioning toxic nodules, again, the euthyroid state is difficult to achieve. It depends on initial volume of the nodule as well as the volume reduction rate. So is it a promising future? Yes, it definitely is. It's an era of minimally invasive techniques today. Careful patient selection improves patient satisfaction, can be a super weapon in a surgeon's armamentarium. It's a short procedure. It has very fast recovery. It has practically no scar. And it's a boon in those patients who have surgical or radioactive iodine contraindications. Thank you.
Good afternoon. So I was mainly told about the industries to cover the investigations part. So I start with the definition. The thyroid nodule is defined as a discrete, radiologically distinct lesion from the surrounding thyroid parenchyma. Nodules which are palpable but do not correspond to the distinct abnormalities on the ultrasound do not fall under this category. This definition was published in 2016. So everything that we touch on the neck is not to be labeled as a thyroid nodule. Benign causes, we know there's a whole list of things. Even in Hashimoto's thyroiditis, sometimes we find some thickening. It doesn't, it's not to be labeled as a thyroid nodule. So that was the meaning of that definition actually. So mainly clinical attention and the detailed history is to be asked from the patient, physical examination. And most of these lesions sometimes
patient may not even know about it, and they are witnessed due to some other procedures, carotid, ultrasound, or CT scans. Indirectly, we see that there is something wrong in the thyroid. The clinical importance is mainly to exclude cancer, thyroid malignancy. 4 to 6.5% may be having malignancy in such lesions. So we assess the volume, the consistency, the nodular features, size, number, location. Nodules that are smaller than and usually less than 1 centimeter, and those located posteriorly, they are hidden. The posterior part may not be palpable, but they may be visible on the ultrasound. And substernal, again, not palpable. As we know, the cervical lymph nodes are to be assessed. Examination of the signs associated with it, hyper or hypo, is to be done. So coming directly to the lab test, serum thyroid function stimulating hormone is to be checked, and TSH. Thyroid scintigraphy / radionuclide thyroid scan in patients with a low TSH is indicated. So this is a table which has been almost 1,500 patients, a publication in 2006, where they found the malignancy increases as the TSH value increases. So this is in direct relationship with that. So we can have an assessment from this lab value, whether it, so the low TSH level will go from the radionuclide thyroid scanning, and increased TSH or in the upper limit of normal is associated with increasing and advanced stage of malignancy may be ruled out. Serum calcitonin, serum thyroglobulin, they have literally no direct role to play. Routine measurements of serothyroglobulin is not recommended in all the patients. Thyroid ultrasound. So we know about the basics of the thyroid ultrasound, and it evaluates the thyroid gland as such and the adjacent structures. In all suspected or known to have a nodule, we identify or see the presence of nodule and the additional nodule if present. And identify the nodules that are posteriorly located, whether it's a cystic or not. Apparent nodularity of Hashimoto's thyroiditis may represent focal enlargement of the thyrocytic infiltrate. It may not be actually a nodule per se. TSH-induced hyperplasia of the follicular tissue or a thyroid tumor may be present. So ultrasound-guided FNSC, we have to identify the cases where we have to offer ultrasound-guided FNSC. And also the cervical lymph nodes and the suspicious sonographic features are to be noted, and evaluation of this for the FNSC as we mentioned. So identification is based on hypoechoic, isoechoic, and hyperechoic, and the size, number of nodules are to be identified as cystic and solid lesions. This is just a basic view of the thyroid scan, where it starts from the trachea and it goes to the isthmus and on two sides. The margins are to be assessed, peripheral sonographic halo is to be seen, and malignant, and we know that the regular feature, the outline, it's more of a benign nature, and the irregularity goes with the malignancy. The echogenicity, the hypoechoic nature is very well depicted here. This is hyper and this is iso. The calcifications, fine and punctate, it may indicate calcified schwannoma body is commonly associated with papillary carcinoma. So we have to look at the nature of the calcification. This is the colloid material that can be seen very classically in the nodule, which is the comet tail appearance. And the Doppler signals are to be seen whether the periphery has enhancement or not. It depends on the benign nature, has very less enhancement. Then the shape, as we know, it's taller than wider, associated with 93% specificity, and anterior-posterior diameter, transverse diameter ratio more than 1 has a reported increased incidence of, and it goes to 82% and sensitivity 84%. Lymph nodes, as we know, all the basic lymph nodes are to be evaluated. And ACR, TR, the thyroid classification, as it's all, we all know the basics of it, and it involves the composition, echogenicity, shape, margin, and echogenic foci. This algorithm will tell us how to proceed. If there is a nodule, what is the TSH level, and then the thyroid ultrasound finding. TSH normal or elevated will go directly for the sonography criteria and also see the FNSC if possible. TSH subnormal, radionuclide thyroid scanning is to be done. And if it's a non-functional, again, FNSC, and nodule, if it's functioning, whether the T4, T3 is normal or high, so it will be categorized as subclinical hyperthyroidism and overt hyperthyroidism. And subsequently, we'll go for FNSC in the FNSC criteria if present. And otherwise, we have to monitor them. Subclinical hyperthyroidism will have to be observed, and overt hyperthyroidism will treat it. Indeterminate nodules, we know that 5 to 15% or 15-30%, they have a predicted risk factor. The pattern vary considerably in management of this. Molecular tests have impacted the management strategies in this category. Clinical risk factors are to be evaluated. Ultrasound and elastography plays a role. Patient preference are to be evaluated, and feasibility of doing molecular tests is to be brought into the decision making for this patient. If the molecular testing is not available, perform or it's inconclusive, diagnostic surgical excision can be considered. Patients with surgical histology, specimens show benign follicular adenoma, do not require further treatment. However, patients with surgical histological follicular thyroid carcinoma might need further completion. So suspicious of malignancy, these specimens, they can be diagnostic, surgery can be done, histological examination, whatever comes, and keeping the criteria of the risk factors and other, we can proceed for completion or not. Non-diagnosis, a repeatedly biopsy taken, FNSC done. If it's blood, that doesn't mean then you stop. You can go for a second FNSC, and if not, still non-diagnostic core needle biopsies, ultrasound guided, are recommended. A word about the pregnancy. If the evaluation of the thyroid nodule in a pregnant lady would be done in the same way as the non-pregnant, ultrasound is the good modality, which is the safe one. For pregnant women with nodule and suppression, TSH that persists after first trimester, further evaluation can be delayed after the pregnancy and cessation of lactation. However, in second part of the pregnancy, if it is diagnosed early, remains, you have to stabilize the patient, and after delivery only to be considered. Consideration could be given to administration of levothyroxine therapy to keep TSH in the range of 0.1 to 1. A word about the contrast enhanced ultrasound. It's widely being used. There is a meta-analysis that was published in 2018, which shows that widely used to evaluate tumor microcirculation, useful in differential diagnosis of benign versus malignant. What did this meta-analysis conclude? No isolated contrast enhanced ultrasound features are there in the conclusion capable of predicting malignancy. So they couldn't identify these are the features that can be isolated. Some features such as hypoenhancement and heterogeneity identify elevated risk factors. That means the only risk factors could be identified through this. Homogeneity and ring enhancement indicate benign nature of the thyroid nodule. Another feature is the previous, yes, that's the last slide, sir. Another, the previous speaker mentioned about the ablations. The contrast enhanced ultrasound has been used to evaluate the residue of the ablated material. And I just conclude. Thank you.
Good afternoon, everybody. And first of all, I would like to thank the organizing committee. And I will be speaking upon retrosternal goiter under various headings. And retrosternal goiter was first described by von Heller in year 1749. And other names given to this entity are substernal intrathoracic mediastinal goiter or cervicothoracic or endothoracic goiter. There are various definitions for retrosternal goiter. However, the most accepted definition is when more than 50% of the gland is located in the mediastinum. This retrosternal goiter can be primary or secondary. Primary retrosternal goiter mainly arises from the aberrant thyroid tissue, which is ectopically located in the mediastinum. And diagnostic criteria are it should not have any connection with the cervical thyroid, and it should receive its blood supply from the mediastinal vessels. However, secondary retrosternal goiter is the downward migration of the cervical thyroid into the mediastinum. It is secondary to the negative intrathoracic pressure, effect of gravity, and traction forces during swallowing. It is a slow and progressive growth and commonly present in 5th or 6th decade of life. Majority of these goiters, they extend into the anterior mediastinum. However, 10 to 15% of the patients, we have migration of cervical thyroid into the posterior mediastinum, that is posterior to the esophagus and trachea. Again, majority of them are situated on the left side. However, 10% of these can be bilateral, and very rarely we can have cross substernal goiters also. So there are various classifications. When the retrosternal component is above the aortic arch, it is grade 1. When it lies between the aortic arch and pericardium, it is grade 2. And when it is below that, then it is grade 3. There is another commonly used classification is where when the retrosternal component is in the anterior mediastinum, it is type 1. When it is in the posterior mediastinum, it is type 2, which is further divided into type 2A and B, and type 3 is the primary retrosternal goiter. So now coming to the clinical presentation, 1/3 of these patients are diagnosed incidentally, and common symptom is the secondary to tracheal compression when the patient is having breathing difficulty, which is mainly positional or nocturnal. Where, however, these patients can come to us in OPD with the history of suffocation, choking, cough, dyspnea also. Acute airway obstruction, where patient may come to us with stridor or wheeze may be present, which is secondary to the enlargement of the goiter, sudden enlargement of the goiter, secondary to the hemorrhage. There may be acute laryngeal edema or underlying malignant changes in the retrosternal component, and some of these patients may require emergency intubation also. Stretching or entrapment of recurrent laryngeal nerve can be there, and these patients present to us with hoarseness or dysphagia when there is a esophageal compression. Superior vena cava compression can be there, and which can be clinically apparent, or we can do Pemberton sign to demonstrate it, where there will be facial plethora and prominence of the superficial neck and chest veins. Some of these patients may come to us with toxic goiter or may be harboring malignancy in the goiter. So the diagnosis is mainly based on the clinical history, examination, and cross-sectional images. CT scan gives us the information about the extent of the goiter into the mediastinum, whether this extension is into the anterior or posterior mediastinum, what is its relationship with the major vascles or trachea, whether it is unilateral or bilateral, whether it is causing any compression on the adjacent structures, and what is the density of this retrosternal component, what is the width of the retrosternal component as compared to the thoracic inlet. So there is CT classification where it has been divided based on these criteria into type A to D. Now, if we look at this X-ray, there is deviation of the trachea on the right side. However, there is no compression. This is another patient where if we see both side right and left lobes are enlarged, causing significant narrowing of the trachea. The lumen was less than 3 mm. This patient presented to us with stridor in emergency. This is another lady without any compression. However, there is significant deviation of the trachea on the opposite side. In this lady also, there is enlargement of the glands and there is tracheal compression. So now coming to the treatment, surgery is the treatment of choice. There is not much role of medical management when we have retrosternal goiter in the form of suppressive therapy or radioiodine ablation. So indication of surgery is when we diagnose this patient is having retrosternal goiter, whether the patient is asymptomatic, then also the surgery is advisable. As delay in surgery may lead to acute airway obstruction, there is chances of malignancy. The grade of retrosternal goiter may change from grade 1 to 2 to 3. These patients subsequently may require sternotomy, which further increases the postoperative morbidity. So surgical approach can be cervical, which may need to be combined with partial or total sternotomy, depending on the grade of the retrosternal component or whether it is only primary retrosternal goiter. The extent is in the posterior mediastinum, width of the intrathoracic component of the goiter, whether it is more than the thoracic inlet. If the patient is having malignant changes involving the trachea and the major vessels, and the density of the retrosternal goiter, which is an independent risk factor which indirectly suggests that there may be malignancy in the retrosternal component of the thyroid. So the anesthetic concerns are airway, whether the patient needs sternotomy, status of the major vessels or trachea involvement, especially in cases of malignancy, and to take care of the to predict post-operative complications in the form of tracheomalacia or requirement of the mechanical ventilation. So the preoperative anesthetic assessment includes the detailed airway examination. Patient should be in the euthyroid state, and if there is any associated major pre-existing comorbidity in that patient. Majority of the benign retrosternal goiter, despite of having significant deviation and compression, it is possible to intubate them with the normal size tube because this deformity is not fixed. However, the plan for the awake intubation, fiber optic intubation, and the to avoid muscle relaxation should be kept in mind depending on the airway condition of that particular patient. So the backup arrangement plan A and B need to be there for each and every patient. So the important steps for thyroidectomy are there should be liberal incision in the neck. We should have adequate mobilization of the muscle, and we should ligate the pedicle and identify the parathyroid and recurrent laryngeal nerve so that we keep our dissection plane anterior to the nerve and can avoid the injury. I will come to the major complication. Our dissection should be kept as meticulous as possible so that we can avoid bleeding intraoperatively and which will reflect to the postoperative course also. If there is adequate hemostasis at the time of surgery, unlikely to have postoperative bleeding, hematoma, or any other complication related to that. And tracheomalacia, the tracheal assessment to be done on table. And we should avoid injury to the recurrent laryngeal nerve and hypoparathyroidism. So the take-home message is surgery is the treatment of choice, And surgical approach is mainly determined by the extent of the goiter into the mediastinum, whether it is benign or malignant. Airway management is very important, and we should have the proper hemostasis and preserve the RLN and parathyroid. Thank you.
Thank you, Dr. Divya. And now we go to the next session. By Dr. Dalapan, surgical surprises during thyroid.
Good afternoon. For the next 8 minutes, we'll rush through slides which are have encountered over the period of time. Before going to it, must remember this gentleman who is the father of our modern thyroid surgery and who has revolutionized it. So surgical importance wise, we are concerned about nerves, parathyroids, ligament of Berry, tubercle of Zucker-Candle, and the embryological rest like pyramidal lobe and thyrotemic thyroid rest. So we'll see certain aspects which we have encountered over the period. So as we know, the nerve can be a single one, or we can have 2 branches in the rectolaryngeal nerve, or we can have 3 branches also. This we have to anticipate that. And this is one we can see not only 2 branch, it actually divides, again rejoins, divides, and again rejoins. This we encountered 3 months back. It's a case of a neurofibromatosis patient where this I could not find any references for this branching and again rejoining of the rectolaryngeal nerve in this, but it was not anastomosis with the EBSLN or like the Gallen's anastomosis. So as we know, this right side non-recurrent nerve has to be kept in mind, which we have around 15 cases we have encountered till now, this non-recurrent nerve. So we have even published this. Another thing, coming out of the embryological rest, we have to be prepared to see the pyramidal lobe, the tubercle of Zucker-Candle, and the thyrotemic thyroid rest. So which can be in this, we can see all the 3 components. So if one is there, the possibility of the other component is to the tune of around 25 to 50%. So that we need to keep in mind while we operate. So this had all the 3 in this. So this is one case which really surprised. It was operated as taken up as a case of a retrosternal goiter on the right side, but intraoperatively we could still see the retrosternal goiter, but it was not the lower lobe of the thyroid, but the tubercle of Zucker-Candle. So this the tubercle of Zucker-Candle which was going as a retrosternal thing. So this is the giant tubercle of Zucker-Candle which was on the right side, which we also published this episode. So this is another patient, as previous speaker has told, there can be respiratory distress who can come in the emergency. You can see the endotracheal tube there. This is due to the retrosternal part which is wedged between the manubrium sternae and the vertebra. So once we removed this, then the patient went home normally. So in case of this retrosternal goiters, especially the thyrotemic thyroid rest, there can be thyrotemic thyroid rest which can be independent or separate from that in spite of a retrosternal goiter, which we can see in this case. This retrosternal aspect of the thyrotemic thyroid rest, which was retrosternal. Along below that, another again remnant was also there, which we must not miss. So this can need to be seen in entirety. So this is retrosternal. Here also you can see retrosternal goiter on the left side. Right side, there was no connection, but there was fibrous tissue was attached on the right side, which we need to be aware of that. So this is another case where you can have both the retrosternal part from the lobe as well as the thyrotemic thyroid attached. So this is another case of where you can have which is separate from the thyroid gland. So this requires a sternotomy. This is one case which I need to discuss. One patient underwent a total thyroidectomy and a post-op and a histopathology of the papillary thyroid carcinoma. But off eltroxin, the patient was kept for a month, but the TSH was not rising. It was still normal. It was around 2 and 3. We repeated in 4 5 labs, but still it was the same. So we are not sure what is to be done. Then again, we went to do a scintigraphy, that is thyroid scintigraphy. Then we found a separate thyrothermic thyroid rest on the right side, right thorax. So which was previously actually thyroidectomy as well as neck dissection was also done. So you can see this this is the thyroid scintigraphy which was done after 1.5 months after surgery, which was separate from the thyroid gland as well as the nodes which was we removed. So the TSH was not rising. So again, we need to go again and do a thoracotomy. Post-operative thoracotomy was done to remove this thyrothermic thyroid rest. So we have published this around 1,118 thyroidectomies, the implications of these embryological rests, and majority had a thyrothermic thyroid rest, which we consider as these retrosternal goiters. So this is another case of it's not a surprise, but we know that there is a hemiagenesis. Just want to show that it's a hemiagenesis of the left lobe, which is not uncommon. So this is another doctor's mother who presented to us with in an emergency with sudden pain and breathlessness. So the patient was taken up for surgery immediately and found the intra tumor. There was a cyst. It was a cyst. The hemorrhage was there, which was causing compression and pain. So once it was operated, she was relieved of that. This is another interesting case where the FNAC was inconclusive, only hemorrhage was there. Ultrasound, they could not, it was done outside, so they could not say whether they told it's a left salty thyroid nodule, but on opening it was, the thyroid was normal. There was a huge lipoma in the region of the thyroid, beneath the strap muscle, over the thyroid gland. So intrathyroidal parathyroidinomas are also we need to keep in mind, because it was done as a reoperative surgery. Previous parathyroidectomy was done, but the PTH level did not fall. So again, on exploration, we found a intrathyroidal parathyroid. This is another case where presented with a lymph nodal mass on the left side, and so we thought we planned for a FNAC was also showing malignant cells. So we thought of doing a thyroidectomy and a lymph node dissection, but on opening we found that it was not a lymph nodal mass, but a tumor thrombus from the thyroid gland, which was going into the internal jugular vein. So it was a tumor thrombus. You can see this, the tumor thrombus, which was shown as a lymph node. So need to be aware of this also. So this is due to local treatment. This is a foreign patient who came, local treatment on this, and she had a TTR. This is not a surprise, known case only. So this is another case which was present as a parathyroid tumor on the left side, the retrosternal parathyroid tumor, but PTH was also high, calcium was also high, but on opening, this was done 2 weeks back, but it was not a parathyroid which was going retrosternal. It was a thyrothermic thyroid rest which was shown, and the parathyroid was on the opposite side. Sorry, actually, just missed. Actually, there is some confusion. I will show it later. So this is an amyloid goiter, which I have encountered only once. This is a amyloidosis of the goiter. So this is another case of like parathyroidomatosis. This is thyromatosis of the from the papillary thyroid carcinoma, which was operated some 10 years back. So she presented with a nodule in the skin. So we removed. This was purely in the subcutaneous plane. You can see here it's in the subcutaneous plane. So we removed it, and it was separate from the thing. So thyromatosis can also occur, but it was not malignant. It was only a thyroid tissue which was in the subcutaneous tissue plane. You can see this. So this is another case of a tumor thrombus which was extending into the right atrium. So with the cardiothoracic surgeon, we had to open it, and the tumor thrombus was into the right atrium, which the patient has completed around 10 years of follow-up. The histopathology was a follicular carcinoma. Thank you very much.
Good afternoon, everyone. At the outset, I'd like to thank Professor Gaurav sir, Anjali ma'am, Gyanjan sir, Dr. Sabha, and the SGPGI for having invited me to this prestigious event. Always a pleasure to come to SGPGI. Greetings from my institute, St. John's Medical College. So, difficult airway in large goiters. It's a little bit of a difficult topic that has been given. So how does one manage difficult airways in large goiters? Call anesthesia. What is the surgeon doing here? Anyway, it always helps us to understand more so that we can explain the patient better, because the anesthetist will be in charge of the patient on table, but we are the people who are responsible. We are the front of the patient. So a little anecdote here. We were doing a reoperative parathyroidectomy, a failed exploration elsewhere, and this parathyroid was on the right side. It was going into the tracheoesophageal groove. It was going quite deep. We had done the dissection, and we had to resect a little bit of the esophageal musculature also along with the parathyroid. We don't want to leave back hyperfunctioning parathyroid tissue in the body. And then the esophageal muscle was repaired. And when I had completed my repair, my anesthetist suddenly said, "Sir, the patient is not. We are not able to oxygenate the patient. Can you check what has happened?" And then we said they tried to take out the, they tried to do something with the endotracheal tube, and they were worried whether there was some problem with the ventilation. And when they tried to pull it out, they were not able to. And then we found out that in repairing the esophagus, the needle has gone through the balloon of the endotracheal tube, and thereby puncturing the balloon, and thereby causing a small 3-4 drops of blood had gone in, and the patient had aspirated. And this was the cause why the patient was hypopatulated. So then we took down the repair again, and then they put a bougie, and then they took the T-tube out, and the endotracheal tube out. They re-intubated the patient, went back under anesthesia. Then we went ahead with the repair. Further period was uneventful. We had to keep the patient in the ICU for a couple of days, and then we discharged the patient. Patient went home smiling. So this background, a little bit of stuff about what is a difficult airway, what are large goiters, what are the difficulties that we might face. How do we manage intra-op? The anesthetist manages intra-op, and we preside over it. What about difficult extubation? So by definition, as per the American Society of Anesthesiologists, it is in which anticipated or unanticipated difficulty or failure is experienced by an anesthesiologist in either of the following: ventilation, laryngoscopy, or ventilation using special techniques, tracheal intubation or extubation. A large goiter, by definition, is a goiter of at least 10 grams per kg body weight of the patient, or a thyroid tumor larger than 10 centimeters. WHO has categorized it according to its inspection and palpatory findings. And there's also been categorization in terms of weight. And I'm happy to quote my senior friends, Dr. Sudhi and Dr. Pradeep here at this juncture. So the patient will come with classic pressure symptoms, respiratory distress, sometimes hot potato voice. There can be tracheal deviation, of course, compression, cricopharyngeal compression. There will be edema of the glottic aperture, edema of the larynx, edema of the pharynx as well, depending on how big the goiter is. There will be there might be tracheoesophageal involvement, which might require complex resection procedures. There might be an obstructive sleep apnea-like picture owing to the respiratory distress. And nowadays, with the advent of transoral surgeries, that's another thing where there's a lot of expertise needed from the anesthesiologist side in order to achieve successful intubation and anesthesia management. So they go about with a difficult airway cart, which involves special equipment, including laryngeal mask airways, the fiber optic scope, They generally take scopes and ET tubes which are 1 to 2 sizes smaller than what is required in order to be able to negotiate the difficult and key trachea. Sometimes they are always ready to anticipate thyroid storms. They keep a lot of cold saline infusions ready and various agents that block the thyroid synthesis and action at various points. 1 unit of cross-match pack cells also to be arranged. So these are all the things that are advised to be kept as part of the anesthesia cart in difficult intubations. So they induce the patient in the semi-supine or sitting position as against the routine supine position. And they advise appropriate pre-medications to lessen secretions because already the path is difficult and we don't want rain on the path. Inhalation induction preferred over intravenous. If there is obstructive sleep apnea, they prefer awake intubation in patients. They always advise pre-oxygenation with 100% oxygen, so that that gives some more time because the anesthesia will be a little, the induction will be a little more long drawn compared to normal cases. Various induction agents of choice depending on the way they alter the physiology. Airway adjuncts such as nasopharyngeal area of correct size. Sometimes they keep it. And then fiber optic intubation is also useful in laryngeal displacement. In patients with striders, sometimes there can be bilateral glottic compression with striders. The patients come with striders. And then an insertion of metallic bronchoscope might help. Sometimes it might induce airway obstruction. So it's better to use fiber optic thinner intubation scopes. Sometimes ventilation through a rigid bronchoscope may be necessary if conventional attempts fail. Whatever is used, all the equipment must be checked and the surgeon must be available stat in order to do a tracheostomy if and when required. And then when they do put the tube inside, they ensure that the bevel of the tube is beyond the point of tracheal narrowing. Invariably, the narrowing is a point narrowing, it's not a segment. Sometimes during surgery, we will be manipulating on the thyroid, unmindful of what is happening inside. When we may compress the trachea, that may cause asphyxiation as well. So they generally put the tube as far distal as they are comfortable, and then they draw the tube to as much proximal as they feel is fit. It also prevents auto-extubation during positioning because we position the patient, we manipulate the neck after the tube is inside the neck. And for transoral surgeries, we require nasotracheal tube placement. That's another technique that is not straightforward. The various tubes, ET tubes that they prefer, the armored tube or the reinforced tube. Sometimes they use the North Pole oral tracheal tubes. That's the north facing. It's kinked up so that it's facing upstairs, the heavens. Of course, with the intraoperative nerve monitoring, the separate endotracheal tubes equipped with nerve monitors, so they have to be conversant with usage of these. And then for maintenance, they prefer short-acting opioids. They prefer various drugs which reduce the opioid requirement. Various relaxants preferred with respect to their physical properties. There's always risk to airway because of the surgeon's actions, especially at the head end, because that's where we stand, and we have to be mindful, especially the person who stands at the head end is generally the junior most in the team, and the one who is least conversant with all these things, who doesn't bother much about these things. So we'll have to tell them, we have to be mindful of that. At the end of the procedure, we always do a Valsalva maneuver. We request them to do a Valsalva maneuver so that we can check for bleeding. And then we always a good policy to identify the nerves on table and then inform the anesthetist, call them over and show them that it's been preserved. Patient should be recovered sitting upright as much as possible. And they always perform the cuff leak test, especially in bilateral large goiters. They deflate the cuff and look for peritubal leak. And if leak is not there, they sort of assume that it might be a tracheomalacia. They'll do elective extubation later. What to do in bilateral nerve injury? There's unopposed adduction of vocal cords, and the glottis assumes a cadaveric position. And sometimes it is made out at the time of extubation. The patient has to be re-intubated stat with a smaller tube. And once the patient wakes up and starts breathing, they should be reassured and then shifted to the ICU, and then a trial extubation at least after 48 hours. And there have been reports where this leak test has been negative for up to a week after surgery. Generally, it recovers, it sort of comes back in 48 to 72 hours. If all fails, emergency tracheostomy. So long-standing large goiters with pressure symptoms might cause tracheomalacia, although thankfully we haven't encountered tracheomalacia per se as such in our practice yet. There's a paper from SGPGI over presenting their experience over 15 years, where they've shown about 20 to 22 cases of tracheomalacia, which they have had to encounter. Not yet for us, luckily, and hope not. So large goiters are challenges to anesthesia as well as surgery. The patient is preferred to be intubated awake. Airway adjuncts and specialized tubes, if required, can be used. Positioning the patient, we always have to be mindful of displacement of the connection. And while extubation, always do a leak test, awake extubation, and counseling before and after surgery is paramount. So this is a lady, a 71-year-old retired teacher who had a huge goiter extending all over the neck into the retrosternum. She had pulmonary hypertension, she had asthma, whole lot of conditions. And she's 6 months later, she's happy and smiling. Thank you very much.
Good afternoon, everyone. This topic is as complex as applying statistics to abstract things. So we all know that thyroid disease, especially benign ones, are very common. And we know that surgery can provide cure for symptomatic goiters. But often benign goiters without such evident symptoms like airway obstruction or esophageal compression are affecting quality of life of the patient, but they could be subtle. And they are chronic conditions. And there's a lot of overlap between thyroid diseases as such. So a goiter with hypothyroidism or a hyperthyroidism, and there is a shift between diseases. That means if we remove a goiter, patient goes into hypothyroidism and things like that. So for thyroid functional abnormalities, we know that if we correct the biochemical abnormalities, the patient's quality of life is going to improve. But do we know that without any of such functional abnormalities, just treating the goiter itself without symptoms, is it going to impact the quality of life? So the best person to tell whether the quality of life has improved or not is the patient himself. But to assess that is a very big challenge. And they are rarely life-threatening. Benign goiters. So it becomes especially important that we understand that it is going to give the patient a good quality of life after the treatment. So there are a lot of lacunae in the scientific evidence as far as the management of benign goiters is concerned. I'll just straight away dive into the quality of life issue. So what is WHO's definition of quality of life? Is an individual's perception of their position in life in the context of the culture and the value systems that they live in. But for us physicians, more relevant is health-related quality of life, which is the way in which the disease and its treatment are going to affect the individual patient in physical, emotional, and social well-being parameters. So it's a subjective measure. Then how to measure patient subjective measure by us? So that's where the role of questionnaire comes. So we are going to ask few questions, get answers, but it's a challenge to understand which questions to ask also. So we have generic questionnaires, health-related quality of life questions, and we have disease-specific. So it's very obvious that disease-specific are better. So in general, we have some guidelines laid down by US FDA and other bodies to understand how to go about developing questionnaires. So you all can refer to US FDA website to understand how the questionnaires are developed. It should be a multi-item scale with content validity. That means ask relevant questions, ask in a way that the answers are going to be answered in the way that it is relevant to the question asked, and there should be sensitivity, responsiveness, and reliability. That means if the questionnaire is repeatedly used, it should yield the answers in a similar way, and it should be sensitive also to measure what it is intended to measure. So for thyroid, malignant disease, and for benign disease, there are different questionnaires. For the current topic, I'll stick to benign thyroid specific questionnaires. There are many. The four of these are listed here, out of which ThyPro and ThyPro 39 are the well validated ones. So coming to ThyPro, Thy is thyroid, stands for thyroid, and PRO is patient reported outcome, which is the term that is being used for health-related quality of life these days. This was developed extensively after extensive research by the team from Denmark, Dr. Watt. The work had started way back in 2006, and the work is still ongoing. The first questionnaire was published in around 2009 to 10, and then the questionnaire started being used in other parts of the country since 2012. So this is a specific health related quality of life questionnaire for benign thyroid goiters. It has 85 items, and later it has been abbreviated to 39 items, and that's called as Thypro 39, because obviously the evaluation time was about 15 minutes with Thypro and is about only 4 minutes with Thypro 39. And it's been later translated into many languages, into Hindi by SGPGI, Professor Anjali's team, and into Tamil by the group from CMC. So it was not easy to develop this questionnaire. They had to first generate an issue, as in what all parameters they had to look to incorporate into the questionnaire, and then they had to prepare a questionnaire based on those observations, and then they had to test it with cognitive interviewing technique, and then there was a validated questionnaire to use in scientific studies. So it has various scales, almost 13 of them, measuring physical, mental, functional, social well-being, and participation, social functional participation. And each item is reported by the patients on a Likert scale. So I'm not going to dive into the details. These are available online. I mean, not really available online, but you can write to the Dr. Watt to get the exact questionnaire, but it has been used with his permission at multiple places in various studies. So Thypro 39 is for convenience, and the method that they have used is graded item response therapy to choose which ones to bring to the abbreviated form. Now, coming to the questions that we all want to understand is actually surgery or treatment of benign goiters improve quality of life. I would say that the answer is not simple. There are not enough studies. The literature is sparse. I'll begin with one of the first studies that is published, evaluating quality of life in benign goiters, published from SGPGI. From this study, we understand that not just the treatment of functional abnormalities, just removal of the goiter itself has improvement in quality of life in the patients. And on multivariate analysis, the factors that were associated with improvement in different domains were younger age and female gender and larger weight of the goiter. So here, the highlights of this study were, as I was saying, this is one of the few first studies which evaluated goiter itself. That means the patients were biochemically euthyroid when the first time the questionnaire was put to the patient. And then, so that means that we are ruling out the functional abnormalities. And then the post-operative outcomes were measured. So in that way, the study was carried out. And in this study, the most significant improvement was seen in the vitality scale part of the questionnaire. But the reason is very difficult to explain. Then another study was published in 2020, comparing endoscopic versus conventional thyroid surgery using Thypro Hindi, not 39, Thypro Hindi. And so in this study also, in all the parameters, the endoscopic patients who underwent endoscopic surgery had better improvement in quality of life. And another study published from Australia has also shown that surgery for benign euthyroid goiters has improvement in quality of life. But these are prospective observational studies and cohort studies. And a study published, all these still now have used Thypro. A study published from Germany, from the Department of Visceral Surgery, has used EuroQL5D. It's a generic questionnaire. They have seen that only 86% patients had either improvement or no change in quality of life. In fact, 14% of them had a deteriorated quality of life at 1 year. But the limitations of this study was it was a generic questionnaire and it was not validated for thyroid clinical studies. And the latest publication is from the CMC group, evaluating the same impact of surgery in the quality of life in benign goiters. So they used Thypro Tamil and Hindi. Here as well, there was a significant improvement in the quality of life and in most of the domains except for psychological well-being. But the reason obviously is a very abstract thing and subjective. So it was not explained by the data itself. And again, in this study, younger age, female gender, and the duration of goiter were the significant factors that affected the outcomes in various domains. So what evidence do we need in terms of quality of life from future studies is, so there are many more potential benefits by removing enlarged goiters. So we only are looking at T3, T4, TSH and just imagining that that is the only thing that needs to be corrected, or maybe physically the obstruction has to be removed. But there are subtle things. Maybe if patient sleep apnea syndrome is improved and that has effect on its social well-being as well as family life and all that. So those areas also have to be explored. And the swallowing perception of the patient, this is another area which can be a focus of studies in the future. And of course, we need more studies evaluating quality of life, endoscopic versus conventional, use of various energy devices, and across various age groups, gender, socioeconomic status, and all these things. So in other words, the data for quality of life studies is very poor, and we need more questionnaires, more tailored questionnaires, and more studies. Thank you.
Good afternoon, everybody. I'd like to thank the organizing team for giving me this opportunity to speak on planning thyroidectomy. Whenever you do something, you do it 2 times. Once it is in your mind, and the second time it is in the real world. So this topic, planning thyroidectomy, when you say that I am going to talk about the first time when you are doing, that is doing it in your mind. So when you're doing thyroidectomy, what are the things that should be going in your mind? If you're in a OPD, you may be seeing patients like this. Your boss would say, plan this patient for a thyroidectomy. A lady who is almost 85 years old with a pacemaker and having a huge gland with obstructive symptom, or you may have a patient who is staring at you with a Graves' disease, or an old lady with a malignancy, or a pregnant lady who's recently delivered and has a sudden increase in size and it's found to be a PTC, or a male patient. So I'm going to tell you how do you plan, like, you can fit in for all these cases. Okay, so like, the speaker just before me said there was an emergency, there was bleed within the gland. It could be rare situations where you have to do thyroidectomy as an emergency, but it's, most of the time it's an elective surgery. So planning has to be done properly so that you don't have problems when you are doing it actually. Okay, so the first thing is evaluation of the cardiac risk and the perioperative pulmonary risk. Check all the lab test, pre-op imaging, laryngeal exam for all the patients. Go back again and see the thyroid scoring which was done. Check for the lateral neck, the central compartment, all those areas again. And if it's an advanced disease, look into the CT scan carefully, whether it is an invasive disease or a multiple, has a multiple nodes, extrathyroidal, retrosternal, all those things. Again, go and check. In the lab test, check for the TSH again. Check for the serum, check for any parathyroid, concomitant parathyroid disorder, suspecting MTC, whether calcitonin was done, what is the range. After you do all this, the most important thing in the imaging, in the investigation is the imaging. See, when you do a CT scan, you do CT scan in 3 planes, that is axial, coronal, and sagittal. And what you do is you operate the patient in your mind in the fourth dimension. That is, write the entire steps even before the patient is on the table. Write all the steps from the skin to the closure, looking at the scan, seeing whether it is involving what is the status of the trachea, what is the status of the tracheoesophageal groove, the lymph node status, everything you study on the scan, write the steps before you even touch the patient. That's called as a mapping of the disease and doing the surgery even before the patient is on the table. The second thing is, in this scan, you can see something called as a R scoring. R scoring is done for recurrent laryngeal nerve. Okay, so there is R0, R1, and R2. R0 means there is no disease in the tracheoesophageal groove, and the recurrent laryngeal nerve on examination has a good mobility. R1 is good mobility on laryngoscopy, but there is disease in the tracheoesophageal groove. Now, this set of patients, it's important when you are consenting, because on the table you may find it infiltration, but the nerve would be mobile. And R2 is when there is, paralyzed cord plus you have a growth. Here in this scan, you can see there is growth in the tracheoesophageal infiltration, but this patient's vocal cords were preserved. They were working well. Why do you need to do a scan? Especially, why do you need to do a laryngoscopy in pre-op setting? It's important to check for any occult recurrent laryngeal nerve palsy. Now, what happens if it's a slow-growing tumor? It may slowly compress the nerve, cause a paresis first, followed by a paralysis. So the opposite side cord has enough time to compensate, and there may not be a frank change in voice. Around 10 to 12% of patients may have such issues. So it's always good to get a laryngoscopy done. This can be even done with an ultrasound. Okay. And we have done a study where we could even pick up small vocal nodules, polyps, and paralysis, of course, by just using the ultrasound probe when you're doing a thyroid scan. Listen to the patient's voice. If he has a breathy voice like this, his voice is like this. This is a breathy voice which tells you there is a paralysis. See this in a post-op setting also. Whether you have paralyzed the cord and is there a change in voice, you don't need a laryngoscopy all the time. And if the patient is hyperthyroid, medical optimization, check whether it is adequately done. The day of surgery, the pre-op, you need to give the antithyroid medications, beta blocker, aim for the 90, pulse less than 90, and lugolcidine for reducing the vascularity. Check the pre-op vitamin D, calcium. And patients who have had a gastric bypass, they have increased risk of developing recalcitrant hypocalcemia. So these things needs to be taken into consideration. What about reoperative thyroid surgery? How do you plan? What are the issues there? If one or more thyroidectomies, thyroid surgeries have been done in the neck, they are at special risk of developing all the complications. Patients who have had cervical spine surgery, especially the anterior approach, or a parathyroid, or even a simple tracheostomy at some point, or a carotid endarterectomy, they are all will be the injury to the recurrent laryngeal nerve and hypoparathyroidism would be high in these patients. So in the operative management, give antibiotic and antiemetic DEXA. DEXA also helps in the paresis if there is any handling of recurrent laryngeal nerve on the table, and even the hypopara. Ambulate as early as possible post-op period, and the anesthesia discuss with the patient with the anesthetist. The anesthesia they are planning to give, whether they are going to give you a oral intubation or a nasal intubation, depending on the approach that you are planning. All the other things was discussed by the previous, the incision and all those things have been discussed. Now, whenever there is suspicion of parathyroid vascularity getting compromised, it's always good to do an auto transplantation into the same side strap muscles. So plan all these things in advance, and on the table, frozen section is rarely needed, only if it is, if you had a suspicious cytology and you want to confirm, or if there is a metastatic node, you want to, decide on the level of dissection, or if there is a parathyroid which is suspicious. Drains are not routinely used unless there is a large goiter or extensive dissection has been done and there is, some kind of a oozing. Pain control, discuss about the pain control, the thyroid hormone replacement that is required in a benign and a malignant. Have these plans all beforehand only. Okay, now this is something which I want to introduce to this group. The Kuma Hospital in Japan, they have brought out this thyroid navigator, which we find it very useful, and it's available free of cost on the iOS. So this gives you an idea how to take a consent. You press hemithyroidectomy, it will automatically show the half side of the gland gone. It shows the recurrent laryngeal nerves, the parathyroids. You press the various diseases. And diffuse nodular goiter, it would show you, pictorially. Diffuse nodular goiter, a cancer, you show papillary thyroid cancer, it will show you how a cancer looks like, how it infiltrates. The advanced disease. So it is very useful to explain to the patient's relatives in the planning stage only. And we have a checklist which is useful. We follow this checklist, and that helps us to keep things planned. So two things I would like to tell through this lecture. One is read the CT scan. Do the surgery in your mind even before you take the patient to the table. Write the entire steps on a piece of paper. We ask usually our residents to do that. And this thyroid navigator, which helps you to take a good consent in the planning stage. This is the World Congress on Thyroid Cancer, which is coming up in 2025. Thank you.
Thank you, organizers, for giving us this opportunity.
Thank you to all the moderators. We now move on to our next session, which is an invited lecture. May I call upon the moderators for the next session onto the dais, please? Dr. Chandan Kumar Jha and Dr. Brijesh Kumar Singh, sir. I may request the moderators to kindly call the speaker on stage.
Medical oncology in thyroid cancer, I would invite Mr. Anjali Krishna, Dr. Mike Teacher. Not much of an introduction. This topic is usually something we would have wanted somebody like him to speak about, and it is my good fortune that I will be listening to that for next 2 minutes.
Thank you, Chandan. Thank you for the kind introduction. And in fact, I was telling Sabha that we are running behind schedule. We could have all together skipped it, but you have to bear with me. So what I would say that all of us, we know that thyroid cancer incidence is increasing with rapid and alarming proportion. But the good news is that it still continues to carry a very low mortality rate. However, we do come across in 10 to 15% cases some aggressive form of cancer which need treatment which is different from what the garden variety of the malignancy. And I would say that I was given task to speak something on targeted therapy, mainly tyrosine kinase inhibitor. And this is a subset of precision medicine, with the term which is much in vogue in today. And I would say that thyroid cancer is a classic example where this modality should be applied to the maximum. The very reason being is that it is a small gland, but it contains so many diverse variety of malignancy and was aptly presented in today's endopathology session in morning. So this is not the current classification of thyroid cancer, but if just to put the things in perspective, if you look at thyroid cells, there are two cells basically, and different variety of malignancy arising from those. A minuscule proportion from parafollicular cells, which is medullary thyroid cancer, and from thyroid follicular cells, we could have DTC. Again, I would say this is as per older classification, and just to initiate the topic. Within differentiated thyroid cancer, we could have PTC and FTC. Then in between, we have poorly differentiated thyroid cancer, and recently introduced term high-grade differentiated thyroid cancer. And at the other spectrum, we have undifferentiated or anaplastic thyroid cancer. So if we have to understand how these molecular targeted therapy work, we have to go into the some embryological part or some basic molecular pathway route. So if you look at this thing, that mature thyroid cells arise from thyroid stem cell, and then in quick succession, those are turned into thyroblasts, prothyrocytes, and then thyrocytes. And if you look at this diagram, so at every stage, there are some genes involved. And when these genes are getting mutated, then we are getting malignant transformation of these cells. And at the end of the day, when there is combination of mutation, we get anaplastic thyroid carcinoma. So what are the basic thyroid cancer signaling pathways which are deriving and these malignancy? Basically, there are many, but there are two major pathways.
One is mitogen activated protein kinase signaling pathways, and other is PKI3 AKT pathway. And if we look at these pathways, so in this upstream of both these pathways is where tyrosine kinase receptors are there, and they are major activator of these pathways. So however, if you look at this MAK pathway, then major other constituents are BRAF, RET-PTC, and on the other hand, EGFR and HER2. So having said that, but we don't see a mutation very routinely in thyroid cancer as opposed to other cancers. Whatever mutations are there, those are not genetic, particularly in differentiated thyroid cancer group. The most of the mutations are somatically acquired, meaning thereby those are not germline mutations. So what are these common mutations? So here I have listed some mutation. One of them, the most common, is BRAF, so much so that as of now it is used as diagnosis of PTC. However, it is one of the great therapeutic targets. Then so far as RAS is concerned, those are mostly associated with follicular thyroid carcinoma. Then RET-PTC arrangements, again, papillary thyroid carcinoma, PAX-PPAR gamma, again, follicular variety. Then there are TERT mutations, which are mostly seen in, PTC. And other mutations are like PTN, these are kind of suppressor mutations, and they have different role to play. In medullary thyroid carcinoma, we know that 20 to 30% patients have germline mutation, but it's very important to remember, even in this thing, sporadic medullary thyroid carcinoma, up to 60 to 70% of patients have somatic RET mutations. So it also has a therapeutic implication. So there comes the role of this precision medicine. So I'm not going into the detail of this part because this was already covered in our morning session. But suffice here to say, if we look at this pictogram, then we can see that one mutation is present, like BRAF is encountered in so many types of malignancy, and one malignancy could contain different kind of mutation. So the most important part to remember, as we know that these are multigenic phenomenon, and we cannot cure or even intend to stabilize these cancers by hitting only one pathway. There could be some diagnostic implication of these gene combination, but I'm skipping that and I'm coming to the topic assigned to me directly, that is molecular and targeted therapy. So if you look in the whole scheme of thing, as I said, that 85% of the cancer would be taken care of with surgery and adjuvant therapy, and I should say that we have a really very good targeted therapy over there, which has been available to us for, I think, so many decades, and that is radioiodine therapy, which specifically targets the thyroid cells. And there is a very small role for other targeted molecules in radioiodine refractory cases or anaplastic thyroid cancer cases or medullary thyroid cancer, which are radiorefractory by nature. So I just mentioned that one of the greatest targeted therapy available, that is radioiodine therapy, and in this modality, now we have one more addition, that is TRRT, in form of which we can deliver via DOTANOC or DOTATAT. So how do we approach a molecular targeted therapy? As we know that cancer cells, the survival is dependent on one side, decrease apoptosis, and on other side, there is increased proliferation. So by hitting these molecules, our attempt is to inhibit cell signaling and angiogenesis, thereby reducing the bulk of the tumor. And one other mode could be that we could induce de-differentiation into the cells so that our good old target could again work, that is radioiodine therapy. So I will just again go back to the same slide and just to remind what are the potential targets. In fact, this is slightly older target because as of now we know that we already have some of the targets in the market, like for mTOR we have everolimus. But important thing to look here is that one target could be hit by more than one molecule, and one molecule could hit more than one target. So this is for MTC. Here also there are tyrosine kinase receptors over there, EGFR, RET, MET, KIT, VGFR. And the important thing down the line is when we reach the stage of RAS, there is convergence of MAK pathway and PIK3 pathways. And one interesting emerging area is which I would briefly touch upon later, that is immune checkpoint inhibitors. So as I was telling, just we can see here that one tyrosine kinase inhibitor could target so many targets, including VEGFR, RET, and so on and so forth. And there are only few tyrosine kinase inhibitors which are really selective. So far as thyroid cancers are concerned, I think just to remind all the students that these therapies are not very old, and the first paper was published in 2014. That was a decision trial where we came across this molecule sorafenib. And if you look at the result of that trial, 417 patients were treated sorafenib versus placebo, and the difference in the progression-free survival was only 5 months. The same was after a couple of years, we got another molecule that in form of lenvatinib, and for MTC, we got cabozantinib and vandetanib. So if we look summary of all these trials, so just concentrate on the fourth column. So overall response rate is to the tune of, I would say 30 to 30%. And mind it, there is no complete response. Most of the cases, the disease is either responding partially or it is just a stable disease. So when we are treating with this, these molecules, we should remember we are not looking at cure. Then, as I was telling, that this is kind of still in imagination, that we could probably able to redifferentiate the undifferentiated cell, and some of these have been tried by our nuclear medicine colleagues in form of retinoids. And so far as gene therapy with NISP53 is concerned, those have been still remaining in the bedside medicine only. So, but there has been some progress so far as redifferentiation is coming. And selumetinib is one of the molecules which has been said to reinstate some redifferentiation into the thyroid cells, and they become somewhat or they acquire radioiodine avidity after the treatment. But overall, the newest exciting molecule, if you look at this, those are very much targeted to BRAF, and two of them is vemurafenib and darafenib, and it is very heartening to know that so far as undifferentiated thyroid cancers are concerned, dabrafenib and temritinib combination has been approved by FDA, and it shows some promise. And as I was telling, this is one exciting area, and like we are seeing in breast cancer, PDL1 and PD, programmed cell ligands, these are one important target for targeted therapy, and we already have some clinical trials undergoing as of now with limited success. And this is last but not the least, since Sabha has added taxanes also. So here I would say that role of chemotherapy as such is very limited in thyroid cancer, and it is limited to very rapidly advancing radioiodine refractory thyroid cancer, but it does have some role in undifferentiated cancers. And usually taxanes are used in the combination of with anthracyclines and platinum. However, there have been some recent small studies where weekly paclitaxel has shown some great response, I would say, so far as anaplastic thyroid carcinoma is concerned. Even couple month survival is considered significant. So I would conclude my talk by saying that precision medicine still has a lot of untapped potential in management of thyroid cancer, and with ever increasing understanding of genetic events, we can expect immense impact on diagnosis, therapy, prognostication, and ultimately clinical outcome of differentiated thyroid cancer. So thank you very much, ladies and gentlemen. And I think Sabha, I did not disappoint Sabha, and I kept my promise that I will finish within 10 minutes. Thank you.
There are any questions?
No, not yet. In fact, this thing for now this issue is settled, but for last couple of years there was some issue with our ethical committee, mainly relating to insurance of the patient. So, but that has gradually been settled down, and we hope that in future we would be able to induct some patients. But most of the clinical trials were halted in last couple of years.
One question from my side.
Yeah.
Will you consider PGES for an operable but difficult thyroid cancer to make it easy?
Yeah, that is very good question. I would say operable, no. If I can operate it, I will go ahead and operate it. But yeah, if there is something, in fact, we have recently published a case report in, I think, Indian Journal of Surgery. But if it is locally advanced and we think that there could be vascular involvement, then we have tried in some cases. And with, I would say, with reasonable good success. Like I had one case where this thing carotid was completely encased. Unfortunately, that patient came during COVID. We put him message, no immediate surgery dates were available. So we put him on sorafenib and he responded nicely. We could take out the thyroid in toto, but unfortunately, because since it was quite rapidly growing tumor, by the time that patient reached for radioiodine scan and therapy, he had already developed pulmonary metastasis. But so far as their indication in neoadjuvant setting, basically this is a neoadjuvant setting, I think there is some promise in cases of locally infiltrative disease. But we, as of now, have limited experience. I have couple of such cases, 4 or 5, and as a department whole also, I think not more than 10. But CMC Vellore also published one such case, and they did it with medullary thyroid cancer, and Dr. Deepak very fondly presented that case sometimes. None. Because the thing which this thing, as I said, there is these targeted therapies are still not targeted. The side there are a lot of side effects. In fact, majority of our patients cannot tolerate the standard prescribed dose of sorafenib, which is 400 milligram BD. I have yet to see a patient who can this thing continue on this dose even for a month. So there is no, as such, if you look any standard guidelines, they say even patient is having metastasis, you need not to start it unless the metastases are progressive or patient becomes symptomatic. No, usually this thing we don't go. Like if you look at guideline, they say if by RECIST criteria there is progression, meaning that by there is 30% increase in the largest diameter of the tumor, you should consider starting. But if you look like, if I'm looking at largest diameter of 7 millimeter metastasis in lung, it becomes 10 millimeter, doesn't make much difference unless patient is symptomatic. When I know this thing, definitely after starting, patient is going to be miserable, and we are deteriorating the patient's quality of life, and we are not adding anything to survival. Most of these patients come back with very severe bad hand-foot syndrome, And but what we have tried in this thing, advanced cases nowadays is we are trying to flip like sorafenib, 1 month sorafenib, 1 month lenvatinib, so that it balances the side effect of two drugs. But if the patient is asymptomatic, I would not, even if it shows progress on CT. And I think you are also privy to some patients who have been coming regularly. And when we discuss it, the patient themselves say, no, we would like to wait.
Ma'am, one question. PPRT and PPI both are at level.
So PPRT, like somatostatin receptors, are generally present only in MTC. So that therapy is usually considered in the background of MTC only, though that this thing, Dr. Bal from All India Institute of Medical Sciences has very large series published wherein he has showed that somatostatin receptors are also present in differentiated thyroid cancer. But there we would not keep it as a primary option. Thank you.
Thank you for the wonderful lecture, ma'am. Thank you to the moderators for their precious time. Before we move on to the next session, we have two announcements to make. First, there are two goggles, 3D goggles missing. So please check, and if you find them, please kindly return them. And the second is all the presenters are kindly requested to submit their PowerPoint presentations with Dr. Spandana during the tea break. Our next session is an interesting session of debate. For this, I would like to call upon the moderators onto the dais, Professor A.K. Verma sir and Professor Ashish Parveez sir. I now request the moderators to kindly invite the speakers.
I request the moderators to kindly invite the speakers on stage.
Yeah, they are doing little hard job. I thought you would be inviting them. Yes. So we have debate on prophylactic central compartment neck dissection versus therapeutic central compartment neck dissection. We're going to have two people debating on this. Or would be Dr. Manish Kushal from Indore, and against would be Dr. Kushadra Gaurav from Lucknow. I request Dr. Manish to please come forward and make the case for to make case for prophylactic neck.
Good afternoon. So the topic for debate for I am speaking in favor of the prophylactic central compartment dissection in T2 papillary thyroid carcinoma. As we understand, the papillary carcinoma is a very good prognosis, and compared to the many malignancies, differentiated thyroid carcinoma, the prognosis is 5 years more than 90%. But the problem is the recurrence, and recurrence is 30% into the up to the age of 20 years of the initial diagnosis. And the recurrence is mostly in the cervical nodes and generally managed with the surgical resection. So these are the points we well know in the management of the differential thyroid carcinoma. And papillary thyroid carcinoma, 35% of the PTC patient presented with the macrometastasis, cervical lymph node metastasis, and 80% undetectable microscopic cervical lymph node metastasis. So presence of the macrometastatic nodal metastasis is an independent predictor of the recurrence, while the significance of the micrometastasis is still controversial. So once we, if we are talking about the central compartment dissection, we know where is the central compartment. It's a from the hyoid bone to the suprasternal notch. It includes the prelaryngeal nodes, paratracheal groups of lymph nodes. So why we should go central compartment lymph node dissection apart from the routine thyroidectomy? Because the limit.
1 second, we have to limit your talk in 5 minutes.
Yes, sir. 5 minutes.
The next person, 5 minutes, and 5 minutes for discussion.
Yes. So the limitation of the investigations of the ultrasound, it's a limit. It's a sensitive and specific test, but it's a very well detect the lateral nodes, but not central compartment nodes. If we suppose the sensitivity is 53%, specificity is 80%, and then the current era more use of the PET scan, the sensitivity is only 40%. So radiologically, it's very difficult to assess the central compartment preoperatively. So central compartment, if we are not routinely prophylactically, we not remove the recurrence lymph node, these metastases 30 to 70%. So prophylactic neck dissection, we should go. Why we should go? Because in experience hand, it's not it. Although it's definitely many persons, many surgeons condemn the prophylactic neck dissection because it's a lot of risk, because it's injured the parathyroid nerve. But in experience hand, it's a well, we can manage with. There are different guidelines, and Japanese guidelines is routinely advocated. European Thyroid Association not recommended, but other British and American recommended with the certain factors. In prophylactic thyroid neck dissection, central compartment neck dissection, a term athyroglobulin means you have to remove the central compartment lymph node precisely, prophylactically. The chances of the athyroglobulin is definitely there. So prophylactic central compartment node dissection is to avoid resurgery. And once, if you are not doing the prophylactic neck dissection, if patient may undergo for the resurgery, that will lead to more problem, and it's less likely to achieve a biochemical cure of disease of minority of the 25% of the patients. So this is one article. We have the role of prophylactic central compartment dissection, clinical note, N0 node. There are, in this article, there are the more studies in favor of the prophylactic neck dissection. We can see in the one side it's a pro, and against we have a many studies. It is clear that the prophylactic neck dissection reduces the recurrence in the central area and affect the distribution of the site of recurrence. Prophylactic neck dissection is not performed. The risk of central compartment recurrence was about 13 times higher than the date of the prophylactic central compartment node group. So this is a significant value. So finally, yes, just I'll conclude. Yeah.
In 2 sentences.
Yes, sir. This is final conclusion. Prophylactic neck dissection may reduce recurrence by 5%, may improve the survival. It may lower the postoperative TG level and leading to effective detection of the persistent or recurrent disease. Prophylactic neck dissection can be safely performed with the comparable morbidity of thyroidectomy along with the experienced surgeon. Thank you very much.
Thank you very much. I call the next speaker, who is our student, now he's in the crime surgery at KTS. So you are welcome, please.
Thank you so much, sir. Thank you so much.
Restrict yourself.
Yes, sir.
Less than 5 minutes.
Yes, sir. I'll try. Thank you so much, sir. Thank you for the organizing team, Gaurav sir, Anjali madam, and Sabha sir for inviting me. I'm speaking against the motion. First of all, why to debate on this? Actually, the role of prophylactic central compartment dissection in T1 and T2 is always controversial. Some studies are in favor, as sir rightly said, and some are against. So actually, ये हंगामा है क्यों? So the first is all about, let's look into the anatomy. Sir ne humko bataya ki the central compartment lies from the hide bone till the level 7 and the upper part, the sternal notch. So it is, I'll not discuss the boundaries, but the important thing is it includes 4 group of nodes: the prelaryngeal, the pretracheal, and both paratracheal ones. So the extent of central compartment dissection is the meticulous dissection of all these 4 group of nodes, at least one paratracheal node. This paratracheal is the culprit one, and which is the important and independent risk factor for local recurrence. So central compartment dissection is divided into 2: prophylactic, when it is said prophylactic when there is no clinical involvement or there is no radiological evidence for that, and it is therapeutic when we have evidence and we do. Berry picking is not advisable. So there are certain surgical challenges that I just told. That is the resection of paratracheal lymph nodes. That is the most challenging part of the central compartment lymph node dissection, especially for the RLN and the parathyroid glands. It is the inferior parathyroid gland that secures its blood supply from the inferior thyroid artery. That is almost all the time. It is temporarily there are chances of temporary hypoparathyroidism. 5% of times these nodes lie behind the recriminal nerve. So there are chances of temporary rexia or very rarely permanent injury of the recriminal nerve. So the question is whether we should do so. If we should only do when the benefits exceed the potential harm. So the benefits are only, we have certain benefits which like better staging accuracy, precise allocation to the radioiodine treatment, and more reduced levels of post-operative thyroglobulin, and possibly contributing to a decrease in recurrence, because we are just talking about T1 and T2. We are not talking about T3 and T4. So what is the cost of doing prophylactic central compartment neck dissection? I've just quoted all the meta-analysis in last previous few years. First one is from 2009 and 2013. They told that there is no increased permanent morbidity, but the recent one published by Wang et al. In 2023, they told that there is higher risk of permanent hypocalcemia and transient hypoparathyroidism, but there is certainly reduced local recurrence. The last one is Liang et al. This was the highest. This recruited the highest number of patients. It was almost 6,800, almost 7,000. They concluded that there is significant higher rate of transient RLN injury, transient hypocalcemia, and permanent hypocalcemia if we do prophylactic CCLND in T1, T2. So what does ATA say? This was meta-analysis. So what does guidelines say? In 2009, the ATN guidelines said that routinely it should be considered. They use the terminology should be considered. So this should be considered terminology led to the controversy. So many surgeons took it as an interpretation कि ये हमें करना है, this should be done. So 2005 guidelines, they changed the terminology. That they said that prophylactic CCLND can be considered in negative central compartment node in disease in larger tumors, T3 and T4, and in clinically positive lateral nodes. That is a weak recommendation. But thyroidectomy without prophylactic CCLND is appropriate for small, non-invasive, and clinically node negative PTC for most follicular disease. That was a strong recommendation. So there is certain also a gray zone. What is that gray zone? Gray zone is T1, T2 tumors which are high risk. That is multifocality, BRAF gene mutation, extrathyroidal extension, and male gender, age less than 44. These are high risk factors because they have higher recurrence rate in central compartment. So, but since most of these are pathological risk factors, we only get to know after doing surgery. So we cannot determine them preoperatively as a roadmap ki kab hame karna hai and when we should plan or we should not plan. So we are still in the loop. So what is the possible solution to the debate whether we should do a prophylactic in T2, T1 tumor or not? So there is a study that I'm quoting that is by Sir Rafael et al. That is published in 2020. They said that prophylactic ipsilateral CCLND should be done and it should be sent to a frozen section and histopathology. If it is positive, then do a complete bilateral central compartment dissection. Otherwise, just abort the procedure. This is the suggestion that they could. So it is in the era, today we are in the era of de-escalation. We are reducing our surgical risk, we are reducing surgical morbidities. So at present, I feel with the novel scientific evolution, currently there is no reason to form ipsilateral prophylactic CCLND in well-differentiated heart cancer. Thank you. This is my team. This is my college. Thank you so much.
Thank you very much.
Thank you, sir.
The debate is open to all of you. Please ask any question if you want.
Do you want to give a rebuttal to him? Because you firmly believe prophylactic, right? And he believes.
I think that will come in discussion.
Okay.
Because there are many surgeons
Okay.
who may be practicing this or that. So let us know what is their view on this. Yeah, anybody please? Your question is directed to whom? Pro or against? So you are in favor of prophylactic dissection? Okay, Kushagra, you have the rebuttal.
Yes, ma'am, you are correct. But as I quoted, we have more. Only there are almost 85 in T1 and T2 tumors, as sir rightly said. There are almost 85% chances of they are only micrometastasis. Micrometastasis are not having any life danger. So they may have certainly a slightly higher risk of recurrence, but there is no endanger to life. So if there is no endanger to life in T1 and T2 tumors, so performing a surgery that may lend into a permanent or transient hypocalcemia and a nerve injury, that is not acceptable.
Most important problem that we find with such problem is the recurrence.
Yes, definitely.
And if the recurrence happens, like in a node, this is I'm talking about if we pre-operatively know that we are dealing with. If the recurrence happens, then going again in the same thyroid plane.
That is a difficult
So
surgery.
for that reason, otherwise if pre-operatively if we don't know that it is PTT and later on it comes back to recurrence. But if we know if it is PTT, it is always good that first time only we just remove as much.
How do you recognize that this patient has central compartment metastasis? How your investigation has shown that the central compartment does not have any metastasis? So, is there a way? Anybody?
So, by the investigations you do, you should be sure enough that there is no suspicious node in the central compartment.
No. The thing is, the size of the lymph node is very small.
Yeah.
No investigation will tell you.
No investigation
But
will tell you.
on the table, you can recognize there and then.
But
yes,
the point which has come up in the low category is low risk patient. Once you go for a frozen section.
No. We are not debating that. Okay. We are saying that a surgeon who thinks that yes, if I encounter lymph nodes in the central compartment, what I am going to do? Suppose I am going to operate. So that the lymph nodes are very small.
But the guidelines nowadays is that.
What about guidelines?
Okay.
You are on the table, you are the surgeon. You are the greatest guideline on this earth because you are treating the patient and patient will come back to you. So in case these lymph nodes are having metastasis, after you do total thyroidectomy or whatever surgery you do, fine. But how you recognize that yes, these small lymph nodes, you can see on the table, they are having micrometastasis or not micrometastasis, at least metastasis, because something happens to them. You can see it there and then, and you can recognize. Then immediately you go for prophylactic dissection. So that's what I want to know from you. How to recognize. Yes, there is a black stippled things are there. So these black dots will tell you, and then if you follow them down. They will disappear because once it go into the mediastinum, you won't find, even if the lymph nodes are there, they won't be black at all. So if you find black lymph nodes in the central compartment, then what are you going to do? Are you going to remove or no? If you remove, then there are risks to the nerve, there are risks to your parathyroid. Okay. So in this situation, what is your take? What are you going to do? Yeah, Aditi, please come. Yeah, yeah. Okay. Okay, how will you deal with it? Okay. Yes, agreed. I agree with you that yes, you should go with it. Well, that will initially before you operating, all investigations showed no evidence of central lymph node dissection. But these small things, when you consider on the table, then you will find them there. You can't see them. Or I don't know what the people like him, what they have planned for him. You have to proceed. Okay. How you going to take care of the nerve and the parathyroids? Because they are very potential and serious complications may occur if the surgery is not experienced. Any particular instrument you would like? Any navigation you would like? Okay. Okay. Suppose you injure the nerve. And after the surgical agents now no. How many you have done any? Have you done any repair in any of the thyroid surgeries? Yeah. Okay. No. That it works for you doing properly. Anyway, so people who do repeated dissection, which was supposed to be prophylactic dissection, okay, then you have to be ready with something so that in case some complication occurs on the table, you can test it there and then. Yes, Sajid, please put your point.
Sir, yes, like what Subhati was saying, I agree with her. Just like test what is prophylactic dissection is available now. And if you encounter any more during surgery, then it automatically becomes therapeutic. By prophylactic means that we are on whatever means are available to us. By that means we are concluding there shouldn't be any metastasis. But so far as like if you take thoroughly from other cancers, like in thyroid cancer, we know the presence of thyroid, even ultrasonography cannot detect small lymph node in center within that thyroid. On clinical examination, even during surgery, unless you go down, you can miss some small nodes. So there are no guidelines that you have to do something like 2 centimeter node biopsy where you are 101% sure that there are positive nodes or negative nodes. So by going by like general whatever feeling among surgeons are during surgery, you don't encounter any broad nodes. And if you are performing a dissection, that should qualify for prophylactic central compartment neck dissection.
Okay, this is prophylactic done into therapeutic.
So yes, sir. If we encounter any enlargement during surgery, that means we are suspecting and therefore we are opting that. But if we don't encounter, then this thing I would like to previously prophylactic neck dissection in all the cases, but as of now, I would like to myself stick to ATA guidelines. I would do prophylactic only in larger tumors.
T3 and T4.
If the patient inputs me for doing, then I would restrict myself to any center. Because whatever said and done, permanent hypoparathyroidism rates are still high. Even if it occurs in one patient, that is a very great morbidity to that patient. And at the end of the day, what are we achieving? We are definitely not going to change overall survival. Only the differences in reference-free survival and if you perform this surgery, the difference is also to the people. So maybe Anish has something to add.
Yeah, please.
So one more point is one more point is that the accuracy of the.
Please, you have asked the question, now it is his turn. Okay.
Thank you, Bhavya. I see that this is prophylactic. What you mean is there are no roads in PGES. I think I agree with them. If it's more than 4 centimeters, I would do a prophylactic. Less than that, it would be utilized based on either what you find in raw or patient.
Yeah.
Yeah. So you have a T2. You have done a thorough search of the central compartment, no on the table, but your molecular test is showing a BRAF and a TERT mutation. What would you do? Would you do a central compartment?
Anybody?
First of all, what is the indication of BRAF and TARP in T2 tumor cell?
Doesn't have any significance.
Once it is proven to be papillary carcinoma, then there is no role of BRAF and TARP if it's not familial disease.
And TERT together.
Yeah, but that is
Together.
if that is there, then you have to be addressed.
Yes.
Remember
No, I'm not talking about only BRAF.
but only BRAF because
No.
previously we were thinking.
Yes, previously we were thinking.
Because our majority, it is the most commonly getting
Yes.
cancer, and most of the cancers are not aggressive. So if it is combined with that, then it makes a difference. But as of now, it is not the standard of care. It is going to pick up.
Yeah, because when I was preparing my slide, I saw Susan Archie's paper
Yeah,
where they
yeah.
are recommending that. So
Yeah,
I just brought
I'm
it up.
coming to that.
Yeah.
Would become standard of care because of change, WHO study the classification. Because these mutations are going to be part and parcel of our disease reporting, maybe
Sir, only one thing, like we were talking about BRAF and TERT mutation in the pre-opsy. I don't know how many of you are doing mutation analysis.
Yeah, so our dynamic cannot be, that's what man is also saying now.
Second thing is regarding cellular compartment, seeing a lymph node positive or not. We are actually, Dr. Renz also will be sharing the same experience. We are seeing so many thyroid patients who are busy. Maybe around 80% patients are there. So you will be seeing so many nodes and we can't associate it benign or malignant in the pre-opsy. So we can tell like we are doing we are not doing a overthink. That is one prediction issue. Second thing is in typical subgroups, especially less than 30 years, because we also have a problem like young age is 20 years in the thyroid carcinoma. So that is also one subgroup. Second is hyperthyroid, Graves associated with nodules. In these cases, few cases, sometimes I also get scared. Like, if we have very small nodes, while visualization, you won't feel like a metastasis. So much micrometastasis will be there in those cases, especially in the young adults. So, okay, definitely if you're doing a finding aspiration cytology genetic, yes. If it is there, you can go for a prophylactic in that case. And subgroup, and I think whenever you're talking about this central compartment prophylactic stuff, what is your take on any, at least any central compartment dissection in a high-risk patient in a unifocal disease? That is more preferable.
Anybody else want to say anything? Yeah, please.
Many have already spoken that they will not do a prophylactic central compartment. I would like to bring out the point that when you do not do a central compartment dissection, the usual follow-up is by doing stimulated thyroglobulin. And it's very often you see that the stimulated thyroglobulin is high in those patients who have not undergone a
central compartment.
And these patients come back to you again and again with this value of stimulated thyroglobulin high. And then you have to keep on chasing it. That is one issue which I find in private practice. And there are studies which have shown that if you have done a central compartment dissection prophylactically in the T1, T2 disease, the TG is very, very low in such a population. It's not an argument, just a comment and observation of practice.
Yeah. The last exercise. How many of you, all our surgeons, please raise your hand that you will do a prophylactic central compartment dissection in this situation? T1, T2. Okay, very few of them. You will like it. So, what is the take-home message from this session? First, I will give my view, then I will ask my colleagues' view. I think that if I find black staple notes irrespective of their size, I will go ahead and do central compartment dissection, because morbidity of this kind of dissection in my hands remains the same, whether I do it or you don't do it. You see? Now, over the period of years, I have to be very confident, yes, I can save parathyroids, I can save another. There won't be any additional morbidity of surgery doing a prophylactic dissection in this patient. Plus, as our colleague has already pointed out, it becomes very good or very easy for us to follow up these patients.
Yes. One message is all the macro notes that you can see with your eyes on the scan, on the table, exploring the central compartment needs to go up. All the micro notes which you can't see even on exploring the central compartment, I won't go for a dissection. Thank you.
Doctor, yeah, please. You want to ask some question? Yes, yes. You. Okay.
Regarding target population.
Okay. So like it's for challenging children. Let the study go, let them come to conclusion after 2 years. That can be applied. Thank you so much.
Thank you, sir.
Sorry, we are still late by 10 minutes. Sorry for that. Thank you very much. He is waiting for you.
Thank you to the moderators and the presenters. We now disperse for tea break, which will last for 15 minutes. After that, we have the endocrine imaging session. So kindly join us after 15 minutes.
कर दिया है किसी के पास किया है हाँ हाँ किया था So, Paul sir, Sudhi ma'am, and re-operator sir. Paul sir is there. Virat sir. Paul sir आए हैं. He's right outside. बाहर आ रहे सर अंदर आ रहे. Paul sir ma'am.
You have the schedule with you? I think
Oh, yes, sir.
Okay. Yeah.
So this one?
Says PG, yeah, PGES is one.
This one.
We are going reasonably on time, huh? Suppose start at 4 session.
We're actually lagging behind.
Or 10, 15 minutes, huh? Or more.
30 minutes.
30 minutes. Thanks. 30 minutes.
Yes, sir. Second year employee.
तो एक्चुअली जो सेकंड केस है उसमें ग्लास स्लाइड है उसको कॉन्फ्रेंस करिए सेकंड केस कॉन्फ्रेंस कर रहा है
कौन सा मैसेज नहीं कर रही हूँ लास्ट स्लाइड नहीं कर रही। ये जो कैलकुलेशन आया था मेरे पास कितना साइड नंबर था जो लास्ट सेशन आया था आपके पास कितना साइड नंबर था 162.5 अभी हम बोल रहे तो उतना ही हमारे पास आ रहा है लेकिन साइड नंबर को आ तो नहीं है ना सर मेरे को नहीं आ रही है आपको समझ नहीं आ रही
You are coming for and you want to do your accommodation. Okay, thank you.
You're telling everything. We don't have time. Oh, Renal. Renal. We don't have time for all this. Jaldi. We'll start it. Yuvraj sir. युवराज सर, युवराज सर, क्या नाम क्या है? अच्छा, उसमें नहीं, इसमें करना है, उसमें किया जा रहा है सब। क्या करना है?
फर्स्ट इमेज है, उसमें एंटर प्रोसेस सब लिखना है। पिछले उसको उठा लेके वही कॉपी कर देंगे।
क्या एंटर करना है? चलो,
प्लेनर इमेजेस में W है, सेकंड थर्ड केस खोल लूँ वहाँ से। इसमें ऐड करना, सेकंड से आप कॉपी कर लो, इसमें कर सकते क्वेश्चन।
नहीं, क्या करना, सेकंड ऑलरेडी है।
हाँ, सेकंड में है, उसको बस कॉपी कर लेना।
Why are you doing this? Sarah, what are you doing? So moderator can do everything.
इंटीरियर में इसे कॉपी करेंगे नेटवर्क में।
छोड़ो इंटीरियर, ठीक है, ये कितनी में था?
बस इसे इसको भी पकड़। साइड कार्टिलेज दिख रहा है ना, वही है कहाँ इसमें? इसमें है कहाँ पर?
वो रखा होगा। ओपन करके रखा होगा। Where is that? Yeah, this one. Projecting. Oh God, it's projecting. Which one? नहीं, इसमें ना।
अरे भैया आई बीसिंग काम करने के बाद कमांड ढूंढती हूँ मैं।
इसमें 3-4 दोनों थे, फोटो 3 की है, 3 की है।
If I was writing level 3, so I should also write level 3, like 3.
सर्च में लेवल 3 लिखा है।
No, I have writing 3 in this 3.
Okay.
I should write it to 3.
आपको 2 सेंटीमीटर मिला था।
हाँ क्यों?
हमारा सेंटीमीटर साइज था।
नहीं एग्जामिनेशन में था उसको 3 into 1 सेंटीमीटर।
हाँ उसमें बड़े हो गए हैं। कितने दिन से गया था दोनों में?
3 months।
कितने में? 3 साल में नहीं बड़े।
मार्च में था, मार्च में बैठे हुआ था।
हाँ अराउंड 1 सेंटीमीटर था मेरे में, 1.23 होगा मैक्सिमम।
अब है
क्रॉस सेक्शन में
हाँ इट वाज
नहीं शॉर्ट एक्सेस बात कर रहा हूँ, लॉन्ग एक्सेस तो ठीक है, शॉर्ट एक्सेस
नहीं एक्चुअली ये वो है इंट्राऑपरेटिव फाइंडिंग है और उसमें बड़ा ही था। देख लो आप जितना खींच सकते हो खींच लेना।
तो सेकंड रोल नंबर आने वाला है प्रोबेबली, फर्स्ट में हम लोग नंबर।
हाँ फर्स्ट आप लोग लंबा कर दोगे, सेकंड वो लंबा कर देंगे, थर्ड का पता नहीं देखा जाएगा। ये जस्ट व्हाट इज द मिनिमाइजिंग।
जी मैम। रिकॉर्डिंग से आप बोलिए हमारा वो नहीं आ रहा है।
सारे खुले हैं भाई।
बंद कर देते हैं हम
एक सेकंड सब नहीं कर रहे हैं। क्यों नहीं हो रहा? What's wrong? खाना कर लिया। हमारे प्रेजेंटेशन में हम ही कर रहे हैं। मेरे सारा कॉल कॉल सारा शुरू करें। बहुत सारा लोग हमेशा आ जाते हैं।
Welcome back, everybody. We'll be beginning our endocrine imaging session. May I please request the moderators to come to the dais? Professor P.K. Pradhan, sir, Professor Archana Gupta, ma'am, Professor Gyanchan, sir, the presenters for this session would be Dr. Spandana, Dr. Rinel, Dr. Madhu, and Dr. Divya from the Department of Endocrine Surgery, Dr. Vineet and Dr. Avinash from the Department of Radiology and Department of Nuclear Medicine, respectively.
Good afternoon, everyone. Starting with our first case, a 30-year gentleman presented with a swelling below the lower jaw since 2019. He then presented with development of multiple new painless swellings in the neck since 2021. He was evaluated outside and a fine needle aspiration cytology was done, which was suggestive of metastatic papillary thyroid carcinoma. At presentation to us, he did not give any history of a thyroid swelling. On examination, he was average built. There was a 3 centimeter lymph node in the submental region, 3 centimeter lymph node at left level 2, a 4 centimeter lymph node at left level 5, and a 1 centimeter lymph node in the upper right paratracheal region. We then went ahead with a thyroid ultrasound.
A very good afternoon to one and all present here. So here in the first image, we can see this is how the normal thyroid gland looks. It is appearing homogeneous and it is hyperechoic as compared to the strap muscles that we are seeing. The image is not that good, however. Then in the lower image, we can see a lesion which has a cystic component, a fluid component, and a solid component, which has similar echogenicity as that of the thyroid parenchyma. So a possibility of enlarged cystic lymph node was kept on ultrasound.
And there was no lesion in the thyroid. We then went ahead with a guided fine needle aspiration cytology of the submental lymph node and the left cervical lymph node, which were both suggestive of metastatic PTC. Our then treatment plan was to go ahead with further neck imaging. And if there was a thyroid lesion, we would then do a total thyroidectomy with a central compartment lymph node dissection and a selective neck dissection. If there was no lesion in the thyroid, we would then do a lymph node biopsy and ISC staining. We went ahead with a CECT neck and upper mediastinum.
So before describing the findings, I would like to just recapitulate how we acquire the CT. So the CT scan is normally done to acquire from the level of base of skull to the level of upper mediastinum. Non-contrast section is acquired first, and then a contrast section is acquired. So here, as we see, we can see the axial contrast enhanced images here in the level of upper cervical region. So just mentioning the few anatomical details here. First, here we can appreciate the internal carotid artery, and here is the internal jugular vein. Then here we can appreciate this is the parotid gland, and here is the submandibular gland, and just anterior to the submandibular gland, below behind the anterior belly of digastric, we can appreciate normal appearing submandibular group of lymph nodes. And here is another important landmark that is crucial for the staging of cervical lymph node, that is the sternocleidomastoid muscle, which is seen here normally. Moving on to further caudal sections. So here, as we have already seen in the clinical examination, that there was swelling in the submental region. So corresponding swelling was also appreciated in the CT image. There was a solid cystic mass which was hyper-enhancing in the solid part. This was actually a submental lymph node which was just posterior to the platysma muscle. And this is the anterior belly of digastric, which is separating the submental group of lymph node from the submandibular group of lymph nodes. And this is the hyoid bone. So this lesion was present at the level of the hyoid bone. Moving further downwards, here we can appreciate the triangular thyroid cartilage, and anterior to this lesion is appreciated. This is the platysma muscle, and the fat planes with this muscle is lost, and the muscle seems to be involved in this case. Posteriorly, as we can see here, behind the internal jugular vein, we can also see a heterogeneously enhancing lymph node. There are areas of necrosis within this lymph node, and there are hyper-enhancing areas, so which might suggest the involvement. And this was a middle jugular group of lymph node, as it was seen below the level of the hyoid bone. Moving further downwards, we can see another solid cystic lesion, which was present in the level 3 only, and the fat planes with the internal jugular vein was lost, and the internal jugular vein was compressed in this case. And here is the supposed normal location of the posterior triangle group of lymph nodes, which lie behind the posterior boundary of the sternocleidomastoid muscle. Here we are seeing some lymph nodes which are small in size and have maintained fatty hilum. Moving further downwards, so this is the level of the cricoid cartilage. This is semicircular cricoid cartilage. It is hypertense, but it is less hypertense as compared to the bony structures. That is how the cartilage looks like on CT. So these there are another group of lymph nodes which are seen at this level, which have partly cystic and partly solid components. The solid component of this lesion have indistinct fat planes to the anterior sternocleidomastoid muscle, and the internal jugular vein is also seen to be compressed. Then furthermore, the solid component of this lesion was seen extending behind the posterior boundary of the submandibular gland. So we assigned this as level 4/level 5 group of lymph nodes. Furthermore, moving downwards, we can appreciate both the lobes of the thyroid gland, and they are showing homogeneous kind of enhancement. No evidence of any lesion was seen in the thyroid gland. And this was a cystic lesion again, which was seen anterior to the internal jugular vein, and it was having loss of fat planes with the sternocleidomastoid muscle with possible invasion. Further moving downwards, we can see that there are heterogeneously enhancing group of lymph nodes which were medial to the internal carotid artery and were in the central region. So we assigned them as possibly involved level 6 group of lymph nodes. And these are the sequential axial sections of the thyroid gland in which we can appreciate the homogeneous enhancement of the thyroid gland. No abnormality was seen in the thyroid gland. No appreciation of nodules can be seen on the CECT. And we have seen the ultrasound also. There was no lesion in the ultrasound as well. Then moving on to the sagittal reconstruction images, in which we can see the relation of the lymph node with the vessels very well. So this is the internal jugular vein that is coursing from the jugular fossa downwards in the neck, just beneath the sternocleidomastoid muscle, and posterior to it is the lymph node, the cystic lymph node, and anterior to it also is a lymph node that we have already seen. These were level 4 group of lymph node, and there was level 4 and level 6 group of lymph nodes which are lying anteriorly, and the fat planes are lost. The vein is compressed, and however there is no actual infiltration inside the vein, but at this point the involvement cannot be really commented upon, so they might be probably involved. And here is the common carotid artery that is lying just in the parasagittal section. We can see the common carotid artery, and the lymph nodal mass that was seen was also lying anterior to it. So we assigned level 6 group of lymph node to it. Then during the primary scan, when the primary scan was reported, at that time we searched in the RGL scans, we were not able to appreciate the actual cause of these metastatic lymph nodes. However, after doing a review for this presentation, we reviewed the scan in the sagittal sections, and we were able to appreciate a cystic lesion which was present between the hyoid bone and the thyroid cartilage, which had an enhancing component to it, which was likely the source of all these metastases. So we assigned this cystic structure was assigned as a thyroglossus cyst with possible primary parathyroid cancer in it, and anterior to it we can appreciate the submental group of lymph nodes which are present, and these were the CD findings in this case.
With these findings, we then went ahead with a left level 5 lymph node biopsy, which was suggestive of metastatic PTC, and IHC staining was also done, which was positive for thyroglobulin. With this, we made a diagnosis of papillary thyroid carcinoma with a multiple cervical lymphadenopathy with an occult primary. We then decided to do a total thyroidectomy with a bilateral central compartment lymph node dissection and a bilateral selective neck dissection, followed by radioactive iodine treatment and proceed. We performed surgery, as you can see in the image, that this is the submental lymph node. These are below the strap muscles. The thyroid seems to be unremarkable, and there were multiple bluish-black cystic lymph nodes in the central compartment. The left selective neck dissection and the right selective neck dissection both had bluish-black lymph nodes. At histopathology, the thyroid specimen was unremarkable. The central compartment lymph nodes were negative. The right selective neck dissection was negative, and the left selective neck dissection lymph nodes had multiple lymph nodes that were positive for metastasis, and the submental lymph node was also positive for metastasis. We then referred this patient to the nuclear medicine department.
Good afternoon to all present here. This 30-year-old male patient was referred to nuclear medicine for the radioactive iodine ablation. Before the radioactive iodine ablation, patient needs to have high serum TSS level to enhance the uptake of radioactive iodine into the remnant cancer cells or thyroid. This is being done with two methods. The classical one is levothyroxine withdrawal, which is done for 3 to 4 weeks. Alternatively, levothyronine may also be substituted for initial 1 to 2 weeks, and levothyronine should also be withdrawn for at least 2 weeks before the plant therapy. The other method is RSTSS administration. This is the exogenous administration, intramuscular administration of the recombinant human TSH. 2 doses of 0.9 mg 24 hours apart. The benefit is this provides superior short-term quality of life to the patients because the patient will not be having the symptoms of the hypothyroidism. And also there has been seen that there is no significant difference in long-term outcome with this method. However, the main limitation is its cost. So these are the indication of the RSTSH according to ATA guidelines 2015. The RSTSH should be considered in the cases of significant medical conditions that could be exacerbated with the hypothyroidism, or if there is inability to achieve the adequate TSH level, which is at least around more than 30 MIU per liter with levothyroxine withdrawal. According to ATA 2015, RSTSH may be considered in ATA intermediate risk differentiated thyroid cancer with lymph nodal metastasis, and it is also an acceptable alternative of levothyroxine withdrawal in ATA low risk or intermediate risk patient planned for remnant ablation or just adjuvant therapy. So this patient was kept on the levothyroxine withdrawal for 1 month, after which his TSS level was 85.6 MIU per liter and TG was 58.6 nanogram per ml. Patient was administered 5 millicuries of the radioactive iodine, and After 48 hours, radioactive iodine, whole body radioiodine scan was done. These are the planar images of the whole body radioiodine scan. This is the anterior view. This one is the posterior view. This one is anterior view of the neck region, and this is the posterior view of the neck region. In the anterior view of neck region, we can see physiological tracer uptake of radioiodine in the stomach, intestine, urinary bladder, and in nasal mucosa. However, there is also an increased radioactive iodine uptake in the neck, which location would further be cleared in the SPECT CT images. So this was the SPECT CT image of the same patient. The upper row images are the CT images, the middle row are the SPECT images, and the lower rows are the fused SPECT CT images. In these images, we can see there is an increased tracer uptake of radioactive iodine in the left thyroid bed region. Based on this finding, patient was planned for the radioactive iodine therapy. The doses of the radioactive iodine therapy is based on the post-operative risk stratification of the thyroid cancer. So 88 low risk category patients are not routinely recommended for the radioactive iodine therapy. However, if there are serum PG is raised or any abnormal USG finding, patient may undergo remnant ablation with 30 millicurie. In the 88 intermediate risk category, remnant ablation can be done with the 30 millicurie of the radioactive iodine, which is as equivalent to as doing with 100 millicurie. And for the adjuvant therapy for the suspected residual disease, up to 150 millicurie of the radioactive iodine can be administered. In the 80 high risk category, for the adjuvant therapy, the same in case of the absence of known metastasis, up to 150 millicuries of radioactive iodine can be administered. And if there are known structural disease like lung metastasis or bone metastasis, then 150 to 200 millicurie of radioactive iodine should be administered. So since this patient was only having the uptake in the left thyroid bed, so for the remnant ablation, he was administered 30 millicurie of radioactive iodine on the ambulatory basis. The patient is currently in the regular follow-up.
This time, what was the CT level of the patient?
Sir, at the time of radioactive
58. 58.
Yes. What was the level of CT?
58 nanogram per ml, sir. So this was 58 nanogram. So this patient is currently in regular follow-up.
Regarding this imaging of the both thyroid
over the last 5 years or 6 years, since I have retired, is there any way to image a thrombus? Because sometimes it is blood and it gives it high, the radiologist is not able to pinpoint, yes, is it thrombus or not. Sometimes it takes to the wall of the vein. So how to detect the thrombus which is stuck to the vein? Is there any new advancement in inflammation?
I think the inflammation advancement is the FDG effect. But this is you can pick up from your contrast analysis scan. So there is no requirement of FDG there.
No, I'm not asking what is to be used, but if the surgeon knows that yes, beforehand, there is a thrombus, although in routine CT is not seen, but sometimes if a thrombus is there, and then it may go down, it may increase in size, and if surgeon knows before operation, yes, there is a thrombus.
FDG will pick up definitely if you have done that, but we never do for that because we depend upon the CT.
Yeah, because in this situation where there are so many metastases and there is compression of the, the interstitial vein, doesn't move. Probably think of removing this vein if there is thrombus inside it. Otherwise, why take it out?
To add something here.
Yeah,
The
please.
CT scan and see if the Doppler cannot miss the numbers in the jugular vein. And in this case, where the radiology as far as shown the images, the vein is full of contrast. The contrast in the human is very well seen in the vein. So there is no number seen in the vein.
Yeah, that's right.
The left side of it.
Yes, but you can
Here you can very well see the full human.
fine. It's all right, but in the lower part, there is a fuzzy thing. So that raises a suspicion that probably the wall of the vein is little irregular. Why it is so?
It is not irregular, sir. Actually, the reason of interest is here the neck part only, not the root of the neck.
Yeah, you know.
The images clearly show. When you would be shown the digital images of complete run through, you can very well see the in axial section also that human is free of number.
Okay. Thank you.
Before taking the second case, I would like to add up in this first case only. After we reviewed the case for this presentation, because the report has been given by some other person and our team here given as impacted lymph node. But when we reviewed the case for this presentation, we found thyroglobal duct cyst, and there is some enhancing component seen anterior to that. That was not being reported in the first CT scan. So that is not, in fact, having the nuclear medicine pharmaceutical also, that area. Avinash, can you show the images in axial and sagittal? We were suspecting some papillary. Yeah.
Actually, we do the main thing. So we never had any.
And we don't have post-operative CT images also, so we cannot also comment. This is the problem. I have given the message to endocrine surgery. They should call the patient and a repeat imaging should be done. But surgery, they have not taken this area out.
Ma'am, at surgery, we could not find any thyroglossal cyst.
It is very small. I don't know. You have gone with that vein also or not.
Yes, I mean that at the time of doing surgery, while removing the thyroid, the thyroid which madam has referred to might be small in size and could have come along with thyroid itself without identifying this on the table after you do the surgery. But I know it is a routine that after surgery we just check the specimen on the table, then look for whatever the area of interest is there.
You might have removed it was not taken up by the scan.
Normally, had it been diagnosed definitely you will get because quality studies are there, you have a and if it is a cyst completely or calcified, then it might because so that's normally they are removed.
Yeah, it's all right. I have nothing on whatever it is.
Excuse me, my question.
Yes, please.
My question is, can we go for repeat surgery in this patient, like get a post-operative scan and then go for the surgery?
No.
Because the location is thyroid bed only.
But there is no uptake at the
But a few images.
You just check if the thyroglobulin is aging and we are again we go for the aging is the thyroglobulin is aging, then we see about it. Next is if there is no other question.
The second case, we have a 43-year-old lady who presented to us with an anterior neck swelling for the last 5 years and a change in voice for 3 months. She was a known hypothyroid and a hypertensive controlled on medication. On examination, she had a right-sided solitary thyroid nodule, which was 8 centimeters in its greatest dimension. The trachea was deviated to the opposite side, and there were no lymph nodes palpable, or there were no retrosternal extensions. She had hoarseness of voice, there was drooping of her left shoulder, and there was deviation of tongue to the left side. Biochemically and symptomatically, she was euthyroid on medications. We went ahead with the ultrasound of the thyroid.
So on the ultrasound of the thyroid, the right lobe was enlarged and it was completely replaced by ill-defined lobular hypoechoic lesion. So the echogenicity of the lesion, whenever we are comparing, we compare it with the strap muscles. So as compared to the strap muscles, the whole lesion was hypoechoic. However, there were more hypoechoic areas within the lesion, which might suggest some necrosis or degeneration within the lesion. So considering all the findings, we placed a thyroid category of 4/5 of the lesion, and we advised for cytopathology. The left lobe, however, was normal on ultrasound, and there were few subcentimetric lymph nodes which were present in levels 2 and level 3, but they were normal and they were showing no loss of arterial.
Video laryngoscopy of the patient revealed left-sided vocal cord palsy. Guided fine needle aspiration cytology of the thyroid nodules revealed follicular neoplasm, Bethesda 4 category. For further imaging, we went ahead with CCT neck and the upper mediastinum.
So these are the axial non-contrast sections of the same patient in discussion. So here in the upper cervical region, we can appreciate that there are few lymph nodes in the submandibular group. As we have already discussed how to identify the submandibular group, it lies posterior to the anterior valley of digastric. And here we can see that these lymph nodes have maintained reniform shape, and they have this normal vessel that is going into the hila. So we are seeing the normal hilar structure of the lymph nodes also. So on non-contrast scan, however, we have to characterize these lymph nodes further on the contrast sections. So moving on to further sections, going down, little downwards, we can see the right lobe, as was seen in the ultrasound images. The right lobe is completely enlarged and it is heterogeneous in non-contrast sections. And we can also appreciate the areas of degeneration or necrosis that were seen in the ultrasound images that are seen here as well. The lesion is also causing some splaying of the sternocleidomastoid muscle, but all these relations we'll describe in the contrast section. Moving further downwards, we are also able to appreciate that just below the level of the sternum, some part of the lesion is reaching. So there's small amount of retrosternal extension of this lesion. Furthermore, we can also appreciate that here is the trachea, which is deviated towards the opposite side, and there's compression over the trachea and the esophagus, and the lesion is reaching up to the tracheoesophageal groove here. So seeing the contrast sections, we'll be able to appreciate the findings much better. So moving on to the contrast sections, we have already dealt with the anatomy earlier. So moving to the findings. So here is the heterogeneously enhancing lesion that was present in the right lobe of thyroid. A small rim of normal enhancing thyroid may be seen in the periphery. And here, if we are looking for the involvement of structures, we always look for fat planes with the adjacent structures. So here, as we are seeing, this is the common carotid artery, and this is the internal jugular vein. In between the vascular structures and the thyroid lesion, there is a small fat plane that can be appreciated. So here we can say that the fat planes are maintained. Medially, however, this lesion is causing displacement of the laryngeal complex towards the opposite side. However, we can see that the laryngeal complex has maintained its architecture. There's no evidence of any bony erosion. There's no evidence of any infiltration into the laryngeal apparatus. Anteriorly, it is causing the splaying of the muscle. But however, we can also appreciate here a small fat plane between the lesion and the muscle. So moving further downwards, we can appreciate the sternocleidomastoid muscle bilaterally, and there is a small fat plane that can be appreciated between the lesion and the sternocleidomastoid muscle. The vessels are displaced posteriorly, and posteriorly it is also reaching up to the prevertebral space. So here is the vertebra, the hypertense structure that we are appreciating here is the vertebra, and the lesion is reaching up to the prevertebral space here. This small structure that is seen posterior to the thyroid, to the trachea, is actually the esophagus, and this is the area of the tracheoesophageal groove where this lesion has reached and is causing the displacement towards the opposite side. Then on the opposite side, we can also appreciate this is the normal part of the thyroid gland on the left side, which is showing homogeneous contrast enhancement, and which was also appreciated in the ultrasound images as well. And on the anterior aspect, we can see these small tiny dots, which are hypervascular structures. These are actually continuing in the axial sections, as we can see. So these are basically the prominent veins. And the reason for this prominence of veins will be discussed in the upcoming sections. Why is it there? Then inferiorly, the lesion is seen compressing the trachea. However, there is no infiltration because the impression that has been caused by the lesion of the trachea is smooth. So there is just displacement and there's compression. So these are the coronal reconstructed images of the same patient, in which we can appreciate the extension of the right thyroid lobe, which is enlarged and it is reaching just below the level of the sternum, not much of retrosternal extension, and it is causing deviation of the trachea towards the opposite side, and the laryngeal apparatus is also deviated towards the opposite side, and the left lobe of thyroid here can be seen normally enhancing. There were few lymph nodes that were seen in the level 3 and level 4. However, they have maintained the reniform shape. So on the imaging itself, we take a criteria of approximately, like usually we take a criteria of subcentimeter. If a lymph node is subcentimetric, then we consider it as normal. But however, if in the presence of a locoregional malignancy, we can cut short that criteria to 5 mm also, and we can consider them significant if a locoregional malignancy is present. So we get always advised to go for further cytopathological evaluation of the lymph nodes for proper staging, as was done in this case. Further, the patient was having complaints of hoarseness of voice and having some tongue deviation, and the scan also incorporated the skull base. So these are the images of the skull base of the same patient, in which this is a non-contrast section, in which we can see that there was a heterodense lesion which was present at the level of the jugular bulb and the hypoglossal canal, which was causing bony erosion on the left side, and some part of the mastoid hair cells were also involved, and there was some involvement of the petroclival area as well. On contrast sections, we can appreciate that the lesion is enhancing homogeneously associated, and there is associated bony destruction. And inferiorly, it is also involving the jugular foramen. And below that, we are able to appreciate the normal internal jugular vein and the normal internal carotid artery. But further to characterize this lesion, we proceeded with the MRI brain for the patient. So just a little recapitulation on how to identify various sequences on MRI. So this is the T2 weighted image, in which we can appreciate that the CSF is looking hyper intense. So this is the T2 weighted image, and the white matter is looking a little darker as compared to the gray matter on T2 weighted image. However, on the T1 weighted image, we can appreciate that the CSF is looking hypo intense. So water is white on T2 and water is black on T1. That is how we are identifying the sequences. And below it is the post-contrast sequence. This is also a T1 based sequence. So we compare the contrast enhancement in the T1 weighted images. Then in between this is a diffusion weighted image, in which we usually use it to differentiate between lesions which are benign and malignant, depending upon the cellularity. So more the malignancy, the more the cellularity of the lesion, and the more diffusion restricting it would be. So coming on to showing homogeneous contrast enhancement, as was seen in the contrast CT as well. And this was a susceptibility weighted image. So we use susceptibility weighted image to look for internal architecture, to look for any calcification or any internal vascularity or any hemorrhage. So in this, there was no such pickup that was seen in the susceptibility weighted image. Had it been a calcification or a hemorrhage which was present within the lesion, we would have appreciated hypointensity within the lesion, which was not seen. So susceptibility weighted image was normal. There was diffusion restriction and there was homogeneous enhancement in the lesion on the post-contrast image. So to further identify the involvement of the nerve, we move forward with a sequence which is known as this sequence of the Fiesta sequence, which is actually a heavily T2 weighted image, just to characterize the nerves and to look for the structures which are passing through the CSF much more better. So what this scan does is this enhances the CSF signal intensity, and the structures that are passing through it will appear more darker. So we will be able to appreciate them better. For example, here, as we can see, this is the normal course of the trigeminal nerve. Bilateral trigeminal nerves are coursing normally, and this is the normal Meckel's cave. Then moving further downwards, we are able to appreciate the normal 7th and 8th nerve complexes, which are normal, and the inner ear structures are also appearing normal. Further moving down, we can see that this is the glossopharyngeal nerve here, which is going normally. And in this area, we can see the lesion is now starting, and the nerve is little thickened here. Further moving downwards, we can see that this is the normal location of the hypoglossal canal where the hypoglossal nerve runs. And this is completely involved by this lesion. So which shows that there was involvement of the hypoglossal nerve in this case. So these are further thin sections of the post-contrast images in which we can appreciate that the lesion is starting here from the skull of the skull base, and this is the location of the transverse sinus and the sigmoid sinus junction. So this is the transverse sinus and sigmoid sinus junction, and this is the sigmoid sinus. So normally on the right side it is seen, but on the left side it is involved by this lesion, which would explain the involvement of the veins. The veins that were so prominent in the anterior part of the neck were actually because of the involvement of the transverse sinus, because of which there were so much collaterals that were formed on the surface of the neck, which is a very important information for the surgeon to know before proceeding for the surgery. Then furthermore, in the coronal reconstruction images also, we can appreciate that this lesion was seen and there was involvement of the sigmoid sinus, and there was compression over the IJV, which is further seen better in the coronal, the sagittal reconstructed images. So here is the IJV, which is completely compressed in the superior part, and the internal carotid artery, which is looking completely normal. So our impression over the scan was that there was a lesion in the thyroid with the possible metastasis to the skull base.
We made a clinical diagnosis of a follicular thyroid carcinoma with skull metastasis with left-sided cranial nerve palsy involving 10th, 11th, and 12th nerves. Our plan was to perform a total thyroidectomy and then subject the patient to radioactive iodine scan and proceed accordingly. Intraoperatively, we found a highly vascular tumor with strap muscles being adherent to the thyroid lobe, and they had to be resected. The right lobe and the isthmus were grossly enlarged, and there was a retrosternal extension of 1 centimeter. There were also subcentimetric right-sided level 3 lymph node that was seen, and it was excised. Histopathological examination revealed a follicular carcinoma with polydifferentiated foci in the right lobe, whereas the left lobe was unremarkable. The resected right level 3 lymph node was suggestive of a reactive lymphoid hyperplasia. We then referred the patient to nuclear medicine department for a post-operative whole body scan.
This patient underwent whole body radioiodine scan after stopping levothyroxine for 1 month, and patient was administered 5 millicurie of radioiodine, and imaging was done 48 hours later. At that time, her thyroglobulin level was more than 500 nanogram per ml, and TSH was 29.2 ml in IU per ml. Sorry, milli IU per ml per liter. This whole body radioiodine scan shows area of increased TSR uptake in the neck region. And this is the anterior image, this is posterior image, and this is the anterior image of the neck. Also, it shows in the posterior image we can better see the physiological TSR uptake in the stomach region, intestine region. Further, the patient underwent SPECT CT. In the SPECT CT, we can see these are the low-dose CT images. The middle row are the SPECT images, and the lower rows are the fused images. In the fused images, we can see there is an area of increased radioactive iodine uptake in the left thyroid bed region. And based on these findings, patient was planned for radioactive iodine therapy, and patient was administered 125 millicurie of iodine 131. And after that, patient was discharged when the radiation limit was permissible to discharge.
Furthermore, we'd like to repeat the whole body radioactive iodine scan in the patient. And if there is subsequent uptake in the skull mets, we would subject the patient to subsequent radioactive iodine ablation.
Just a minute.
Yes.
What happened to the metastasis or local extension of the tumor in the skull base? Because it was probably compressing the nerves, or it was involving the nerves, three nerves we are told. So what did you do with that? Did you call the neurosurgeon?
Yes, sir. The patient was also started
because there was a significant size of the tumor which was left behind. It will cause increase in TD to very high level, which was shown. So what was your plan for this local extension of it?
So the neurosurgical team was involved, and the patient was started on steroids. The patient was subjected to radioactive iodine ablation. Here,
No, that's right. I'm just concentrating on steroid itself. What did the neurosurgeon say? Did they say that yes, they operate with you as a team, or will do it separately, or they will not operate on this?
So the initial plan was to go ahead with the total thyroidectomy. Then, based on the radioactive iodine scan, they said if if there had been an uptake on those scan, then we would have gone ahead with and updated both.
No, the thing is,
We follow this testing system, we see whether there is improvement after
gadget only. Because these tumors, if they become dedifferentiated, you will not find any activity uptake in the scan. So the first surgery is there, and that is the best chance to remove this tumor. So that's what my view is here. But whatever was done is all I feel is.
Yes, sir. Actually, this thyroid scan was after surgery, so then only we can know whether if there is a take is there or not.
Actually, the iodine was not concentrating. It's possible that it may not concentrate if it's follicular feedback. So, I think Dr. Verma's question was right in this sense. Why did you take care of this at the first go? The radioiodine was not concentrating. Then you had a consultation with neurosurgeon. So, what is their opinion? I don't see it.
So they have actually now planned for a guided biopsy of the lesion, and they have now planned for gamma knife therapy for it. But it is not necessary, but it was their initial plan. But now they have referred the patient to radiotherapy for. Yes.
I think vascular is not a contraindication. Sometimes we embolize initially, then of course that's their opinion. But we can embolize and do the surgery. It depends upon the location. I think fair enough to have a external radiotherapy or what they are planning for gamma. Yeah, and I feel here, we have to refer the patient to the.
Yes, sir. AIMS in Delhi.
Now,
but
okay. Gamma knife treatment has been done or it's scheduled?
Scheduled.
Scheduled. Okay.
So last case of the session. Back in 2013, this patient noticed a swelling in left anterior neck. 5 years after which, in 2018, she presented to hospital elsewhere, and evaluation was done. FNS was suggestive of papillary neoplasm. Followed by that, she was subjected to left hemithyroidectomy. Histopathology was suggestive of papillary thyroid carcinoma. 1 month after that, she was subjected to completion thyroidectomy and referred to SGPGI in 2019 for further management plan. The patient was first presented to nuclear medicine department and under the follow-up of the department.
This patient presented in the Department of Nuclear Medicine in January 2019. At that time, she was asked to stop levothyroxine for 1 month, and after stimulation, TSH stimulation, her TG was 221 nanogram per ml, and WBRI whole body radioiodine scan was done, which showed uptake in thyroid bed and left cervical level 3 lymph node, for which patient was administered 100 millicurie of radioactive iodine. In the further follow-up, her TG decreased to 176 nanogram per ml, and WBRI scan shows there was no uptake. However, low-dose CT scan of the neck was done, which showed a 8 mm left cervical level 3 lymph nodes. Patient was not administered radioactive iodine, and patient was kept in follow-up, regular follow-up. In next follow-up, her thyroglobulin level raised to more than 300 nanogram per ml, and also WBRI scan was negative, so patient underwent FDG PET CT scan. FDG PET CT scan shows mildly metabolically active, SUV max around approximately 4.2, 8 into 6 centimeter left cervical level 3 lymph node. And the patient was, this was the only lesion, there was no lung lesion or any skeletal uptake. After which patient was kept on the regular follow-up, and Presently in the 2023, patient presented with TGA of the 264 and a TSH of 125 after the stimulation, and WBRS scan shows no uptake. This is the whole body radio. I present the latest whole body radioiodine scan of the patient after the administration of 5 millicurie of radioactive iodine, and scan was done after 48 hours. This is anterior image, the posterior image, and the anterior neck image. As we can see, there is no abnormal focal pressure uptake in the neck or region or anywhere else in the body. We can see the physiological pressure uptake in the stomach, intestine, and urinary bladder. After which, USG of the neck was done.
So in this USG, as we can see, the thyroid fossa here, as we can see, this is the tracheal impression, and this is the normal thyroid fossa where the thyroid tissue was supposedly located. So this was post-op scan, so there was no residual thyroid that was seen. There were few level 3 group of lymph nodes that have been seen in the scan, and these are partly cystic and partly solid. So with these findings, we proceeded to FDG PET.
After this finding of level 3, the cervical lymph node on the left side, patient was planned for a FDG PET CT scan. Patient underwent FDG PET CT scan after the proper preparation of the empty stomach for at least 6 hours, and patient was administered 10 millicurie of radioactive iodine, 10 millicurie of FDG, and after a waiting period of 1 hour, imaging was done from the vertex to knee region, and with the perfect position of 1.5 to 2 minutes. This is the maximum intensity projection image of the PET CT. We can see the physiological trace uptake of FDG in the brain, myocardium, kidneys, liver, urinary bladder, and also there is supraclavicular brown fat uptake, since this scan was done in winter season, and it is quite common to see that. Also, there is one abnormal tissue uptake in the left cervical level. So these are the axial images, the upper one are CT images, lower one are fused PET CT images. In these, we can see left cervical level 3 lymph nodes which are FDG avid. Also, we can see there are left cervical level 6 lymph nodes which are FDG avid. So with these findings, patient was referred to endocrine surgery for the surgical management. Also noted, there were some at least 3 number tiny 1 to 2 mm size nodules in the upper lobe of the both lungs, which were non-FDG avid.
When this patient presented to us, an examination, a healthy scar was found to be present in the midline, and 2 by 2 centimeter mobile lymph node was palpable on left side at level 3. On biochemical evaluation, she was found to have a TSS level of less than 0.005 with a normal serum calcium and IPTS value. An ideal left vocal cord palsy was present. Guided FNAC of the left cervical lymph node was done, which was positive for malignancy. So we have made clinical diagnosis of recurrent PTC, which is thyroglobulin elevated negative iodine scan in left cervical lymph node at level 3. Our plan was to go for left selective lymph node dissection and central compartment lymph node dissection. And before surgery, we went ahead with CCT neck and upper mediastinum.
Here are the contrast enhanced axial sections of the same patient. Here we can appreciate that anterior to the internal jugular vein and the carotid, we can see heterogeneously enhancing lymph node, which is below the level of the thyroid, which is below the level of thyroid. So this is level 3. Here again in the downward section, caudal section, we can see this similar solid cystic lesion that we have seen in the ultrasound, and it has indistinct fat planes with the IJV. However, there is no definitive infiltration and there is no evidence of any tumor thrombus. Then furthermore, going downward, we can appreciate that there are few small hyper-enhancing lesions which are present in the central compartment or the level 6 group of lymph nodes. And we can also appreciate that this was a supposed normal location of the thyroid. So there was no enhancing tissue, which would suggest there was no residual thyroid that was left in the thyroid gland, thyroid fossa. So moving on to the sagittal reconstructed image. So this is the maximum intensity projection image in which we can see the vessels more clearly and the relation of the enhancing structures more clearly. So here we can see with these lymph nodes that we had already seen, the level 3 group of lymph nodes, the partially cystic and the partially solid. They're enhancing as much as the vessels. So this is the characteristic of the metastatic thyroid lymphadenopathy, that they are as enhancing as vessels. The few other metastases can also look like these, but thyroid in neck is very common, which is showing this kind of an appearance on imaging. So in this, we can appreciate that the fat planes are lost. However, there is no actual infiltration into the vessel, or there is no evidence of any tumor thrombus that can be appreciated.
So this patient underwent left selective lymph node dissection level 2A, 3, 4 with left hemicycle LND and frozen section biopsy of the right level 3 cervical lymph node. Intraoperatively, multiple enlarged lymph nodes were present on the left level 2A, 3 and level 4, largest being 3 by 3 into 1 into 1 centimeter at level 3. 2 enlarged lymph nodes were also present at level 3 on the right side, were sent for frozen section biopsy and were reported negative for malignancy. On histopathology, left selective lymph node dissection, 11 out of 30 lymph nodes showed positive for malignancy. In CCLND specimen, there was reactive lymphoid hyperplasia was present. The further plan for this patient was to follow the patient with TSS, TG, and ATG, and whole body radioiodine scan after 6 months.
Now, in this case, I don't have any commented query, but the one which was previous this, I have a suggestion that generally, as I have seen over the last 30 years, if I never select for something which you think that yes, they will be able to contribute, because it is not their patient and practical, don't take it otherwise, they will not interfere. If I were there in this, because I had during my training at AIIMS, I worked in neurosurgery also. And larger tumors, vascular tumors from the brain were very easily taken out by the expert surgeons. So this residual mass which is there near the sigmoid sinus is nothing as compared to the tumors in the brain which I have assisted and I have seen. So if I were the operating surgeon in this case, what I will do is a Lyons directly. You won't have heard the name, but me and Sabha, we had one particular private case, emergency case. We designed this name. Anyway, what does this mean? It means that you take the tumor out piecemeal. Don't try to go around and try to put your finger anywhere. There is no space there. Right? So better is to pack it with a little bit of tip of nose piece, then obtain your hemostasis. And for neurosurgeons, they do such big craniotomies and then the tumors out. This tumor should have been very easy for them. But anyway, if I were there, I will not call because I know my capability and I can do it. So gradually with patients, with spending a little more time using suction, and because there is no place to retract, okay, but you should be able to take it out. And if you have available any business space, use your handheld ultrasound. With that, I think I would certainly be successful in taking this tumor out, which we have left it, will cause problems in the long run for the patient. That's what I have to say. And one of my queries is there, which have not been solved till now, to both the imaging experts, how to detect the involvement of a thyroid cartilage during, that means if it is an area which is near to the thyroid cartilage, which has started becoming, dedifferentiated. So sometimes we get the report that yes, there is involvement of thyroid cartilage. I remember doing 5-6 surgeries where I have taken out the thyroid cartilage also, the tumor. But getting a report from histopathology that there is no involvement of, no infiltration of the thyroid cartilage from the tumor. That addresses that why we done this. So is there any advancement in science either in imaging or in radiology to know that yes, this cartilage is now involved, just becoming, in contact, we assume that probably there is the infiltration of the cartilage in the direct cartilage. That puts the surgeon in a fix about to leave or take it out. And if you are operating on a cancer, you are always inclined to take it out. So is there any way or you enlarge it or whatever you do? So I want to know from the imaging experts.
So there is evidence of erosion. Yeah, but how to find that? So on imaging, you just change the window. Look for the for bone, we change the window to bone, and we can find out the changes in the bone if there is lytic lesion, osteotic lesion, or mixed variety of lesions. Change the cartilage also. If there is erosion of the margin, then you can 100% change the cartilage.
Okay. In one or two cases, we got this, and after I got these negative reports from the histopathology, I just scrapped, not take out the cartilage. Okay, and we were able to take the remnant thyroid out, whatever was left, but did excise the cartilage. But in the long term, in the follow-up, there was no evidence of any recurrence from that cartilage, which we have just scrapped and not taken out. So probably we have yet to find out a very convincing, evidence. Yes, we should take the cartilage also. Probably, I don't know.
Like in this case, the cartilage is well preserved.
No, not in this. I'm not asking this case. This case is very well preserved.
Problems sometimes occur with the trachea. When the cartilage of trachea is calcified, that you can say it is involved. Otherwise, you cannot say just compress or.
Yeah, just appertain.
Yeah, just compress.
That's all. He wants that.
Until
So.
there is intramural,
Yeah, unless there is, of course, intermittent. So take home message for all endocrine surgeon is that you find a suspicion of probably involvement of the trachea, tracheal cartilage. It is probably better to leave it there rather than inside the tracheal cartilage. Unless, of course, as Madam has said, there is frank, you can see the tumor inside the human of the trachea.
It's a very nice case, actually. There's a lot of learning from this case. The first point I want to comment is the initial FNC was reported as papillary neoplasm. So never go with the word papillary neoplasm because there's a well-set classification. So you just stick to that classification.
It was done outside.
Yeah, I know that. I'm not blaming anybody. I'm just telling the learning point. So if you are going to practice, if you get the report like papillary neoplasm, it is 99% papillary thyroid cancer because there is no reporting like a papillary neoplasm in the practice system. Second one is this was a surgical surprise to me for any surgeon that it was a papillary thyroid cancer, and the second surgery was completion surgery. Knowing that it was a papillary thyroid cancer, we should go a complete imaging of the neck. At that time, you would have been taking lymph nodes also. And the second surgery would have been ideally completion thyroidectomy with central compartment with lateral intersection. So the whole story will change, would have been changed because now we are stuck with the 10. And third point is, if even after completion thyroidectomy, patients would refer to the radiology, and if there was a suspicion of lateral neck, it was not explored before. That is, the area was still working. So in that scenario also, we would have gone for the lateral intersection because the area was not operated. In recurrent cases, it's good not to go again because it's a difficult surgery. But for first surgery, it would have been the other way. And the last point is, it was now the case which we labeled it as a 10. So how you follow the patient who was operated for 10? So that you will do the whole body radioactive hiding scan follow-up. So what is the protocol for follow?
Actually, tennis patients are followed up on the TG level mainly, and if there is a rise in TG level, then we do imaging.
I think the answer can like what is radioactive? I think it was negative before.
Once you can do the radioactive scan, but not repeatedly the radioactive scan in this current, because it is shown that there is unlikely to concentrate radioactive. So better to stick to twice so that you get your stimulated TB twice. You do the whole body radioactive scan maximum twice. Okay. Later on, there is no point that you just go on doing radioactive scan. That's the way how we should follow these issues. FDG is definitely better in those situations, but in these patients particularly, I said the FDG showed only the lymph node, no? Nothing else it showed. So this can explain the amount of TG which is producing because there are multiple lymph nodes. So that's not debate about it. And the very tiny lymph nodes what it showed probably doesn't explain about the lung, doesn't explain the TG. It is mostly to the. So that's the only way with the stimulated TG and ATG.
So once we make a diagnosis of tennis, do we again go for radioactive scan in the future, or we only go for FDG scan?
Occasionally we do, but not required actually. Once you diagnose for tennis, sometimes if you are intervening with a decompensating agent, yes, you can do again the radioactive scan, because that is the clue there that we try our best to demonstrate the radioactive effect by any other intervention. Otherwise, as such, the radioactive scan beyond 2 times you should not.
When you do an empirical therapy of say 100 millicuries, that does not become then you permit as a tennis. And then we have done 4 or 5 weekly scans. In my center, what we do is to assess this one scan, 1 5 weekly scan. What we do at the thyrotoxin regulation is an empirical therapy of 100 millicuries. And if that 100 millicuries does not show any uptake anywhere, then we turn it as a television load. And the next step would be go to SGPGI. That is probably sometimes in private practice we do it before actually doing a empirical therapy. That's one. And second thing is those small nodules which are there, unless you do empirical therapy, they may not pick up. Because if you have poor rate, sometimes the disease is the dose. The disease is probably somewhere else. Probably not even I would assume are metastasis. And maybe you should, in my center, as I said, only one 5 millicuries scan. Here the TB is low, we just do 1 5 millicuries scan. We stop there.
Might be you are in much hurry actually. So we are not at all hurry. We take our time, prove that it is truly tennis. Then now with the advent of PET-CT, we are not really giving any empirical therapy. The concept of empirical therapy earlier, that the TG will decrease by 30 to 50%, that is no more in this mandatory expectation, is almost obsolete now after the advent of it. We know the PET-CT will help if your TG is more than 100, that is the most cutoff, then your yield will be better, and at least 1/3 of the patients we can lead to for the surgical ablation surgery rather than radioactive. So, to my understanding, please don't give that, because that is not tennis. Tennis is defined in a very different way. I think Dinesh, will you explain tennis exactly what it is? Otherwise, I will explain. Okay, should I explain and tennis? Okay. So I think that the tennis is a disproportionate uptake. One is no uptake at all. Okay, in the radioactive scan, or you are seeing structural disease and there is the less of the, or this is heterogeneous, like you are seeing very less uptake in one lesion the other lesions are not picking up. So there are 3-4 criteria to say that it is steril. It is not that one criteria. So doctor, wherever you are practicing, I don't know personally, but I think I will discourage that. And please discuss with your colleagues and do further things. Okay? Because thyroid cancer is very slow growing. And your hands will be dry and you will be helpless if you just go on pull. So don't go radioactive. That is just hardly any use unless until you demonstrate the radioactive uptake with a resetting agent or something else you are doing. Of course, there are ways I will suggest you which is not yet possible. I can give you some hint. If you suppose do with iodine 123 or iodine 124, normally picks up 50% lesions more. Then probably we can explain if you have iodine 124. Okay, so these are the ways how you demonstrate fast the object. But that also, if I demonstrate, suppose there are 10 lesions, I am demonstrating with 2 lesions object, that doesn't have value. Then I will again tell this is 10. Okay, so this is the way how to go about it. And, so any other thing?
Dr. Saran, just one question about redifferentiating therapy. I think in the current era of tyrosine inhibitors, are we doing any redifferentiating therapy now?
I think Dr. Paul, we are doing, but we are not really doing directly because we are realizing. I think we have just recently applied for a research project in the research protocol, and hopefully we will be able to give the answer in the next meeting after a year to all of you with both the iodine 124 as well as the lenvatinib tyrosine kinase if the research project is accepted.
Just to add a point, we looked at our own experience with empirical therapy and found actually there was very little effect. It's not really worth it.
Yes. Then that was time when there was nothing. So obviously the PET has not come. So empirical therapy was the only answer because they were vouching that probably you are doing molecular therapy directly and decreasing the TG level. But that explanation didn't suit really much, and you are only 20-25% decrease. So that doesn't really help much. Rather than demonstrating the uptake, either in FDG, then tell them at least 1/3 surgery. Of course, surgery is also not all the panacea for the recurrent thyroid cancer. Let me tell you. It will decrease by again 50% or 60%, and then it continues to grow. Today only I have seen a patient who has been operated, I think way back in 2007. So today is already 16 years now, and again reoperated for central compartment nose. Again the recurrence came, and the central compartment he went ahead and got operated at Tata also after 2 surgery here. And now the lymph nodes are persisting, but what we are able to do is with PSS, his PG is normal. Okay, on eltroxin, his PSS is normal with suppression, with 3.5. But if I off, I know that his PG will be around 30 or 25. But we are happy that okay, for the 16 years there is no other recurrence in the neck. Might be something lying in the central compartment, doesn't matter. He's an old man, only 67 years old, doing happy, everything. So that's the way how you follow.
The last 30, 40 years. Tell you what is going to happen to this patient most of the means how far he can continue there, and then after the fact there is a escape phenomena for rejected item. After how many years rejected item that we won't work in this patient?
We can't. I can't say. At least I don't have that knowledge, or from the literature, if somebody else knew, must be reading something aggressively. So to best of mind, that part we can't predict. We have to do it as scan, demonstrate it, whether it is taking uptake or not. Maximum we can say there are 2-3 things we can think of. If there is no concentration, you can measure your contamination part with the urinary radiology. If that is also proven, then you can go for your demonstrating the ultrasound. But normally I prefer, if you are the best, to utilize the ultrasound part, because most of the metastases are, we know the predilection is to the neck, and so you please do a ultrasound first rather than going for a CGT or a FDG PET. That should be the one.
I request the moderators to kindly wind up the session.
Yeah, thank you very much. Thank you for that.
Thank you to the presenters and the moderators for this very interesting session. Moving on to our last session for the day, which is based on malignant thyroid disorders. May I please invite on stage the moderator, Dr. Boon Johri ma'am, on stage. And the chairpersons for this session would be Dr. Nitish Gupta and Dr. Geetika Nanda. May I please have you on dais, please? I would request the moderator to kindly call upon the speakers one after the other.
Thank you. First, I think my Geetika ma'am. The first speaker for today is Dr. Anish Cherry from CSC Lucknow, and the topic is micropapillary carcinoma. What's new?
Thank you. Greetings from Vellore, and I'll be speaking on papillary thyroid microcarcinomas. I thought I'll just give a broad overview as to how the management has evolved over the years, and then a lot few slides on issues that were new. So by definition, papillary thyroid cancer, microcancers are papillary thyroid cancers of a size up to 10 millimeters, regardless of the presence or absence of high-risk features such as recurrent laryngeal nerve palsy, clinically apparent cervical lymph nodes, or distant metastasis. So therefore, it covers a broad range of biological characteristics. Most of them are screen detected. A few are incidental following thyroidectomy, and a minority present with cervical node metastasis or distant metastasis. In the early or late 90s, the concept was these are small cancers. They could grow, they could metastasize, and therefore we need to surgically remove them to prevent progression. And as we all know, surgery is associated with morbidity. Epidemiological studies over the years have shown that there is increase in papillary thyroid cancer, majority of which have been due to microcancers, but the mortality has remained stable. It's interesting to note that clinically present papillary thyroid cancers or microcancers 1,000 times lower than those that are reported in autopsy series or that has been detected on cyst screening. In addition, Sugitani has compared the postoperative course of two groups of patients, those with symptomatic papillary microcancers and those who are asymptomatic. Asymptomatic group included those that did not have lymph node metastasis or recurrent laryngeal nerve palsy at presentation, and showed that the asymptomatic group did very well. So the inference from all the above is that there is an increased incidence of papillary microcancers, and this is probably due to the increased use or advancement of imaging studies. Microcancers rarely grow and become clinically apparent. So then there was a concern regarding overdiagnosis and overtreatment. So the question that arose was, how do we appropriately treat microcancers? How do we determine which of these cancers would progress? And this brought about the term active surveillance by Professor Miauchi. And what he meant by active surveillance is close monitoring of primary cancers without performing immediate surgery, intervening in the event of a progression. This was mainly to avoid overtreatment and prevent potential morbidity of surgery. To implement this as a modality of treatment, there were two questions that he needed to answer. One was, is it safe to observe and detect microcancers that progress? And in the instance that they do progress, does rescue surgery affect the outcomes? Now, his inclusion criteria for his elaborate trial was ultrasound detected suspicious lesions up to 10 millimeters, and those that were 5 millimeters or above in size, he performed an FNAC to confirm the malignancy. We know that some of these have high-risk features. These include cervical node metastasis at presentation, distant metastasis at presentation, signs or symptoms of invasion into the recurrent nerve or trachea, or high-grade malignancy on cytology. These were excluded. So those that fit into the inclusion criteria, they were offered either active surveillance or immediate surgery. Those that chose active surveillance, a repeat ultrasound was performed at 6 months and then annually. Tumors that progressed in size over 3 millimeters on follow-up, or there was a development of new cervical lymph node, or if there was a tumor size increased more than 12 millimeters, moved on to surgery. The risk of tracheal invasion was assessed by the position of the tumor on the ultrasound. If they were more dorsally placed, a CT scan was done to calculate the angle between the tumor and the thyroid cartilage. If it was an obtuse angle, this was shown to be a high-risk feature for invasion and went immediately for surgery. Whereas if the angle was acute, they were low risk and continued active surveillance. To assess the risk of recurrent laryngeal nerve invasion from these tumors, this depended upon the presence or absence of thyroid tissue between the tumor and the course of the recurrent laryngeal nerve. So in summary, the diagnosis of papillary thyroid microcarcinoma was by FNAC or ultrasound with suspicious lesion. Those that had high-risk features or preferred surgery, patients went ahead with surgery. Those that did not have high-risk features went on to the active surveillance group. If there was a progression during the active surveillance, there was a conversion to surgery, and those that did not progress continued active surveillance. So the end of this and years of follow-up, he showed that only about 8% of tumors in a 10-year follow-up time progressed 3 millimeters or more in size. In addition, only about 3.8% developed new cervical lymph nodes at follow-up of 10 years, which show that active surveillance is a therapeutic option. And to answer the second question, is it safe to intervene? He showed that when he compared groups that underwent immediate surgery to those that had active surveillance, the incidence of recurrence or new cervical lymph node was not significant between both the groups, which showed that intervening when progression is detected was a safe strategy. In addition, the Mayo Clinic conducted a large retrospective series of about 900 cases over a 60-year period. These are all papillary thyroid microcancers that were operated upon, and they showed that there was no significant difference to the rate of recurrence depending on the extent of surgery or on patients who received radioactive iodine ablation for remnant disease. So demonstrated excellent prognosis and also showed that limited surgery and the avoidance of radioiodine was possible for these tumors. Following all this, multiple guidelines have started implementing active surveillance as a method of management for these tumors. And there are more studies that keep coming out showing and proving that majority of these are indolent tumors with similar rates of progression in size or detection of new cervical lymph nodes. An interesting finding recently, which the Miyochi group came out with, was when they studied the natural history of papillary thyroid cancers. They showed that about 17% actually decreased in size. And I think that's the first time that there was documentation of decrease in size of tumors on just observation. Our experience, which was published years ago, I think the main point that we saw was that amongst the group of patients who had metastatic disease, all of them had multifocal tumors. So therefore, we concluded that multifocality would mean that these tumors could be more aggressive. So coming to high-risk features amongst papillary thyroid microcarcinomas, age less than 40 has been shown to influence the recurrence of cervical lymph nodes, tumor size progression, and progression of clinical disease. Tumor size, there are various reports that say tumor size more than 7 millimeters is a risk factor for tracheal invasion. Tumor size more than 5 millimeters is a risk factor for extrathyroidal extension and lymph node metastasis. And similar to our study, multifocality has also been implemented as was shown to be a high-risk feature. Now, Dr. Smita had already spoken about the role of ablative techniques, include microwave ablation, radiofrequency ablation, and percutaneous ethanol injection. These have been shown to be effective and safe to control the primary tumor. However, currently there's not enough long-term data to support this modality of treatment. Regarding biomarkers, BRAF and TERT, currently prognostic role in progression of papillary thyroid microcarcinoma has not been established. A high Ki-67 index has been shown to be related to tumor enlargement, but this has been shown only in pathological specimens and not yet evaluated in the preoperative FNA specimens. Recently, the WHO classification has recommended that it is not only adequate to mention the size of the tumor to define papillary thyroid microcarcinoma, but we need to include the subtype information as well when we report. This is because we know that some subtypes do behave more aggressively. So to conclude, majority of microcarcinomas are indolent. A subset may progress, hence the role for active surveillance. Selection of appropriate patient is paramount. Not sure if this is feasible approach in our patient population. There are a couple of high-risk features that we need to keep in mind when addressing these tumors, and these include the age, tumor size, and multifocality. When the pathologist is reporting papillary thyroid microcarcinomas, it is important to include this subtype information. The role of ablative techniques, long-term data is still awaited, and the identification of markers of tumor progression is an area of ongoing research. Thank you.
Thank you, Dr. Nish, for the excellent talk. Before we go on to questions, may I please invite the other chairpersons for the session, Professor M.J. Forrester from the diocese to chair the session, Dr. Chandan Kumar from AIMS Patna, and Dr. Vishwa Chandra from SGPGI. While chairpersons are coming on the dais, any questions from the group?
Again, just to share, I think when the initial data came out, she had 2 patients who did that survey. The problem in our country is, follow-up is difficult. They came for 3 years, and one dropped out at 2 years and one dropped out at 3 years, and I don't have any follow-up after that. So that's one of the challenges we face. The system is, especially if you're in a bigger institute and they're coming from far away, patients in India usually do not do long-term follow-up. That's, I think, it's just a behavior pattern. So you have to take this to the will to start in our situation. I don't know if any other experience on the floor at this level. It's not just Western, it's specific to Japan and that area. Because if you ask the Americans, they'll say any patient you say you've got cancer, that's 2 millimeters, 10 minutes, take it out. But they're also not very practice surveillance. I think they have. So it's a cultural issue. I think Japanese probably they're very confident of the follow-up. The countries connected with is willing to come for it. No, I don't think any country will get that kind of long-term data on that. then there'll be a whole host of relatives who will be paying the
That's true, sir. Actually, one patient who had an FNAC, microcancer, kept on surveillance. They went back home, showed another doctor, and they said, "You have a cancer, go back and get it operated."
Thank you, Dr. Anish. The next topic is anaplastic thyroid cancer is the light at the end of the tunnel, and may I please invite Dr. Shekhar from Vijayawada.
Good afternoon, everybody. So before going into what's currently new in the management in anaplastic thyroid carcinoma, I think it would be good to briefly have an overview of how the disease presents and how we evaluate it in first hand. So most of you know anaplastic thyroid carcinoma. There are three kinds of stages. Stage 4A, which is intrathyroidal malignancy. Stage 4B, which is extrathyroidal, and stage 4C, which is distant metastasis. So historically, the median survival for anaplastic thyroid carcinoma was stated as 5 months, and 1 year survival rates were approximately 20%. And so the light at the tunnel that we are currently searching for is not exactly, complete response, cure rates, complete cure rates, or something like that. But how do we prolong this lifespan that was historically quoted? One of the most important things these days is targeted therapy, and for not only the reason of achieving a diagnosis of anaplastic thyroid carcinoma, a core needle biopsy or even an FNAC is essential for genetic analysis of the sample for us to determine what kind of mutations are there in that individual person's specific anaplastic thyroid carcinoma, so that we can assign appropriate targeted therapy for that person should they require it down the line in the treatment. So coming to FNAC, sometimes FNAC is sufficient in anaplastic thyroid carcinoma, not for the diagnosis per se. I'm talking about the gene sequencing that we need later on. But in the paucicellular variant, we'll probably not get enough cells to create a cell block and do the gene analysis. So the better option would be to do an ultrasound guided core needle biopsy to avoid any necrotic areas. Also, something that can be done is an incisional biopsy, but if somebody is doing an incisional biopsy, it is better to also do a frozen section at the same point to ensure that enough material has been taken out, and because we usually do have that kind of facility available to us these days. And always there is a confusion in the diagnosis of anaplastic thyroid cancer. It can mimic poorly differentiated cancers. It can mimic extrathyroidal malignancy metastasis like lung metastasis. So some kind of immunohistochemistry evaluation might also be necessary other than the regular gene analysis that is required for targeted therapy. If there is any DTC that is seen along with a picture that is similar to anaplastic, then that is almost a sure sort sign that it is an anaplastic. But if that is not the case, in some situations, we do need to do immunohistochemistry before going down the line for treatment for anaplastic cancer. So there are multiple genes that can be mutated in anaplastic thyroid cancer, and next generation sequencing is or whole genome sequencing. Both of these are good things to go ahead with, especially because if one targeted therapy is not working, you need to move on to the next one if the goal of treatment is to prolong life rather than giving hospice care or supportive management. The surgery is actually the mainstay of the first line of treatment in stage 4A cancers and some of the stage 4B cancers, especially when there is no involvement of the carotid vessels or the airway or the GI system. So in those patients, we need to aim to go for an R0, R1 sort of resection. So no gross disease to be left behind. And this helps us further down the line when we are assigning the patients for adjuvant treatment. So in 4A, most of the patients should undergo surgery at the first step and adjuvant treatments later on to improve the disease-free survival rates or progression-free survival rates. Whereas in 4B, neoadjuvant treatments can also be given. We'll just skip to the part where we have treatments. So in the neoadjuvant setting, external beam radiation, chemoradiation are both good options, whereas chemotherapy has not been shown to be very effective on its own. However, it can be used as a bridge in the therapy before starting targeted therapy. Targeted therapy is usually based on the gene sequence reports that we get. And if it is next generation sequencing, it takes a minimum of 2 weeks. And if it's the whole genome sequencing, it takes several weeks for the results to appear. So before starting targeted therapy, we can go ahead with radiation or chemoradiation in such patients. This is especially true in the adjuvant setting rather than the neoadjuvant setting. And there are multiple studies that have shown a significant difference in overall survival rates in patients who have received external beam radiation or IMRT following R0, R1 resection. So radiation is definitely a good option in maintaining progression-free survival, at least for a couple of months. And chemoradiation in particular is slightly probably superior to radiation, but we don't have actually comparative studies between the two. And there are several studies which have quoted around up to even 2 years of progression-free survival, the increase in survival rates to that extent following chemoradiation. Coming to systemic chemotherapy, so a combination of drugs is usually used. When I was talking about neoadjuvant, there have been studies that have tried single agents such as doxorubicin or docetaxel, and single agents usually do not work. So it's usually a combination of docetaxel with a platinum or doxorubicin with platinum used as a bridging treatment between your radiation and surgery and the final targeted therapy that is increasing the survival rates. Coming to the targeted therapy, some of the genes that are targeted are the BRAF mutations, the MEK, VGFR, RET fusions, and especially the PD1. So PD1 comes under immunotherapy, whereas BRAF and MEK, they come under single agent tyrosine kinase inhibitors. And a combination of agents, dabrafenib, which is against BRAF mutation, and then trametinib, which is against MEK mutation. So a combination of these two agents has shown some amount of progression-free survival and stable disease post-usage, and has improved the overall response rate. And the overall response rate was around 69%. So a combination of drugs is used rather than single agents because and when a single agent is used, a resistance to that agent occurs very quickly, and that's why a combination of agents is used. And currently there are RCTs also that are looking into the neoadjuvant setting use of BRAF and MEK. The studies that were done in locally advanced patients and in patients who had metastatic disease, and this combination is actually approved, FDA approved for metastatic disease, and it's also used in the adjuvant setting for stage 4B disease And also probably in progressive 4A disease, you can also offer this to patients. And once patients are no longer responsive to the BRAF and MEK treatments, the anti-BRAF and MEK treatments, there are other mutations that can be looked at, such as mTOR, tropomyosin receptor kinase, ALK fusion, and RET mutations. So all of these have some amount of progression-free survival, but we are talking about anywhere between 20 months for mTOR, whereas for the other agents, it's like tropomyosin receptor kinase, it's only a couple of months, like 2 to 3 months progression-free survival that we are looking. So it's the individual patient, it's completely dependent on the individual patient and their response to the particular drug. So most of these studies are case reports and case series rather than actual observational, long-term observational studies, because of the rarity of the cancer, and most of the treatment is also, it's based on level 5 evidence and level 4 evidence. Just as how you would not compare proton pump inhibitor to surgery for gastric ulcer. We usually don't make those comparisons here. And when a patient is resistant to a drug, moving on to another drug in this setting makes some sense. Coming to immunotherapy, other than pembrolizumab, which is nowadays being used for a multitude of cancers. We use it in triple-negative breast cancer, we use it in lung cancers, we use it in sarcomas. So it is an immune model, it's an anti-PD-1 agent. So similarly, there was a study on atezolizumab, which is a PD-L1 inhibitor. And they divided the ATC patients into 3 cohorts. And the first cohort, which was where the patient was given vemurafenib or cobimetinib for BRAF mutation, this cohort demonstrated an overall response rate of 71% when the PD-L1 inhibitor was added to the treatment. However, as I've just mentioned, when we use the combination of dabrafenib with the trametinib, so that was 69%, and this is hardly 2% different from that. And 2 agents are being used. So rather than using these 2 agents separately, it's possibly better to have that combination initially, and when the resistance develops, probably move on to PD-1 later on as a second step or third step. And currently, and also there was a retrospective analysis of 6 patients in which the VEGFR, anti-VEGFR lenvatinib was combined with pembrolizumab. And progression-free survival was 16.8 months, and median overall survival was 17.3 months. So rather than speaking about the original median survival of 5 months, now after adding all these therapies, so chemoradiation adds anywhere from 1 year to 2 years of life, and then the targeted therapy adds another anywhere between 6 months to 2 years. So we are trying to help people who want that kind of treatment to prolongate their lives. So just this is a brief summary of what the treatment management is. Like I've said, for 4A, surgery is going to be the first step, and followed by adjuvant treatments in the order of chemoradiation, followed by targeted therapy. And if 4B disease is resectable, in situations where there is no airway involvement, or when there is no carotid involvement or esophageal involvement, when it's resectable, definitely go ahead and do the resection, and then follow it by adjuvant treatments. And when it's not resectable, give the agents in a neoadjuvant setting, and then if surgery is feasible, follow up with that. And best supportive care and hospice are always options for these patients. It depends on the patient's preference as well. And a lot of these drugs are also extremely expensive. So the combination that we've mentioned, the anti-BRAF and anti-MEK, they are currently available and are in the market. So per month, it costs 1,35,000 for the patient. So it's not always something that can be feasible. It's not like chemo, even chemoradiation is expensive, but this seems to be a monthly recurring expense that is probably out of the reach for many people. So to summarize, conventional oncology, there has not been much change in the past decade or so. So surgery followed by the chemoradiation. The chemoradiation protocols are from over a decade ago. Nothing much has changed in that perspective. However, there are newer targeted agents. Multiple agents have been tried, and in individual patients, we have seen responses, but this is not something that can be applied in a generalized manner, and it has to be individualized for each and every patient. And so I would say, even though it feels like the tunnel is longer, we probably are moving in the right direction. Maybe there is some light at the end of the tunnel, but we are not able to see it right now. Probably we will in the future. Thank you. Yes, sir.
Tumor is basically a triangle. Okay. Before it pounces on the surgeon has to pounce on it. Okay. These patients, they come in the OPD, we see them, and then there is no lymph node, nothing, it is confined to the tumor, the thyroid gland. But the earliest sign will be when you try to ask the patient to take water. The thyroid to be removed initially, but within 3 or 4 days to stop moving. That means it is stuck to the bed. That raises suspicion. Second thing is, if there are lymph nodes, you can take an analysis, but generally the initial setting you won't find any lymph nodes. The other thing is edema of the skin in front of the thyroid. If it is there, it's a very strong suspicion. Yes, probably you are dealing with a anaplastic carcinoma. And this I say and I teach is basically a emergency situation. This is thyroid emergency. There are no other lymph nodes present there. Please schedule your patient for surgery. Do an extensive surgery. You find a lymph node, do the section there and then. Okay, if you don't find, just take the thyroid out. But here, there is a specific caution that do not dissect around the thyroid. Try to reach the thyroid individually, all these things, but you have to go a little away from the thyroid. So that the surrounding areas of the thyroid are also removed, taking care to protect the nerve. And in that process, the parathyroid is close to the thyroid. Please take it out first. Put it on the eyes, mince it, or do a thyroid transplant, because otherwise you do it both the ways, it will be hypocalcemic. But you have to be very, very aggressive in this patient. I got a lady who I operated middle-aged lady. Only these are rare because I got only one. I tried to do the best for this lady, but that time there was no lymph nodes. When she came for follow-up after 6 weeks, there are multiple lymph nodes. Probably went again and did the second and the third, but we lost her within 6 months. There was no arrangement for hyperfractionated radiotherapy. Initially, it was tried in the Scandinavian countries. So what they will give you pre-operatively, give you first a few doses of little higher dose of radiotherapy. Then immediately patient goes for surgery. Then once the patient is better, they are discharged and then they go to radiotherapy, and then further whatever is done. But still in that, at that time they were the best series available, and they were patient. The patient was living to the maximum, maybe about 8 months or 12 months. So have you operated any of these patients? And I want comments of Dr. Paul in the surgery. If he has any experience of operating on anaplastic centers.
So I'm actually going to give a talk on that one. So if you don't mind, we move on. Thank you for your comment.
Thank you. The next topic is pediatric differentiated thyroid cancer, and the speaker is Dr. Aruna Chekawar from Kolkata.
Good evening, all. Maybe so happy to be here for almost the last session. So it's about children and young adults. So I will start with a small clinical history. One 19-year-old female came to me with a left solitary thyroid nodule, size of 0.7 centimeter. The FNAC was paucicellular, 3 times than outside, and she's a doctor right now. And repeated FNAC was Bethesda 5. We performed total thyroidectomy, central compartment dissection, and selective node dissection because of lateral compartment node positive. His final histopathology was 0.8 centimeter PTC with multiple central and lateral compartment nodes. So with this history, the main problem is who we should call a pediatric patient or a young adult in the thyroid way. The problem is in our scenario, at least in thyroid, we can call a person less than 20 years as a pediatric, because there is really so much controversy regarding the age limit. Few papers telling it is 16 years, few 17. So you can take it as 20 years. So at least we will also feel young regarding this. So the topic will be divided based on this, and the topic is this way based on the management guidelines in children and thyroid nodules differentiated by ATC. So if you talk about thyroid nodules, thyroid cancer is leading cause of pediatric endocrine cancer. It's almost 6%. But if you see thyroid nodule as such, the incidence of nodules is less in pediatric age group. But if you think in terms of percentage of malignancy, it is really high compared to an adult. It's almost like 20 to 26% versus 5%. So most of these will present as a asymptomatic nodule, and examination is same as any adult patient: clinical examination, thyroid function test, ultrasonography, and fine needle aspiration cytology. And the problem is with ultrasonography, all those things is whenever you are seeing a high-grade lesion in an adult, we have a size criteria for fine needle aspiration cytology in an adult. But in pediatric, according to ATA, size doesn't matter. If it is high risk, we have to go for a fine needle aspiration cytology, considering the high risk feature in that one. And another thing is, we will be seeing so many thyroiditis patients in southern part of India. But few of the pediatric patients will come with a enlarged thyroid. It's few microcalcification here and there. So the incidence of diffuse sclerotic variant of papillary thyroid carcinoma is higher in this pediatric age group. So in such a diffuse goiter, if you're seeing any microcalcification, you should not miss a fine needle aspiration cytology. So as usual, we will do fine needle aspiration cytology in a young adult and on a adult patient. Everything is similar. Only thing is the malignancy risk is really high in this indeterminate group compared to a adult patient. So if you've done a fine needle aspiration cytology and you are finding a Bethesda 3 or 4 lesion. So in the previous discussion, people are talking about doing, I think Ashish Varghese was telling about doing a FNAC genetics. It really matters in a pediatric case because like whenever you're going to proceed for a surgery in an indeterminate nodule with such a high risk, we have to be more careful about the complications. And so it's always better to have a genetic study if it is possible, because if it is a high risk mutation, more chance of malignancy we have to go to radical. So regarding calcitonin versus no calcitonin, they neither recommend for regans because of sporadic mutations are not that common. So regarding molecular testing, if it is indefinite, category 3, 4, or 5, definitely you have to go for a molecular testing because it will help in doing a more oncological work than doing a half job. So after fine needle aspiration cytology, you have to have a treatment planning because at all pediatric cases or INL should be done by a multidisciplinary team approach only because in these cases, chance of metastasis is more, local metastasis is more, extracardial extension chances more. So what surgery has to be performed? Normally, imaging is the same way around. You have to go for a neck ultrasound if needed, CCT, chest X-ray, and followed by that surgical plan. So there is no role for a near total thyroidectomy, no role for hemi thyroidectomy. In pediatric age group, if there is a suspicion of malignancy, it's always better to go for a total thyroidectomy because considering the possibility for multifocality and metastasis. So the next one is central compartment dissection. We were mentioning about prophylactic dissection and therapeutic dissection. Therapeutic, definitely, whenever you're finding nodes in preoperative setting or intraoperative, you have to go for a therapeutic central compartment dissection. But what about central compartment dissection in prophylactic setting? As I already mentioned, chance of metastasis is more in pediatric thyroid cancers and recurrence rate is more. So you have to be carefully select patients for central compartment dissection. So if it's a unifocal disease, anyway, we'll be performing total thyroidectomy only. If it's a unifocal disease, low risk, there is no visible. One choice is to go for a hemi-CCLND or completed prophylactic bilateral central compartment node dissection in pediatric setting. So end of the day, pediatric cases, initially for diagnosis, more FNACs, no size criteria. Second thing, who you should call as a pediatric patient, less than 20-year-old patients. Then the last, second thing, surgical planning. You have to plan more extensively than an adult patient. And rest of the things are almost similar for an adult and a pediatric case. Thank you.
Thank you for speaking to the time. Any questions?
So one quick one, the 88 document, around the 88 document defines the pediatric age group, and is there any data to show behavioral difference at a certain cutoff age?
So basically regarding this one, if you consider the papers as such, you can consider, few are mentioning 16, 17, but 20 can be taken off as a cutoff. That is a common sample.
I think the recent world now they take it 50.
And more concerning part is like, sir, most of these lesions are asymptomatic. So patient may come to us after the age of 28 also. Difficult disease, they will come at 28 years with metastasis. So age is always a questionable thing in pediatric age group. Because we consider it as a subgroup.
Thank you. The next topic is locally advanced thyroid cancer and request Professor Paul.
Okay, good afternoon, everyone. Maybe everyone will just stand up and sit down for a while because I think we're all on borderline mode of sleep, or just move around in your chair. Sure. So I think this topic, I'll use a little more visuals so we can move, stay awake. So locally invasive disease I've divided into three axes. The central axis, trachea, larynx, esophagus, laryngeal nerves. Then there's the lateral carotid IJV and the lateral nerves. And in the mediastinum, great vessels. I'm not going to focus. Mediastinal great vessel, basically a situation where you have central lymphadenopathy we see sometimes in medullary or in polydifferentiate or variant lymph nodes that go into the brachiocephalic vein. And that can be sorted out by either partial resection or there is get away with it, and we've seen that in one issue. The IJV, I'm not going to deal in detail. I think most of us would have experience with tumor thrombi going to IJV or adherence, and you can just resect it unilaterally without a problem. So I'll focus mainly on the aerodigestive tract invasion. So there is, from data 18 series collated of 10,000 patients, reported about 600 cases of aerodigestive tract. So that's about 6% in a review. So it's low, but it's not that rare, and most of us will come across this. So if it's invasion of aerodigestive tract alone, it's 35%, with metastatic disease 28%. And this is the commonest cause of death in thyroid cancer in these two situations. If we look at what is involved, strap is very common. We just remove the inner strap often. It's not an issue. The recurrent laryngeal nerve is the next at 47%, trachea 37%, the esophagus, larynx, and other sites in lower percentages of involvement. So management principles: one, aggressiveness based on life expectancy. In thyroid cancer, fortunately, except in the anaplastic situation, we know that there is a reasonable life expectancy. And early days, I remember trying to get collaboration of the thoracic team or the neuro team. We had to convince them that even though there may be some lung mets or some other bone mets, this is not, an end situation which is going away in 6 months. So we had to tell them, no, we still need to do the local aggressive surgery because they have long-term living potential. So short-term maintenance of speech, breathing, and swallowing function is very critical, and that must be looked into when we are doing these aggressive surgeries, and a long-term goal of disease control locally. So external beam RT is important here. Ablative options also we have to look at, and consider a neoadjuvant tyrosine kinase, as was talked about it. I think now we've realized we've shifted the whole game now from earlier chemoradiation or chemotherapy, and now tyrosine kinase inhibitors we've seen work very well in this situation. It can convert a fixed mass into a mobile, and it can, a borderline paretic nerve can recover function we've seen post PGES. So that's something which is very useful now. And the decision has to be made in a MDT setting, get as many opinions on board. So this is a famous picture from the Grillo team, Shin staging. So we have basically to say that if you have only superficial involvement, then just a shave is fine. If it is deep into the tracheal wall, then shave plus RT. Query resection depending on the depth. If it's gone submucosal or into the lumen, then resection is the best option. So it's shown that if it's superficial tracheal fascia, shave is equivalent. We don't have to resect, and intraluminal, definitely resection is required. So for the deeper stage 2 in the wall, there is still controversy, and as we saw in the imaging session, it can be difficult to actually see what is the involvement of the tracheal wall on CT. So it's mainly an intraoperative decision that you have to take. So here's an example of a 58-year-old female who had noisy breathing at presentation, and you can see the tumor in the going beyond the tracheal cartilage into the lumen. And so this is clearly intraluminal. That's the intraoperative picture where we've actually done the tracheal resection, and you can see the tumor inside the lumen of the trachea and the ET tube. So here the whole tracheal resection has been done, and then it is sutured close. So this we found actually has very good results. Initially, back in 2007, was the first case that I attempted, and that patient did well. I'll just show you that also. This is an internal view of how it looks, the bulge pre-resection and post-resection, the suture line. This was a case, the first case that we attempted. This lady came with choking and stridor, and we had to go in quite urgently. And so this tube exchange that undergoes on table, I won't go into those details. And then the suturing, we use 2O vicryl with some fixing sutures as well. So the circumferential resection over time, we found we don't take it in terms of tracheal cartilage, but a 4 centimeter length seems to be up to the maximum you can go without too much of mobilization. So this lady actually came with pulmonary mets even at presentation, but because of the local problem, we did this and then gave external beam radiation, and her lung mets after initial iodine ablation responded and then recurred. So 5 years later, she went into a resistant lung met situation, and then we gave her sorafenib. She had it for about a year but couldn't tolerate the side effects, and then this was the lung 5 years later. So but there was no local recurrence in the neck. She died of the lung metastasis, which she couldn't continue with the sorafenib. This is recurrent polydifferentiated CA invading the larynx. You can see that is the tracheal cartilage and the cricoid completely covered by tumor. And the right picture is post-resection, and the pharynx has been closed. And this is an internal view. You can see the tumor where the arrow points is coming into the vocal cord on the left side. And that's just after radiation, so the post-RT effects can be seen. And these patients who come in either with stridor, choking, and quite bad symptoms, I was surprised that she was actually very happy with her result, even though she had an end permanent tracheostomy. And she survived for a long period after this. So even though these are extreme situations, patients come in bad, they still do well and they are happy with results. Even the ones with permanent tracheostomies, we found they're happy. So here is an experience of 22 situations of trachea and laryngeal involvement. So 19 tracheal resections and 3 laryngectomies. Only 2 sternotomies were required. We managed the rest from the neck. The mean length resected was about 2.9 centimeters, maximum of 5. All of them could be closed primarily. So, yeah, I'll move on because of shortage of time. If there's any questions, you can take later. What we do generally is mobilize the trachea from below just through finger dissection into the mediastinum, and superiorly we divide the thyroid muscle, which drops the larynx down, and that will give you up to 4 centimeters easily. One case we did even 5. So this is a rare case of carotid invasion. Next big involvement of carotid, you can see in the CT that the left carotid is completely 360 engulfed and narrowed. But in the coronal section also, you can see the carotid narrowed, but it's still intact. So there's no luminal irregularities, an important thing. This patient was actually seen at another big center. They opened and decided it was inoperable and sent him home. Then he came to us, young boy at the age of 12 years. By the time he reached again, he was already in stridor. So we went in, and this is an example of how carotid can be salvaged. So bilateral complete recurrent nerve encasement. Left side already palsied where the carotid was encased. Right was functional but completely encased. So the left carotid encasement was excised by a subadventitial plane dissection. So we cut the tumor open like a book onto the carotid, open it, get into the subadventitial plane and dissect it around. And usually the carotid can be salvaged. So that's the carotid after resecting that 360 tumor. The left nerve was non-functional, was resected. So we left on the right side, we left residual tumor on the right recurrent laryngeal nerve, and then radiated the patient. So that was now 8 years ago. He's now finished school, finished college, and he's studying to be a chartered accountant with an adequate voice. He's happy. The only thing he's concerned about is the sternotomy scar, which has given him itching sensation. So that's him who came recently, and you can see he permitted me to show this photo because you can see the ptosis on the left where we did the carotid excision. So he's got a Horner's on the left, but otherwise he's doing fine. And Sabha Ratnam was with us at that time, so he actually wrote this paper to describe this encasement. So recurrent laryngeal nerve, I think, is going to be dealt with. So I'll just quickly go through this. These are the 4 situations where direct transection can be resutured. If there's loss of length, use a cable graft. If there's no distal stump available, you can get into the muscle and lateralize the nerve and then anastomose it and use an ipsilateral ansa cervicalis. People have even described using the contralateral ansa and bringing it posterior to the trachea to anastomose. So there are a lot of options. Now, our own experience is an example where we did an ANSA RLN using a loop. Ideally, if you have a microscope, it's better, but usually we manage with a loop. So initially, we were quite thrilled with Miyaguchi's description, but unfortunately, our results were not that good. So our hand surgeons have said we can bring the microscope and do it for you if you need, but so far we've not had to do that. So I use it selectively. This is an example of another extreme case where large tumor with sternal metastasis, and you can see the narrowed airway, everything is completely engulfed. And the MRI shows the main mass, the sternal mass, and also metastasis in the vertebral column, spinal metastasis. So this is one extreme situation where we used both the thoracic and neuro teams. And we could see the RLN on this is the left side. This is post-excision of the entire mass. And that was, she had a dual stage procedure. After we finished the main tumor, the neurosurgeons came in, took out the cervical met from the anterior approach, and we excised the sternal met also with the thoracic team. And they did a second procedure from posterior, where they excised the remaining tumor from the back, but only anterior fixation of the spine was required. Now, she again, this is 6 years after surgery on a permanent track. We couldn't get her track off, but again, she's very happy. She just closes it and speaks. And unfortunately, after 6 years, developed brain metastasis and has had stereotactic radiation for that. Following that, they haven't had follow-up. This is probably the largest tumor we had. Can you guess what pathology this might be? This is actually a papillary cancer thyroid, just very large. So this is, he just sat on it, as usual, tried homeopathy, tried Ayurvedic, waited, and finally came with this massive tumor. And here's one instance where we use a preoperative embolization to try and reduce the vascularity. Initial operation was done by Dr. Arun and Dr. Ben when I was away in 2006. And then I came back, did 2 reoperations of skin metastasis and axillary lymph nodes as well. But this is him 8 years after surgery, again with a permanent track and a smile on his face. He's so happy even now. He can manage his life himself. So it's amazing how these locally advanced tumors can still have very reasonable quality of life. Adjuvant external beam radiation to the neck has been used a lot now in our center. It should be considered when there's high risk of local recurrence, micro or macro residual disease, extrathyroidal extension. So this is, you need to have an